Hello, good morning, everyone, and welcome to this 2021 session of the Best of AASLD, which is an activity which is started by Dr. Sareen and Dr. Amrapurkar, and now it is being continued by Professor Sareen in the memory of Dr. Amrapurkar. Every year we try to get you the best of the papers presented at the AASLD because many of us have not been able to travel, and especially with COVID restrictions. Thank you all for being here with us in such large numbers. And let me now introduce the man behind this whole activity, Dr. Sareen. Dr. Sareen, as you know, founded the ILBS, which has become a premier institute of hepatology in the world. He was also the chairman of the MCI when it was in troubled waters, and he set the whole thing right. And now I think he's going to do the same to the national board. And sir has been given the Padma Bhushan for all his exemplary activities. There's not a single area in hepatology which has not been influenced by his research. And in short, I was very lucky to have him as my teacher in my GB Pant days when I was doing my DM. So I can describe in short a great researcher, academician, clinician, and an excellent human being. Sir, may I invite you to just give a few words of introduction to this meeting.
Thank you, Vinay, and welcome to one and all. It's a pleasure to have Vinay steer the boat. Deepak was dear to all of us, and I still can see him sitting next to me, planning and speaking, and the charged man. So, in his memory, this is the only meeting I single-handedly try and do. And I want to thank his sister Manisha and Science First, who have done a great job in putting things together. We have 15 faculty, 12 international from the US. That includes the president-elect of AASLD, past president of AASLD, and amongst the best of the brains, Indians and overseas who are there. We have 20 sessions in this and 2 orations. And one man who I revere is Dr. Jim Boyer, who had been at the Yale. He must be close to 85, 90, but the youngest mind, and he has agreed to give his biopic. So I really feel this meeting is blessed by Jim's participation. Many of you may know he started with the idiopathic portal hypertension terminology, but we'll come to it. In addition, we have best of AASLD coming in, means the Indians who were there or would have been there at AASLD would all be presenting. I feel it is a very intense meeting. There may be no breaks, but you can have your cup of coffee and mug of green tea with you all the time. And I think you will give us a feedback on our omissions or kind of planning, if at all, for future. With that, and also with thanks to Science First, and who is getting supported by Reddy's Lab. Many thanks, and over to Vinay for spearheading and guiding us for next 2 days. Thank you and welcome.
Thank you, sir, and welcome to all the delegates and especially the moderators for this session. Dr. Sujit Chaudhary from Emory is the head of the department there, and he's based in Kolkata. Then Dr. N. Arun, who is the consultant gastroenterologist at Apollo, and of course Sunil Darich, who is the senior professor and head of the department at Jodhpur. So welcome the moderators, and I think we have the first talk by Professor Bernard Schnabel. He's not going to be live with us, unfortunately, today to answer your questions. But as you see, he's an associate professor at the University of San Diego, University of California at San Diego. And his work on dysbiosis in chronic liver disease has some exceptional, it has been exceptionally noted. So let's hear from Dr. Schnabel as what is new in this area of liver disease.
Hello, I would like to thank the organizers of the Hot Topics at AASLD 2021 and especially Dr. Sarin for inviting me to talk about gut-liver axis and FMT. I'm Bernd Schnabel. I'm a professor of medicine at the University of California in San Diego, and I'm also the director of the San Diego Digestive Diseases Research Center. These are my disclosures. In the following, I would like to present you some abstracts presented at the AASLD 2021. The first one is entitled Probiotic Lactobacillus rhamnosus GG derived exosome-like nanoparticles protect against alcohol-associated liver disease through regulation of the intestinal miR-194 FXR FGF15 mediated bile acid synthesis pathway in mice. And this abstract was presented by Dr. Chiang in the basic and translational plenary session. This is a basic abstract. So lactobacillus treatment is known to potentiate intestinal hypoxia-inducible factor. It promotes intestinal integrity and ameliorates alcohol-induced liver injury. We know that LGG culture supernatant without viable probiotic bacteria is very effective in preventing experimental alcohol-induced liver disease in rodents. And we are going to hear today about the exosome-like nanoparticles from Lactobacillus rhamnosus GG also protect against alcohol-associated liver disease. You can see in this slide that Lactobacillus rhamnosus GG produces these exosome-like nanoparticles in different sizes. When mice are being gavaged with these nanoparticles, you can localize these nanoparticles abundantly in the intestinal villi, in the lamina propria of the ileum, in the mesenteric adipose tissue, but also in the liver, although here it's very rare. To determine whether these lactobacillus-derived nanoparticles affect and modulate ethanol-induced liver disease in mice, the authors used the NIAAA model, binge on chronic alcohol exposure. Lactobacillus-derived nanoparticles were administered to the mice in the last 3 days of the 10-day course of alcohol exposure. As you can see here, liver bile acids are significantly increased after ethanol feeding, and this was ameliorated with administration of these lactobacillus-derived nanoparticles. In addition, nanoparticle treatment reversed alcohol-induced fatty liver disease and liver injury. To determine the mechanisms behind this suppression of the liver bile acids, the authors looked at the intestinal and especially ileal FXR axis, serum FGF15, and then bile acid synthesis in the liver. The authors initially looked at the miRNA 194 expression in the ileum, which is increased after ethanol feeding and suppressed when nanoparticles were given to ethanol-fed animals. Alcohol decreased the intestinal FXR mRNA expression and also subsequently FGF15 levels in the serum, and this was prevented by the administration of these nanoparticles. In addition, the authors also showed that the alcohol elevated miRNA expression in the enteroids suppressed FXR expression. Finally, the authors also used a luciferase reporter assay of FXR activities in fecal extracts and serum, and the authors showed that alcohol decreased this FXR activity in the fecal extracts but also in the serum, and this was inhibited by treatment with the nanoparticles. To further define and show that this beneficial effect of the nanoparticles is dependent on FXR in the intestinal epithelial cells and on the serum FGF15 levels, the authors used mice that have a tissue-specific FXR deficiency in intestinal epithelial cells, and when they administered nanoparticles in alcohol-fed mice that lacked FXR activity in the intestinal epithelial cells, you can see here that this beneficial effect of the nanoparticles is abolished. There was no any longer liver injury improvement, and liver bile acids were also not suppressed after chronic alcohol feeding in the presence of these nanoparticles. Similarly, in FGF knockout mice, the authors also showed that this beneficial effect of the nanoparticles was completely dependent on FGF15 expression in the mice. This is their final cartoon, what the authors are suggesting. So after alcohol, you get a intestinal dysbiosis with an increase of miRNA expression. This leads to a decrease in FXR activity in intestinal epithelial cells, which leads to lower FGF15 in mice and possibly 19 in humans. This inhibits usually the bile acid synthesis in the liver. However, if FGF15 is lower, there's a increased bile acid synthesis and possibly lipogenesis, which leads to alcohol-induced liver disease. Nanoparticles now can suppress the increase in miRNA. FXR activity is increased, FGF15 is increased. That leads to a suppression of the bile acid synthesis and a decrease in lipogenesis and improvement of alcohol-associated liver disease. So this is a very elegant study showing that these lactobacillus-derived nanoparticles can indeed affect alcohol-associated liver disease via modulating the intestinal FXR, FGF15, and then the hepatic bile acid synthesis axis. I would like to continue now with probiotics. I would like to present you another abstract that was presented as an oral presentation in the Clinical Advances in Alcohol-Associated Liver Disease. The abstract is entitled Efficacy of 6-Month Lactobacillus Therapy in Reducing Heavy Drinking Among Heavy Drinkers Diagnosed with Moderate Alcohol-Associated Hepatitis. The first author is Dr. Vatsalya, last author is Dr. McLean. So in this case, the authors included 38 patients with alcohol use disorder and moderate alcoholic hepatitis with a MEL lower than 19. Age was 21 to 67 years. 21 patients were treated with Lactobacillus rhamnosus, or they had in the placebo group plus standard of care 17 patients included. The authors collected data on demographics, drinking, and liver injury at baseline 1, 3, and 6 months for the Lactobacillus rhamnosus efficacy, and they tested whether alcohol consumption is reduced. And this was determined by baseline audit, and the authors also gave the study participants monthly alcohol questionnaires. Coming to the results, patients treated with LGG showed a significant reduction in drinking to the social abstinence level of less than 4 drinks per week at the 6-month assessment compared to the patients treated with placebo. LGG after 6 months and placebo after 6 months. There was also a significant drop at the 6th month assessment for average drinks per week in the LGG arm compared to the placebo arm. In addition, lowering of alcohol consumptions over 6 months in both the groups for average drinking per week was significant, with higher significance in the LGG group, which is likely that the counseling, which is part of the standard of care, is a contributing factor to the reduction in alcohol intake in the placebo arm. In addition, as you can see in these graphs, there was a drop in the MELD score that was statistically significant in the LGG arm at least at 1 month and at 6 months, but that was not seen in the placebo arm at 1 month and after 6 months. In addition, there was also a drop in the AST to ALT ratio in the LGG arm that was significant compared to the placebo arm. The 7-day ABIC score also dropped significantly from baseline, only in the LGG arm, but not in the placebo arm. In addition, the authors did modeling, and the outcome prediction in the LGG group by lowering of the MELD lower than 12 was predicted by the baseline ABIC score. So in summary, 6 months of LGG treatment reduced heavy drinking levels to the social drinking or abstinence levels. I think these are very exciting results. Counseling therapy in patients, particularly in the placebo-treated patients with AUD, seems to provide some benefit in reducing drinking levels. LGG treatment showed a significant reduction of some biomarkers of liver injury progression and severity, and results are obviously warrant a larger, well-designed, rigorous treatment trial clinical study, which the authors are presently pursuing. The next basic science abstract that was presented orally in the Experimental and Translational Advances in Alcohol-Associated Liver Disease by Dr. Laurenti, who is an assistant professor in my laboratory. This abstract was entitled IL-6 signal transducer, which is also commonly known under GP130, induced muscarinic receptor opens goblet cell-associated antigen passages to suppress alcoholic liver disease. Here you can see a cartoon of the intestine, on top the intestinal lumen, intestinal epithelial cells, and lamina propria. In the middle you have one goblet cell. Recently it was appreciated that goblet cells can form so-called goblet cell-associated antigen passages, so-called gaps, and they can deliver luminal substances to the underlying lamina propria antigen-presenting cells in a manner capable of inducing adaptive immune responses. Upon mucin secretion, despite this mucus fence, in response to acetylcholine, in this case acting on this muscarinic acetylcholine receptor 4, goblet cells now can form so-called goblet cell-associated antigen passages, and these luminal antigens can now be presented to the antigen-presenting dendritic cells in the lamina propria, which then can induce an intestinal tolerogenic response. We have shown in patients with alcohol use disorder that mucus-producing goblet cells are increased as compared to the control patients, and these are duodenal biopsies. Furthermore, we show the same evidence in mice that were chronically fed alcohol. In this case, mucin 2 is increased, goblet cells are increased, and most importantly, these goblet cell-associated antigen passages are decreased despite having more goblet cells and despite having more MAC2. Similarly, this muscarinic acetylcholine receptor 4 mRNA expression in the mouse intestine is also reduced, so suggesting that possibly through a reduction of this acetylcholine receptor 4, you get a significant reduction in these goblet cell-associated passages. We used a genetic mouse model, in this case a transgenic mouse that overproduces GP130 or the IL-6 signal transducer, specifically in the intestinal epithelial cells. In the wild-type mice, after ethanol feeding, you get a significant increase in liver disease, and this is ameliorated in the transgenic mice, shown here by liver injury and hepatic triglycerides. Now, interestingly, in these transgenic mice overexpressing GP130 in the intestinal epithelial cells, we have now a significant increase in the GAPs. We have a significant increase in the acetylcholine receptor 4, and however, we see a decrease in the MAC2 production and less goblet cells. To show you that there is a tolerogenic adaptive immune response ongoing in the intestinal epithelial cells, and especially in the lamina propria immune cells, you can see here that IL-22 production is, as we have also described before, reduced after chronic ethanol feeding, but this is completely restored in these transgenic mice overexpressing GP130 in the intestinal epithelial cells. Antimicrobial molecules are also significantly increased in these GP130 transgenic mice. Based on these findings, we were wondering whether we can use a pharmacological manipulation of these GAPs to alleviate ethanol-induced liver disease. So we used a M4 agonist that induced GAPs after treatment with ethanol and with this VU drug, as you can see here. In the presence of this M4 mimetic, we get a significant decrease in liver injury and in liver triglycerides. Furthermore, you can see that the tolerogenic immune response in the intestine is induced. We get more REC3B and REC3G expression, which are antimicrobial molecule expressions, and we can decrease bacterial translocation. So this brings me to my summary slide. What I have at least partly shown you today is that ethanol, and not shown today, but also we can use inhibitors of this M4 receptor. This inhibits the gap formation. We get less immunotolerance in the lamina propria cells. We get less IL-22 production, less antimicrobial molecule expression, and this increases bacterial translocation and promotes liver disease. On the other hand, we have shown you, or I have shown you today, that we can use either an approach by using GP130 transgenic overexpression in intestinal epithelial cells, or an M4 mimetic that induces the M4 expression, induces gap formation, induces an immune tolerant state in dendritic cells, stimulates IL-22 production by ILC3s in the lamina propria to induce antimicrobial molecule expression, inhibit bacterial translocation, and improve alcohol-associated liver disease. The next abstract that I would like to present to you is also a basic science abstract and translational study. This was presented at the basic and translational plenary session. Is entitled by Reduction in Alcohol Preference and Intake is Transmitted Through Colonization of Germ-Free Mice with Stools from AOD Patients that Received Fecal Microbiota Transplantation, presented by Dr. Wolstenholme, and is part of Dr. Bashar's research group. So what Dr. Bashar showed previously and has published in Hepatology in a phase 1 double-blind randomized clinical trial, he showed that FMT from a donor enriched in beneficial Lachnospiraceae and Ruminococci into patients with alcohol-related cirrhosis significantly reduced craving and alcohol intake compared to pre-treatment with favorable microbial and cognitive changes. The objective of this basic science study was to determine if this drinking behavior improvement in humans after FMT could be transmitted also to mice, and also to determine microbial tax associated with these changes. So what Dr. Bashar's group did, they used stools from humans pre and post FMT and transplanted this stool into germ-free mice, and then they tested their drinking behavior by using a 2-bottle choice ethanol drinking assay. their main finding is shown over here, that there was a reduction in total and binge alcohol intake in mice that were colonized with post-FMT stools versus pre-FMT stools, and that was likely linked with ruminococci and a higher microbial diversity. So this suggests that FMT may be a promising therapy for reducing alcohol intake and craving, and transfer of microbiota rich in ruminococci are associated with lower intake and preference for alcohol in germ-free mice. So very elegant translational study. After having shown you a basic translational research approach using FMT, I would like to present you this very exciting abstract that was presented by Dr. Phillips in the Clinical Presidential Plenary Session, entitled 3-Year Follow-up of Alcohol-Related Hepatitis Patients Undergoing Healthy Donor Fecal Transplant, Analysis of Clinical Outcomes, Relapse, Gut Microbiota, and Comparisons with Standard of Care. The authors have previously shown that healthy donor fecal transplant shows clinical benefits in alcoholic hepatitis, but also other liver diseases, long-term outcomes, and the gut microbiota changes in severe alcoholic hepatitis after FMTs are known. And that was the goal of this abstract, to follow up these long-term changes. The authors included severe alcoholic hepatitis patients that underwent FMT. These were 35 patients in the FMT group. They received FMT daily for 7 days via a nasoduodenal tube, or as a comparison standard of care. In the standard of care, they had NS26, and the study was from May 2017 to June 2018. The two groups were very well matched for age, Child-Pugh MADRS score, portal hypertension, infection episodes at admission. FMT had significantly higher hyperbilirubinemia, as you can see here, and also CLIF-C scores at baseline. Other parameters are not significantly different, as you can see here: ascites, hepatic encephalopathy, infections, acute injury, or SCLF grades. On follow-up, as you can see here in this table, the incidence of ascites, hepatic encephalopathy, need for critical care, non-critical infections, and critical infections, they were all significantly higher in the standard of care as compared with the FMT group. Alcohol relapse was lower, and time to relapse was higher in the FMT group. The proportion with relapse developing recurrent severe alcoholic hepatitis was not significant between the two groups, as shown here. Most importantly, the survival and the long-term outcome. At 3 years, there was a trend towards improved survival noted in the FMT group as compared to the standard of care group, although this was not significantly different. But overall, the authors also did a gut microbiota analysis between groups at year 1 and 2 and at year 2 to 3, and they showed remarkable changes in the phyla in the FMT groups, while there was not dominant changes in the standard of care group. High-dimensional biomarker discovery revealed significant increases in some of the bacteria in the standard of care group compared with the FMT group. at 1 to 2 years, while we had an enrichment of actinobacteria, bifidobacteriaceae and bifidobacterium in the FMT group compared with the standard of care group. So there seems to be a long-lasting effect of the FMT even after 2 to 3 years. So in summary, this very exciting abstract shows healthy donor FMT treated patients with severe alcoholic hepatitis experienced significantly less hepatic encephalopathy, critical infections, hospitalization, and alcohol relapse, with trend towards improved survival compared with the standard of care group. Clinically relevant outcomes were associated with beneficial gut microbiota modulation in the FMT group. Obviously, larger controlled studies on FMT in patients with alcoholic hepatitis are needed and are apparently already ongoing in this group. I would like to continue with FMT in patients with severe alcoholic hepatitis. This is a very elegant abstract and study presented in the parallel gut-liver axis and microbiome session. It is entitled Fecal Microbial Transplant Suppresses Hepatic and Systemic Inflammatory Responses and Gut Leakiness in Severe Alcoholic Hepatitis Patients. This abstract was presented by Dr. Bavella and is coming from Dr. Sarin's group. It will explain, and I will show you the results in the next several slides. It will explain some of these beneficial effects that I have just showed you in the previous abstract. As I have mentioned before, fecal microbiota transplantation shows initial promise in severe alcoholic hepatitis patients. The potential cellular and molecular mechanisms are unclear. Dr. Sarin's group investigated alterations in immune cell subsets, their functions in their association with gut permeability before and after FMT in these patients with severe alcohol-associated hepatitis. The authors included 27 patients with severe alcoholic hepatitis. They were histologically diagnosed and they were undergoing FMT given through a nasoduodenal tube for 7 days. These patients were studied pre and post FMT. High dimensional immune profiling for monocytes, as you can see here on the left side, neutrophils, Th1, Th2, Th17, and these mucosal associated invariant T cells are also called mite cells, T regulatory cells and B cell subsets. Intracellular cytokines in the peripheral blood were studied by flow cytometry. In addition, duodenal biopsies were obtained pre and post FMT to study intestinal permeability, including sonula occludens 1, so SO1, and claudin 1 expression. In addition, liver biopsies were studied for intrahepatic mite presence. Genes associated with inflammation, mucosal immunity, and permeability were analyzed by qPCR. These are the results. Very interestingly, the authors saw post-FMT that there were elevated levels of circulating CD8 positive mite cells post-FMT. There were lower levels of IL-17A production from the mite cells post-FMT, and this altered activation of mite cells post-FMT was demonstrated by showing these activation markers, not shown here, but they've shown it in their presentation, by the activation markers of CD25 positive and CD69 positive. These were low on the mite cells. Switching over to the liver biopsies, the intrahepatic mite cells were significantly reduced post-FMT at day 28. And finally, intestinal barrier function also improved as the expression of tight junctions proteins such as SO1 and Claudin-1 were increased. These are the key takeaways from this very exciting abstract. Circulating CD8 mite cells are severely depleted in patients with severe alcoholic hepatitis, and they show an elevation after FMT. The activation markers of mite cells declined by 50%, with decrease in pro-inflammatory activity of mite cells. And then the after 1 month of FMT, intrahepatic mite cells decreased and gut permeability is reversed. So overall, this shows, as we have seen by the previous abstract, improvement in severe alcoholic hepatitis patients post-FMT by day 28. Mite cells may aid in antimicrobial activity in the circulation and increases the overall mortality. Finally, and this is my last abstract that I would like to present to you today, the abstract is entitled Acute Alcohol Consumptions Increases Translocation of the Gut Microbiota into the Circulation in Individuals with Early Alcohol-Associated Liver Disease. This abstract was presented during the parallel gut liver axis and microbiome session by Mats Israelsen, and he is in the group of Alexander Krag. So what the authors did here, and their aim was to study the effect of acute alcohol consumption on gut leakiness in early stages of fatty liver disease. They used 40 biopsy-proven alcoholic liver disease patients, 15 biopsy-proven non-alcoholic fatty liver disease patients, and 10 healthy controls. All of them were in not a decompensated cirrhosis, so none of these patients had a decompensated cirrhosis. They all received 2.5 milliliter of 40% ethanol per gram body weight infused over 30 minutes via nasogastric tube. And then the authors took serial blood samples. Hepatic and systemic venous blood was sampled simultaneously at 9 time points within the 4 hours. So they end up with a very large number of samples, 702. And then the authors did, in these blood samples, detected bacterial DNA by qPCR, and they also did ribosomal sequencing. These are the results. At baseline, so before the alcohol intervention, there was no significant difference at the phylum level, not shown here, when comparing the blood microbial community composition of the hepatic phenotype and blood compartment. However, after alcohol consumption, this led to a rapid increase. You can see this here within 90 minutes of bacterial DNA, especially in alcoholic liver disease patients. And this was not the case in the control patients, healthy controls, and also not the case in the patients with non-alcoholic fatty liver disease. So their conclusion was that acute alcohol consumption seems to increase translocation of the gut microbiota into the circulation, and this happens mainly in individuals, and in particularly, and this is the interesting aspect of this study, even during early alcohol-associated liver disease. This suggests that alteration in the gut-liver axis manifests prior to hepatic decompensation in alcoholic liver disease, and this could be therefore a potential target for treatment of early alcoholic liver disease. Again, I would like to thank the organizers and Dr. Sarin for inviting me to present these highlights from the gut-liver axis in FMT. I hope you have enjoyed the few abstracts that I have been able to present to you today. There would have been many more, but the time was limited and could not present other certainly very outstanding abstract. I will hope that you will enjoy the rest of this meeting. Have a good day or evening today. Thank you and bye-bye.
Thanks to Professor Stavel, but he's not able to join us live. So I think the moderators for the session can give their comments. Plus, there are a few questions in the chat box. If you look at the chat box, over to the moderators of this session. We have 5 minutes. So I hope we stick to the time.
Really a great and excellent. The field is so much growing in the field of hepatology that alcohol-induced liver disease, and along with that, not only for that, the fecal microbiota transplant, along with that gut microbiota, this being taken as a separate entity. And moreover, there are so much of new innovations is being happening, and so much of trials are being happening. And I think one of the best of talk what you've been listening to, but so thank you, sir.
So any more comments, any comments from the other moderators? Because there are some questions in the chat box. Is that Dr. Setuba was asking that therapy is now lifeline microbiome or fecobiome, which is specific to each disease. So where are we on that? Is it available or is it experimental?
So ideally, microbiota is one of the most important things. So fecal micro, rather than considering as my fecobiome, therapy now with focusing on more of a Leofilus microbiome, because as we all know, the transmissibility of that ethanol-induced liver disease mainly by gut bacterial dislocation and all those, mainly by a leaky gut dysfunction. So what is going to happen? So we need to prevent the transmission of all the viable bacteria and microbial products which is going to develop in the liver, and which is going to promote your inflammatory pathways, and which is going to promote your hepatocyte death and fibrotic, which changes is going to get activated. All those things has to get prevented mainly by a microbiota alteration rather than by considering only by fecobiome. So that is what my personal opinion is. That's it.
I think we are fortunate to have Dr. Sareen here on this talk also. Sir, you have a lot of original research work starting from a very basic level. So where do we stand now with these therapies? Are they ready to come on to the clinical arena, or still there is time?
Thanks. We started this about 8 years ago, 2013. Have more than 300 patients. Basic science is coming. It decreases the inflammation, leakiness of the gut. Also, bile acid levels go down. The better part of it, patient starts feeling well in about 2 to 3 days time. Avoid it in patients who have got SBP in the past or have ascites. Other than that, if you have patients, it's up to a MELD of about 25 to 30, it is reasonable. A recent study after Philip was by Apurva, which is under review, and 3 more DM theses are on. We are not ready for prime time. We are still far away from this, but I think it's a very, very promising therapy.
Sir, I want to ask one query, that how this FMT is altering the behavior of the drinking behavior, whether it is directly due to the inflammation reduction or if there is some CNS effect, because these patients are the improved, then the drinking behavior is altered and reduced. So what is the mechanisms?
It modulates the blood-brain barrier and tryptophan metabolism to a large extent, and I think Jess has shown this. And Rumani Kokisei is a good product, but we still have a long way to go.
And sir, what is so specific about this Rhamnosus GG, lactobacillus rhamnosus?
It's not specific. Alcohol actually reduces it, and this is the one on lactobacilli increase. So if you take desi ghee, the proliferation of lactobacilli goes by about 20 times. Similarly, if you have alcohol, it goes down. And this is your main bacteria, which is the facultative bacteria, which extracts the energy from your food. But now the new studies which will be coming are the biopsy-based studies. Which of these bacteria hang on to the mucosa? But I would encourage people to read more and leave it to Vinay because we're running out of time, I guess.
Yes, thank you all the moderators for being here on this session. We are short of time, so we have to move on to the next session. Thank you, Dr. Sareen sir, for your comments. So now we close this session and move on to the next session. The next talk will be on the dreaded complication of liver disease, which is, of course, kidney injury. And Dr. Raki Maiwal is going to give that talk. She works at the ILBS with Dr. Sareen, and she has a special interest in renal dysfunction. A very avid researcher, a great clinician. So over to you, Dr. Maiwal. And for this session, we have the moderators, Dr. Shiva Prasad, who is a senior consultant and a good friend who's based in Visakhapatnam, and Dr. Y. Nagarjuna, who's the chief of gastro at SUM Hospital. So I welcome the moderators for this session.
Yeah, good morning. Thanks everybody for this opportunity. Though, of course, I think all of us would have preferred it live, and I was really looking forward to what would have been probably the first live meeting since the onset of COVID. But we have to accept that, COVID sets the agenda and whatever we may be thinking of. So as already mentioned, this is an important topic. And as we know, in the last few years, there's been a lot of change in terms of the definitions of HRS and again, in terms of the setting of cirrhosis and with, the thresholds for treatment probably coming down, which also raises new questions also. So we'd really be curious to know what's happening at AASLD as far as this field is concerned. And as Vinay said, Raki is the best person to tell us. Over to you, Dr. Raki. Can you please start your presentation?
Yeah. A very good afternoon, and I would like to thank Professor Sareen for giving me an opportunity to discuss the best abstracts presented this year in AASLD with the topic of acute kidney injury in liver diseases. I have no disclosures and no conflict of interest. So what I'll do here in the next 30 minutes is take up some abstracts. First, dealing with HRS-AKI and the management and prognostication, the spectrum of kidney dysfunction, biomarkers, and then acute on kidney injury in context of acute on chronic liver failure. So this is the first abstract on hepatorenal syndrome and acute kidney injury done by Professor Sanyal. The basis of this work was that prior studies had shown that the liver disease severity is a determinant of poor outcomes in patients with HRS. So they wanted to explore whether HRS-AKI is determined and the response in a real-world setting is based on the disease severity. And now this was a retrospective chart review of all adult patients hospitalized at 11 tertiary care centers, and the data was collected from 2016 to 2019. The primary outcome was HRS response, which was defined as complete, partial, or no response based on the degree of decrease in the serum creatinine below 1.5 and more than 30% as partial and no decline by 30% as no response. And further, they classified these patients based on the standard presentation and a severe presentation. So severe presentation patients had either a baseline serum creatinine of more than 5 or they had an ACLF grade 2 more than 2 or a MEL score above 35, and the remaining had a standard presentation. So 132 patients, 65 in the standard and the 67 in the severe group were compared here, and we can see here that the demographics, the ethnicity was not different, but the alcoholic hepatitis was more often seen in the severe group, and GI bleeding as the cause of AKI was seen more often in the severe group of patients, as was advanced hepatic encephalopathy. The MEL score, serum creatinine, ACLF grades, because these were the defining criteria, were significantly different in the severe group as compared to the standard group. But the initial vasopressor therapies that was provided to these patients included midodrine octreotide, which was seen in almost 89% and 82% in the standard and severe group, followed by norepinephrine. The median duration of initial therapy was not different, and more than 99% of these patients had received concomitant albumin. Now, if you see here the bar diagram, and the purple bars indicate the complete response and the green bars the partial response, and this is the stratification based on the standard versus a severe presentation, and we can see here that there was no significant difference. The standard presentation patients rather had worse response, both complete and partial, lower than even the severe presentation group. And the standard presentation group patients, and even in the overall population, we can see here that the response rates were extremely low. So below 20% with octreotide and midodrine. And the severe group had a worse survival as was expected than this standard group. So the two important the results suggested from this paper that the disease severity and the vasopressor therapy was not related, and the overall response rate was extremely low with the octreotide midodrine combination that was used in majority of these patients in the United States. Now, this is another study, and this is done in the United Kingdom. Again, a retrospective analysis, and herein they were planning to assess these patients of HRS-AKI and the response rates to terlipressin based on stratification on serum creatinine. And this was a retrospective chart review from January 2013 to December 2017, and they recorded all the baseline characteristics of the patients, stratified these patients based on the serum creatinine above or below 5 milligram per DL, and a total of 203 patients were enrolled of HRS-AKI, and 89%, almost 90% had serum creatinine less than 5, and a small proportion had a serum creatinine more than 5. And as is expected, a complete response was much higher in the patients who had low serum creatinine as against the higher group. And the incidence of adverse effects, particularly fluid overload, pulmonary edema, and multi-organ failure, were all noted in almost a third of population who was in the sicker group of patients, that is a serum creatinine. So there was a poor response and more adverse effects, and the survival was extremely poor for this group of patients. So these findings highlight a significant and unmet need of alternative therapies for a particularly sicker group of HRS-AKI patients, because these do not respond, and on the other hand, they also develop side effects. So what can be done for such patients? And this is an important paper, an oral paper, which was presented from our institute by Dr. Vinod, and this looked at a protocol of very low terlipressin given as a combination of norepinephrine in the treatment of patients with cirrhosis and HRS-AKI. Now, basically, we know that continuous infusion of terlipressin is now more popular because it is more effective. The maximum daily dose of terlipressin is reduced, and the response is higher. The side effects are lower as compared to the bolus group. But if you look closely to the terlipressin infusion group, again, almost 35 to 40% still develop side effects, and 20% of these patients also have severe adverse events. Now, this is the data, a randomized controlled trial in context of a severe group of patients, acute and chronic liver failure, which is defined according to the AASLD criteria. And in this randomized controlled trial, we showed that terlipressin given as a continuous infusion was superior to norepinephrine in achieving reversal of HRS-AKI. However, the adverse effects were significantly higher, even with a continuous infusion of terlipressin requiring more drug discontinuation. So we need to have the reversal of HRS-AKI and also achieve a lesser incidence of adverse effects. So this was a protocol that was designed and conducted in a retrospective analysis. HRS-AKI, cirrhosis, and AKI progression and regression was defined according to the International Club of Ascites criteria. The primary outcome of this paper was reversal of HRS-AKI day 14, and secondary outcomes were predictors of early response, 28-day survival, and adverse events. Now, if you look at the study protocol, patients with stage 2 and 3 AKI who were non-responsive to the initial volume expansion at the end of 48 hours did get a continuous infusion of terlipressin if they met criteria for HRS-AKI. Now, in this set of patients, there were two groups, one who was intolerant or developed adverse effects, and the other was patients who were non-responders or who developed progressive AKI. So both these groups were actually treated with the NORT protocol, and this protocol included providing a continuous infusion of norepinephrine initiated at 0.5 mg, which was doubled every 4 hours to aim a target of MAP of at least a 10 millimeter elevation, and a maximum dosage of 3 milligram per hour of norepinephrine was provided. In patients who were either intolerant or progressive or had AKI progression on terlipressin infusion were given boluses of terlipressin, 0.5 mg boluses twice or once a day if they developed adverse events. And the response was graded as a partial, complete, or no response, and reversal of HRS-AKI was defined at day 14. Now, a total of 760 patients, of which 160 met the criteria for HRS-AKI, And these patients were managed with a continuous infusion of terlipressin, of which 60% of these patients were responders and they were excluded, while the remaining 39% who were intolerant and the 52% who had AKI progression were included in the NORTI protocol. So a total of 33 patients, these were middle-aged males majority, and 40% of these patients were alcohol-related. And most of these patients had stage 2 or 3 AKI. Serum creatinine at admission, we can see here 1.71. At the start of terlipressin infusion also was 1.79, but at the enrollment for the NORTI protocol was much higher, 2.68, low mean arterial pressure. Most of these patients were child C with a high MEL score. But let's look at the response rates of HRS-AKI. At day 4, 42% of these patients had responded, which increased to 58% at day 7, and at day 14, 70% had responded. And only 15% of these patients went on to requirement of dialysis, with a median time to around a week after the initiation of the NORTI protocol. And when the predictors were identified, only the NORTI protocol and the baseline disease severity were associated with the response to the reversal of HRS-AKI. So it was concluded that supplementing terlipressin with norepinephrine infusion helps in the resolution of AKI. The adverse effects were much reduced. The response rates were very high. 70% patients had responded. And considering the sick group of patients, like was included in this particular study, and the survival advantage, this definitely merits a randomized controlled trial to look at whether when we offer this therapy in a randomized controlled trial, we get a similar benefit. Now, coming to the next part is the spectrum of kidney dysfunction. And this is the work from Peregrine's group, and the work was presented by Dr. Laura. And we know about when we see patients with liver disease, the renal dysfunction can either be in the form of acute kidney injury, it can be a subacute renal dysfunction or acute kidney disease, or a chronic kidney disease. Now, acute kidney injury, the time frame is 48 hours or 50% elevation in the 7 days duration, or a decrease in urine output in the 6 hours time. But what is acute kidney disease? Acute kidney disease is a subacute form of renal dysfunction where the patient has GFR reduction below 60, but is less than 3 months. The structural kidney damage is also not meeting the CKD criteria. And there is a decrease in GFR by 35%, but it is not meeting the AKI criteria. So this is acute kidney disease. Chronic kidney disease is abnormalities in structure or function, which is persisting for more than 90 days. And we have multiple prospective studies now, which indicate how AKI can progress to chronic kidney disease. And almost 1 in 3 cirrhotics develops acute kidney injury transitioning to chronic kidney disease. But what about patients with acute decompensation or acute and chronic liver failure? This is a sick group of patients. So the authors here investigated the patterns of kidney dysfunction. They did a prospective study which included almost 518 patients. All these patients had acute decompensation, but 232 patients did not have ACLF, while 407 patients without ACLF were included. The urine samples were analyzed for urine biomarkers. These patients were followed at admission during hospitalization and followed up for a period of 3 months. And the interesting part over here was that acute kidney injury was frequently seen in patients with acute and chronic liver failure, even though majority of these patients did not have underlying chronic kidney disease, and AKI and CKD was seen in just 22% of these patients. The frequency of CKD alone was low and similar in between the groups, wherein the patient had ACLF and no kidney dysfunction. AKI and ACLF was associated with poor kidney and patient outcomes, and independent predictors of poor 3-month survival included a high MEL score, the ACLF grade, and the higher levels of urine NGAL. Now, these are the Kaplan-Meier survival curves, which show that patients with no AKI and no ACLF had the best survival, while patients with AKI and ACLF both were having the worst outcomes. In the set of patients who had either AKI, these patients did better as compared to patients who had ACLF and no AKI. So when they compared again the group of patients who had AKI without ACLF versus AKI with ACLF, it was seen that both the severity and the phenotype of AKI was significantly different between the two groups. That is, patients who had AKI and ACLF, they have more severe AKI, and they had a majority of patients who had ATN, HRS, or miscellaneous forms of AKI, while the patients who had no ACLF, they more often had hypovolemia-related AKI. So the results of the study suggest that AKI without ACLF has a very good prognosis. Most of it is volume-related, hypovolemic, and responds to volume resuscitation. The best predictors include the severity of liver disease, ACLF status, and the urine NGAL, that is a degree of tubular dysfunction. And these factors could be helpful for guiding the clinical decisions. Again, we need to manage these patients differently to improve their overall outcomes. Now, coming to the next part is about the kidney after liver versus a simultaneous liver kidney transplant. And we know that in a simultaneous liver kidney transplant is better with respect to the graft and patient survival, because the liver provides an immunological advantage to the kidney graft, and the HLA-1 and the HLA-2 antigens are produced in the liver. The alloantibodies are absorbed. There is mild chimerism, and the risk of rejection is supposedly to be lower in SLK as compared to a kidney after liver transplant. So the authors aim to determine the incidence of acute cellular rejection of both the kidney or the liver in SLK recipients versus the kidney after liver transplant recipients, and also looked at the graft and the patient survival. So enrolled all patients who underwent liver transplant alone, SLK, or a kidney after liver from the UNOS database from 2010 to 2019, and recorded a 1-year data of all these patients, and including the demographics, the severity of liver disease, the donor characteristics, ischemia times, the HLA matching, and immunosuppression. And the outcomes included the graft loss, the mortality, and acute cellular rejection. So we can see here in this table, in the population were matched with respect to the demographics, the ethnicity, the diabetic, and the need of dialysis was much higher in the SLKT group, while the MEL score was much higher in the kidney after liver transplant group. Now, when they compared the liver-treated acute rejection at 6 months and 12 months, we can see here that the SLK-treated patients had a lower, almost half the risk of rejection of the liver graft as compared to the kidney after liver and a liver transplant alone. However, the rates of kidney treated acute rejection, the renal outcomes was not significantly different between the three strategies. And when you look at the Kaplan-Meier survival curves, patients who underwent a kidney after liver transplant had the worst survival. So the authors concluded that because the liver ACR is lower, definitely in SLK patients, and the graft survival is worse, we need to have more follow-up data on this strategy to say that liver transplant alone is superior in patients who have to undergo a SLK. Now, this is another abstract which looked at the analysis of the new OPTN and UNOS policy, which was implemented in August 2017. Under the new policy, the simultaneous liver kidney transplant candidates must have CKD, which is defined based on a persistence of the reduction in GFR for 90 days, or the GFR is below 30 immediately before listing, or be receiving chronic hemodialysis. Sustained AKI is defined as patients who are meeting hemodialysis, who are requiring hemodialysis for at least 6 weeks, or have a documented GFR below 25 during that time, and the liver transplant patients who developed kidney failure. So a safety net rule was applied here, which includes that patients will be given priority for on the kidney transplant waiting list in patients who underwent a liver transplant alone and who subsequently developed kidney failure in the first year after liver transplant. Now, the authors aim to study this new policy. So what they did here was they extracted the UNOS data and they subsequently stratified these patients. So the SLK passed group was one group, which comprised of all SLK candidates who were listed for SLK before the policy, that is August 2017, but who would not have met the new OPTN and SLK criteria. And similarly, patients who received liver transplant alone before the policy, but could have met the criteria for SLK, were labeled as a liver transplant alone passed group. And a propensity score matching was done for SLK listing in the merged cohort, where SLK passed and liver transplant alone passed groups were used to match the SLK passed and liver transplant alone present groups. Now, a total of SLK passed 1,976, liver transplant alone passed recipients, 3,000 plus patients, and a liver transplant alone recipients, 5,429 were included in the analysis, and the matched cohort of SLK passed and liver transplant alone present cohorts included 220 and 402 patients. Now, when they looked at the patient survival in this matched cohort, they found that there was a trend. The P log rank T test was around 0.09. And the Cox hazard model showed that the degree of renal failure was not associated with worse outcomes. So these are the Kaplan-Meier survival curves clearly showing a survival advantage for the SLK. However, we need to see whether with follow-up the curves merge or they get better with time. So the causal effect of adding simultaneous liver kidney transplant in the target population seemed marginal, especially because this is the immediate group and most of the mortality happens within the first year after transplant. And the cost benefit analysis from the viewpoint of the entire transplant society again has to be seen more carefully. Now coming to the biomarkers, and this is the biomarker study which looked at the renal vulnerability and incidence of acute kidney injury in outpatient cirrhosis. So this is a new biomarker that was investigated here. This is an emerging biomarker, the SUPAR, which is actually implicated, and it is released from the vascular endothelial cells as a part of urokinase degradation, because in the activation, the process of preventing the fibrin degradation, there is an activation of plasminogen to plasmin, and this requires urokinase. So what this SUPAR does is it binds to the beta-3 integrin on the podocyte cells. This causes a defective barrier function, albuminuria, and this is linked to the poor renal outcomes. So what the authors did here was they conducted a pilot study where they studied a set of biomarkers of glomerular function, and they stratified and they chose a group of patients who developed AKI versus who did not to see whether these biomarkers could predict the development of new AKI. So they looked at the eGFR estimation, the cystatin C, which is well established, urine albumin to creatinine ratio, and what they studied here was the proencephalin or the PENC. Now, PENC is another very important biomarker which has been studied not in patients with liver disease, but in critically ill population with sepsis, where it has been shown to predict very good, it precedes the changes in the glomerular function. And the other is the SUPAR, which I already discussed. And they also checked the marker of glomerular and tubular interstitial fibrosis, which included the DTK3. Now, 42 patients in a case-controlled study, 21 patients who developed AKI versus 21 who did not. The biospecimens, blood and urine were stored and they were analyzed for the biomarkers. And these are the diagrams showing the different biomarkers in patients with AKI and without AKI. And we can see here that there was a significant elevation of SUPAR levels. And in the conditional logistic regression model, they showed that amongst all the biomarkers, the levels of SUPAR were the most accurate in predicting the risk of incident AKI, and this model had a higher discrimination than a model which included serum creatinine, MEL sodium, SBP, and the ascitic status. Now, the SUPAR can also be a marker for predicting the development of chronic kidney disease or chronic renal dysfunction, and this needs further validation because this was performed in a very small subset of patients, and we really need to see whether these biomarkers could enable us in identifying patients who have compromised renal function. Now, coming to AKI in context of acute on chronic liver failure and biomarkers. So this was a study which was presented as an oral paper, wherein we showed the utility of urine NGAL and cystatin C in determining the terlipressin non-response, the need of dialysis, and 28-day mortality in a cohort of 240 patients of acute on chronic liver failure. And we can see here that the area under the ROC was quite good, almost 80% for cystatin C and 78% for urine NGAL, and a cutoff urine NGAL above 900 and a cystatin C above 2.5 was able to detect the need of dialysis, mortality, and terlipressin non-responsiveness. So this can be useful in aiding selecting out patients who are likely to non-respond and should be subjected to alternative treatment modalities. Now, this is another very important paper on coulimic nephrosis. And this was presented by our group. And we have previously shown in a large postmortem kidney biopsy data that coulommic nephrosis was more commonly seen in patients with acute and chronic liver failure as against patients with decompensated cirrhosis. And what was seen in this study was that coulommic nephrosis patients had a toxicity due to bile cast. And there is a defective oxidative phosphorylation, mitochondrial dysfunction. There is presence of bilirubin crystals in the urine analysis, and you need to have a kidney biopsy as the gold standard for the diagnosis of coulommic nephrosis. Now, this presents to us like a structural AKI because this causes tubular cell injury and cast formation, causes dilatation of the kidney tubules and tubulointerstitial nephritis. So how do we detect? Because we cannot perform a gold standard or a kidney histology for all these patients. So with this aim, we designed the study to look at a panel of biomarkers and markers of systemic inflammation in different phenotypes of AKI in patients with acute and chronic liver failure. And all these patients were graded as volume non-responsive AKI. And we also studied the pathogenetic basis and the response of the different phenotypes of AKI to different treatment modalities. Now, we took around 45 patients, 15 each in the HRS, the coulommic nephrosis, and ATN, and we basically used a combination of clinical, urine microscopy, spot sodium, and a kidney biopsy. And we did a panel of 30 different cytokines and growth factors. We also analyzed the genes of mitochondrial biogenesis in the exfoliated renal tubular epithelial cells, which were extracted out from these patients. And we also did IHC for the mitochondrial biogenesis marker, the SIR211, and the hypoxia-inducible factor, that is a marker of ischemic related injury. And a linear discriminant analysis approach was used for predicting the spectrum based on the biomarker. Now, these are the demographics of the patients. So we can see here that majority of these patients were males, alcoholics, had high MELD SOFA score. Most of these patients had R grade 3, deeply jaundiced. Most of these patients had a bilirubin above 15. The urea and the serum creatinine were elevated, and most of these patients had stage 2 to 3 AKI and all had metabolic acidosis. Now, let's look at the PCA plots here. This is a no AKI group, and we can see here there was a distinct difference in the panel of urine biomarkers between the three phenotypes of volume non-responsive AKI. And when we classified these phenotypes, we see here that patients with coulommic nephrosis, which are represented with the red dots here, they had a significantly higher level of serum bile acids. The markers of systemic inflammation, as can be seen in this heat map, were markedly upregulated in coulommic nephrosis, as against which were downregulated in patients with acute tubular necrosis. Now, when you look at the important biomarkers, cystatin C in the urine, which could be a marker of tubular injury, we can see here with the purple dots, the injury biomarkers, that is the NGAL, renin, were all elevated in ATN, and these were the injury biomarkers were all suppressed, but markers of tubular repair, that is the EGF, calbidin, and the osteopontin were markedly elevated in both CN and HRS, as against patients with ATN and no AKI. So patients with CN and HRS showed significantly higher repair biomarkers and lower levels of injury biomarkers. And we found that a cutoff level of renin above 9.4 and NGAL above 1100 classified ATN with 100% accuracy. And between the two groups of CN and HRS, patients with CN had a probability of having more renin, that is above 1.34. Now, when we looked at the tissues of these patients, and these are the beautiful pictures of postmortem kidney biopsies and the tunnel assay, we can see here that this was markedly higher and was expressed on the renal endothelial cells as well. In the renal epithelial cells in ATN, while it was expressed in the endothelial cells, the mitochondrial biogenesis genes in the exfoliated renal tubular epithelial cells showed suppression in ATN, while they were upregulated in the coulommic group. And in the histology, again, significant differences. The morphology was different, and so was the IHC staining, and SIR211 staining was more prominent in coulommic nephrosis. And if you see here, when we did plasma exchange and patients who had response in the renal functions with plasma exchange, we can see here a significant downregulation of all the pro-inflammatory cytokines was noted with respect to the improvement in the renal functions. So what we concluded here was that coulommic nephrosis is a distinct form of renal injury in patients with ACLF. and intense systemic inflammation, toxicity of bile acids, activation of renal repair, and lesser tubular injury is a hallmark. Renin and NGAL were identified as accurate biomarkers to differentiate ATN at least from CN and HRS, but really these need to be validated in a larger cohort of patients. And we should have different management algorithms, and each of these phenotype of AKI should be identified and managed differently in patients with acute and chronic liver failure. Now, very interesting study on exosomal microRNAs in the plasma and urine in patients with alcohol-associated hepatitis by Professor Raymond Betaller. And exosomes, we know they carry biologically active microRNA that can mediate AKI. And here they took 10 patients without AKI and 10 patients of alcoholic hepatitis with AKI, and they performed a microRNA analysis. And this is the heat map of patients in the plasma and the urine comparing alcoholic hepatitis with and without AKI. And what they found was 25 microRNAs were downregulated and 25 were upregulated in the plasma. And similarly, 33 were downregulated and 13 were upregulated in the urine samples of alcoholic hepatitis patients with the presence or absence of AKI. And the top plasma urine markers which were downregulated in AKI included the MIR22 and the MIR10, while upregulated included the LATC and the microRNA 27B. And the integrative pathways were all identified, which included pathways related to inflammation, the IL-6, the IL-6 receptor, IL-32, and LPS as potential mediators of AKI. A similar very interesting test, the neutrophil lymphocyte ratio, very simple test in patients with alcoholic hepatitis. 190 patients were analyzed here in 72 subjects. And what was interesting to see here that the NLR was associated directly not only with the risk of AKI, but also with the severity of AKI and the need of CRRT. So what the authors proposed here was the elevated NLR on admission was associated with increased incidence of AKI, and this could be also a strategy because this tells us about the systemic inflammation and the response of the host or the immune function of the host. And therefore, we need possibly more strategies targeting the systemic inflammation in context of alcoholic hepatitis and acute and chronic liver failure. So I would like to conclude that appropriate diagnosis and management of AKI can improve outcomes. The field of AKI is rapidly evolving. However, we need to have newer therapeutic strategies as well as diagnostic modalities to identify early and provide an effective management to these patients, which is an unmet need. And I would like to thank you for your very kind attention.
Thank you very much, Dr. Raki. That was very interesting and covered most of the challenges that we face daily. We are behind time. So Shiva and Dr. Nagarjuna, can we have some quick comments from you? We may have to wind up in the next 2 minutes, and Dr. Raki can also just conclude, if you don't mind.
I think it's a very good presentation, Dr. Raki, a very in-depth presentation. I know we're short of time. I have only one comment to make. The question of chloremic nephrosis looks very interesting. Probably the plasma exchange or the adsorptions might have a chance to play. Like we're talking about the cartridges, which will remove the bilirubin and bile acids. So probably in that particular scenario, I think you might have something to do for some other patients where they have a chloremic nephrosis. Yeah, thank you. This is from me.
Shiva, any comments?
No, there are plenty of questions, but I think with the time running out,
with the time running out, Dr. Raki, thank you very much. Very interesting. And thank the moderators. And we move on to the next session, which is going to be a talk by Dr. Akash Shukla. And let me invite the moderators for that session also. Dr. Manoj Sahu, who is the HOD and professor at the SUM Hospital, and Dr. B.C. Sharma, Professor B.C. Sharma also from ILBS New Delhi. Dr. Shukla is the head of the Department of Gastroenterology. The great interest in hepatology. For now, he's spearheading the transplant programs, many of them in Mumbai, and a very young, dynamic person. And let's hear it from him now. And I hope that we have some time left after this talk for some questions.
Good afternoon. respected co-moderator Dr. B.C. Sharma, our esteemed speaker Dr. Akash Shukla. We are indeed grateful to Professor Sarin and Manisha for this opportunity. Now I request Dr. Sharma to introduce our speaker and start the session. Dr. Sharma, please. Okay.
I think there's a connectivity issue, so we can go on with Dr. Shukla's talk. I have already briefly introduced him. Akash, we can go ahead with your talk, I think.
Thank you, sir. At the outset, I would like to thank Dr. Sarin for having me invited for this opportunity, and the chairpersons and the moderators for those kind words of introduction. Are my slides visible and moving?
Yes, yes.
Okay, thank you. So I will briefly touch upon the use of anticoagulants in patients with cirrhosis. Then I will cover hematological factors which contribute to rebleeding in patients with acute variceal bleeding. Then portal vein thrombosis, prophylactic use of blood products prior What is the anticoagulants with advanced liver disease? So this, we know there are patients who develop acute venous thromboembolism in the presence of advanced liver disease, and it becomes very challenging because most of us are worried in using anticoagulation in these patients because of the risk of bleeding. And all the venous thromboembolism studies have excluded patients with advanced liver disease, and therefore there is very little high quality data for this group. So in this single center retrospective database study, the anticoagulant practice patterns in adult patients with cirrhosis diagnosed with acute venous thromboembolism between January 1st, 2010 and 2019, December 31st were included. A study of 895 patients, almost half of which were child pug B, 283 were child pug C, and 205 were child pug A. Interestingly, only 16.2% of these patients received a therapeutic dose of anticoagulation, and only 2.8% additional received a prophylactic dose. Other patients did not receive any anticoagulation. Amongst those who received therapeutic anticoagulation, majority received vitamin K antagonists, 49 received DOACs, 61 received low molecular heparin, and 7 received fondaparinux. The DOAC use was more common in CTP A and B patients as expected. Now here in red, you see the use of DOACs, which has increased in the last 5 years. And in the blue is fondaparinux, which has gradually come down. And if you see the proportion of patients with low molecular heparin, which is in yellow, has remained the same. And the green is vitamin K antagonist, which has gradually started coming down in the last 5 years. The 3-month survival was higher in those who received DOACs as compared to other anticoagulants, but also as expected, the 3-month survival across the CTP classes also declined. So A had the highest and C the lowest as expected. So whether this DOAC benefit is because of the DOACs or it is because many of these patients were child A cirrhosis, we'll have to wait for the full paper to come out to interpret. Bleeding was the least common in CTP-A, as well as the recurrent thrombosis was also most common in CTP-A cirrhosis. The bleeding events were similar with all anticoagulants, but the recurrent thrombosis per patient were lower with DOACs as compared to low molecular heparin or vitamin K antagonists. So they concluded that over the last 10 years, there is an increased use of DOAC usage, especially in the last 5 years. The bleeding risk is similar, but DOACs probably have a greater efficacy in preventing rethrombosis. Survival after venous thromboembolism was worse in patients on LMWH than those on DOACs or vitamin K antagonists, but this appears to be influenced by higher proportion of patients on low molecular heparin being in child pug classes B and C. Now, use of oral anticoagulants with vitamin K antagonists for cirrhosis with PVT. This was a systematic review and meta-analysis. We know that there are practical concerns using vitamin K antagonists in patients with PVT because of their narrow therapeutic range, dose titration, risk of vitamin K antagonists because you cannot assess the efficacy based on INR, and therefore people have been looking for alternatives always. Recent AASLD guidelines recommend direct-acting oral anticoagulants in cirrhosis patients with non-tumoral PVT. Currently, the efficacy between DOACs and VKAs for treatment of cirrhosis with non-tumoral PVT remains unknown. So in this systematic search, they looked at all the studies comparing DOACs with vitamin K antagonists to treat PVT in patients with cirrhosis. The primary outcome was complete or partial PVT recanalization, and secondary outcomes were PVT progression, major bleeding, variceal bleeding, and death. 11 studies were included, of which 10 were observational and 1 randomized, and they evaluated 4 types of DOACs. Overall, the PVT recanalization rate was 46%, PVT progression was seen in around 13%, major bleeding in around 8%, and death in around 10%. DOACs were associated with a higher pooled rate of PVT recanalization and lower risk of PVT progression. The risk of major bleeding similar to the previous study, safety appears to be better here, and the efficacy also appears to be better here. So for the treatment of PVT in patients with cirrhosis, the bleeding risk was comparable between DOACs and VKAs, but DOACs were associated with a higher pooled rate of PVT recanalization. While these findings are likely to be applicable to patients with CTP A and B cirrhosis, remember, we cannot use these drugs, DOACs, in patients with CTP C cirrhosis and have to be used carefully in patients with CTP B cirrhosis. But we still do not have randomized studies to confirm these findings. Coming to the second part, what are the hematological factors which govern rebleeding in patients with acute variceal bleeding? So this work done by Madhumita and her group from PGI Chandigarh. So even after controlling acute variceal bleeding, we know that sepsis leading to hyperfibrinolysis, endogenous heparinoids, and coagulation dysfunction resulting in higher risk of rebleeding is observed in clinical practice. This secondary fibrinolysis is often caused by altered balance of TPA and pi, which is quite often due to the inflammatory and endothelial elements. Prospectively assessed in this study was the association of coagulation failure and hyperfibrinolysis with rebleeding events, sepsis, and outcome in patients with acute variceal bleed. So consecutive eligible patients were included, and they were assessed for their coagulation parameters and presence of endogenous heparinoids, which was defined as difference in the sonoclot traces for activated clotting time, that is ACT, H more than 40 seconds, ACT minus ACTH more than 40 seconds, and clot lysis more than 5% at 30 minutes was considered significant. Patients with recent blood component transfusions or refractory shock were excluded. Of the 138 patients with cirrhosis with acute variceal bleeding, 80 patients were recruited. 13 had early rebleeding in less than 14 days. Endogenous heparinoids were noted in 40% of the patients at day 0 and 68.55% patients with rebleeding respectively. Standard tests of coagulation like platelet count, PT, and APTT did not differ between patients who did or did not rebleed. ACT of more than and 82% and 74% respectively. So these were the factor assays which were evaluated. The factor 8 levels were actually higher in patients with early rebleeding. Factor 13 levels were lower in those with rebleedings. TPA levels were higher, and pi levels were lower in patients with early rebleeding. The predictors of mortality at day 0 were factor 8 antigen levels more than 145%, TPA levels higher, low PAI, and INR more than 2.4. In multivariate analysis, only factor 8 antigen levels and INR remained significant. Markers of inflammation like interleukin-1 beta and interleukin-6 were higher in patients who had a rebleeding. And presence of endogenous cypionanoids at day 0 predicted development of sepsis, rebleeding events, and higher risk of mortality. So they concluded hyperfibrinolysis, systemic inflammation, and endogenous cypionanoids contribute to coagulation failure, increased tendency to rebleed, and mortality in cirrhosis with acute variceal bleeding. Coming to portal vein thrombosis. Now, whether portal vein thrombosis impacts natural history in patients with cirrhosis. So this was a study which looked at the outcomes in patients with PVT in the presence of HCC. Previously, the data has been conflicting with Philippe Neri study from France and Portugal, as well as Maruyama studies from Japan showing no impact on natural history. And in contrast to that, the study from UNOS database, which showed that it does impact the natural history. So in this study, cirrhotic patients with HCC undergoing laparoscopic microwave ablation were enrolled, and they were classified according to presence of non-neoplastic PVT over a period of 4 years. Patients with tumoral thrombosis or previous surgery were excluded. They were followed from 36 until death or liver transplantation. The thrombosis extension was noted. The HCC total tumor volume and the response to treatment were taken into account by a single radiologist who was blinded. Similarly, the risk factors were evaluated with both uni and multivariate logistic regression analysis. 750 patients were included, of which 88 had portal vein thrombosis. 50 of these showed isolated PVT, 33 had extension into mesenteric vein, and 5 had involvement of portal vein, splenic vein, and mesenteric veins. On multivariate analysis, the pre-treatment total tumor volume and presence of CSPH were the only independent predictors associated with development of PVT. 56 patients with PVT were followed up for more than 3 months, and of which 14 were treated with anticoagulation. Interestingly, PVT improved in 43% of anticoagulated patients versus only 6% of those who were untreated. Anticoagulant therapy and HCC response to treatment were independently associated with improvement in PVT. The only predictive variable of PVT progression was lack compared to 47 months in those with recanalized or stable partial thrombosis. So recanalization does improve survival in this cohort of patients. The prognostic of progressive PVT was 2.1 hazard ratio along with total tumoral volume and CTP, and this persisted on multivariate analysis. So we know now PVT development in patients with HCC is predicted by tumor burden, whereas its progression is associated with non-response to microwave ablation. In patients with complete or progressive PVT is independently associated with mortality, and this raises an important question whether patients with high tumor volume or lack of response to treatment should be considered for thromboprophylaxis. And because there is improved survival in those who had recanalization with anticoagulation, should we consider anticoagulating bland thrombosis in the presence of HCC? Now, another study looking at importance of portal vein thrombosis in patients with cirrhosis. This was a MUSC clinical database, 198 patients with cirrhosis and PVT. 89 had simultaneous PVT and diagnosis of cirrhosis, whereas the others had sequential diagnosis of cirrhosis followed by PVT. The data were extracted Those patients who had simultaneous cirrhosis and PVT diagnosis, they were less likely to experience thrombocytopenia and splenomegaly as compared to the others. The ascites, varices, with or without bleeding, and encephalopathy were more prevalent in patients where PVT developed after the diagnosis of cirrhosis. But these developed more rapidly in those patients who presented with simultaneous cirrhosis and PVT. And when we look at the survival, patients who presented with PVT along with cirrhosis, those are represented in the blue line, had a lower survival at 1 year and 3 years. Their year was 41% and 10% as compared to 49% and 32% in those presenting sequentially. So patients who develop PVT early in the clinical history of cirrhosis have a more aggressive clinical course than patients who develop PVT after the diagnosis of cirrhosis, including significantly greater 1 year and 3 year mortality. What about natural history of a portal cavernoma in the presence of cirrhosis? We know that patients who develop PVT
I guess we lost her.
I think we are having some connectivity issue with Akash's talk. In the meanwhile, may I ask the panel until he rejoins us, can you analyze or from your own experience say how these papers are relevant? I think Akash is back with us. Just let us see if he can. Yeah, okay. There is some audio issue, but I think we can very well read the slides, and they are quite self-descriptive.
Akash, you need to unmute, sir. Unmute.
I think I muted myself. Sorry. So so this was about the cavernoma study. So patients who had a cirrhosis and cavernoma had lower APRIs and FIB4 as compared to patients with cirrhosis and PVT alone, although their disease severity scores were similar. There was no difference with respect to development of esophageal varices and hepatic encephalopathy, and there was a trend for patients with cavernoma to have a lower incidence of ascites on follow-up. Patients with cavernomas transformation were less likely to have HCC, again probably reflecting a lesser level of advanced fibrosis or advanced parenchymal extinction at presentation. Over a mean follow-up period of 60 months, the mortality of patients with cavernoma was less as
Holding slide up.
may be guiding these patients. Prophylactic use of blood products prior to paracentesis and thoracocentesis in patients with who are undergoing tapping. So we know INR and platelet are poor indicators, and people often overuse FFP and platelets. So this study aimed at identifying risk factors associated with major bleeding events, as well as pre-procedural prophylaxis, depending on who is prescribing these products and who is going to do the procedure. So this was a retrospective study over 1 year period. All patients undergoing abdominal or thoracic paracentesis were included, and major bleeding events were defined by the ISTH guidelines. 122 patients met the inclusion criteria. 153 patients were excluded because of different reasons. A total of 300 procedures were finally taken into account, of which 9 had major bleeding events, including 2 deaths. There was no difference in the MELD sodium, INR, or platelet count prior to procedures in which bleeding occurred versus where bleeding did not occur. 53 patients received FFP and 22 received platelet transfusion. Very interestingly, although interventional radiologists performed 40% of the procedures, 89% of FFPs and 77% of platelet transfusions were given to those patients where procedures were performed by interventional radiologists. Although these patients had same MELD scores, same INR, and same platelet count. And among the different specialties of medicine, whether hospital medicine, emergency medicine, or internal medicine, the pre-procedure transfusions were very, very same. So this was a very interesting finding. So they concluded bleeding events in patients with decompensated cirrhosis are not related to pre-procedure INR or platelet count. And therefore, consensus guidelines across specialties need to be developed so that everybody is on the same page. Coming to the last part, that is Budd-Chiari syndrome, outcome of patients with acute and subacute Budd-Chiari syndrome when they undergo TIPS. This was from Dr. Amar Mukund from ILBS. Now, these are the patients with acute and subacute Budd-Chiari syndrome who have high mortality rates, and therefore it becomes difficult to treat them. So here in this study, they analyzed long-term outcomes of direct IVC to portal venous shunting as a treatment. So over a period of 7 years, 68 patients who underwent DIPS were analyzed. Patients were divided into 2 groups based on LB, whether it was low LB or high LB, and both the groups were compared for outcomes and transplant-free survival. Overall, the time taken for resolution of presenting complaint was around 9 weeks, and pain in abdomen was around 2.5 weeks. All patients who had variceal bleed had complete resolution of varices on endoscopy at 3 months, and no significant differences were observed between the 2 groups with regard to procedure-related complications. The transplant-free survival at 1 and 5 years after intervention in both groups was 96% and 92.2%.
I think this was the last part of the talk by Dr. Akash. And I think we do have some connectivity issues. Are the moderators on, Dr. Sahu? I can't see Dr. Shukla in the on the participants. Dr. Sahu, are you there?
Yes, sir.
Yeah. So maybe I think you can, I think this looks like the last part of the talk, and we have lost Akash. So some comments from you on this presentation, Dr. Sahu.
I think, sir, this is a beautiful presentation by Professor Shukla. So one important thing is that if you see the study, so the use of FFP and platelet transfusion in different specialties. So can we come forward and make some guideline nationally, and so that this will be followed uniformly regarding FFP and platelet transfusion? I think he's
I think he's back, so we'll just wait for the talk to conclude.
For this is my last study, and after this, if time permits, then I'll take 1 or 2 studies from basic science, but otherwise I'll stop after this.
Akash, we may run out of time.
So I'll stop after this. This is the last study, then I'll take. So predictors of outcome for Budd-Chiari syndrome with acute on chronic liver failure. This was a multi-center study from our center as well as multiple other centers from AASLD Research Consortium. So Budd-Chiari syndrome may present as acute on chronic liver failure. There is paucity of data with regards to the outcomes and predictors of outcomes. In this study, consecutive patients with Budd-Chiari syndrome presenting as ACLF were included in the study. The baseline parameters and disease severity scores, as well as type of intervention and 90-day outcome were recorded. Patients are classified into three subtypes. Type A, who were previously diagnosed or undiagnosed BCS, who develop ACLF because of acute thrombosis, extension of thrombosis, or reocclusion of hepatic vein or the stents. Type B, previously diagnosed or undiagnosed Budd-Chiari syndrome with ACLF due to an unrelated acute hepatic insult. And type C, acute hepatic vein or IVC thrombosis is the acute insult in patients with pre-existing other causes of chronic liver disease. 70 patients were analyzed. Ascites was present in all, hepatic encephalopathy in 38.6% patients, and half of them had grade 3 or grade 4 hepatic encephalopathy. Type B was the commonest, followed by type A and then type C. The median MELD score was 15, the LaFAS was 7, and the mean Rotterdam score was 2.51, and mean BCS TIP score was 5.25. 19 patients died or had liver transplant. The primary outcome of mortality or transplant was higher in patients who did not undergo intervention. Absence of endovascular intervention and presence of hepatic encephalopathy were found to be independent predictors of mortality on multivariate analysis. So these are the comparison of different scores for predicting survival, and LaFAS score, that is the lactate-free ARC ACLF score, was found to have the best discriminatory performance. So to conclude, type B BCS ACLF followed by type A BCS ACLF is the commonest presentation. Timely radiological intervention is associated with better outcomes. And here we demonstrate that presence of hepatic encephalopathy is not a contraindication to doing TIPS in this cohort of patients with Budd-Chiari syndrome. And amongst the prognostic scores, LaFAS had the best discriminatory performance for mortality or.
Thank you, Dr. Akash, for giving us such a great collection of papers, which gave us a great prognostic window. A quick comment from you, Dr. Sahu, since we don't have any questions in the chat box, because then we break for lunch.
I think a lot of thanks to Professor Shukla, beautiful presentation. He finished on time, so it is the best opportunity. I think we wind up here. If Dr. Sharma is there, some comment from Dr. Sharma, otherwise we'll conclude the session here.
Yeah, so I think Dr. Sharma is unfortunately not being able to join us. So I thank Dr. Shukla, Dr. Sahu. I thank all the viewers who have been with us in this pre-lunch session. And just to remind you that please join us at 1:30 for the next exciting session of the hot topics at the AASLD. See you all at 1:30. Hello, everyone, and welcome back to the post-lunch session of the hot topics at the AASLD. Thank you for being with us in the morning and joining us again after lunch. So now we have a very exciting session on clinical vignettes by Dr. Patrick Kamath, who, as you know, is the professor of at the Mayo Clinic, professor of hepatology in Rochester, USA. And for this panel, we have a very exciting panel of moderators, as Professor Vivek Saraswat, who is the head of hepatology at the MG Mahatma Gandhi Hospital Medical College, Dr. G.N. Ramesh, who is at Aster Cochin, Dr. Setu Babu, of course, a well-known person, is the head of gastro at KIMS. And I think we will now go on directly to the recorded talk by Dr. Kamath. He won't be able to join us for the Q&A because it's very early in the morning there, but I'm sure that our good, excellent set of moderators will answer any questions, and we pass on your questions to Dr. Kamath as well. We can start off with the talk.
Thank you very much for inviting me to speak. I wish this could have been in person because I'll be showing some clinical cases and it might have been best to be interactive, but we'll do the best we can, okay? So let's start with the first case. 34-year-old woman, ALT 100, alkaline phosphatase 500. She has type 1 diabetes mellitus, which is poorly controlled. Viral, metabolic, and immune causes of liver disease have been ruled out. MRCP and MRI show no biliary obstruction. She has a history of retinopathy and nephropathy. So what would you advise now? Like I said, I wanted it to be interactive, but I put up choices and you think for yourself what you might want to do, and then I'll proceed with what I did, okay? So what would you advise now? Would you recommend a liver biopsy? Would you recommend a triple phase CT? Would you fractionate the alkaline phosphatase? Or would you test for short telomere syndrome? And the answer here clearly is a liver biopsy. Triple phase CT won't show you much more than what the MRI has shown you. Triple phase is a little better to show you portal vein and hepatic artery and its branches, but really we're not suspecting that here. We're certainly not suspecting any disease in the large blood vessels. No need to fractionate the alkaline phosphatase. The only time you'll fractionate the alkaline phosphatase is if you have isolated elevation of alkaline phosphatase and you want to see whether that is from liver or from bone. When you get ALT elevated along with alkaline phosphatase, that assumes it is of liver origin, and so no need to fractionate. Short telomere syndrome, you suspect when there's idiopathic portal hypertension, especially if it is familial, or if you have a patient with premature graying, bone marrow problems, skin changes, and also cryptogenic cirrhosis. So that is not the situation here. So liver biopsy would be the best. So here's what the liver biopsy shows. I want you to know this condition. It's called diabetic hepatosclerosis. So that is microangiopathy of the liver. So remember in diabetes, you have the diabetic glomerulosclerosis, you know, the diabetic nephropathies, the Kimmel-Steele-Wilson lesions. So diabetic hepatosclerosis is microangiopathy of the liver. So the blood vessels have an angiopathy. So the typical features, our patient has long-standing type 1 diabetes. There are microvascular complications the patient will have. So our patient has retinopathy as well as renal involvement. It is mainly as an alkaline phosphatase elevation because it's arterial disease, so less blood flow, bile ducts get impaired blood flow, so you get mainly alkaline phosphatase elevation. And the biopsy will show you dense perisinusoidal fibrosis. So here, this is a trichrome stain, and see around the sinusoids, you get fibrosis. Note, there is no fat. So type 1 typically does not have fat in the liver. Okay, so microangiopathy of the liver, suspect that in anyone with type 1 diabetes and other vascular complications, retinopathy and nephropathy, who has an isolated elevation in alkaline phosphatase. Okay, let's stick with diabetes again. So this is a 20-year-old female with type 1 diabetes. She comes with ALT elevations. So this is the 4th hospitalization for diabetic ketoacidosis in 2 years. AST and ALT range between 400 and 800 at the time of hospitalization, but normalize between episodes and are associated with marked hepatomegaly. Okay, so hepatomegaly with intermittent elevation of the AST and ALT. So what condition are you thinking of? Shrikant Mukhewar, if you're listening, what condition are you thinking of? Because your son, Shaurabh, has written about this. So this condition is glycogen hepatopathy. You might remember in younger children was described a condition called Mauriac disease, which was glycogen in the liver in type 1 diabetes and associated with growth retardation. A broader term is just glycogen hepatopathy. So what are the features? More common in females in their 20s. They present with abdominal pain and hepatomegaly, recurrent diabetic ketoacidosis. And when they come with ketoacidosis, the AST and ALT go up in the high hundreds, occasionally over 1,000. These patients typically have an elevated hemoglobin A1C. And the CT scan shows you a white liver. Okay, so it's important to know what are the different causes of a white liver. And on pathology, the liver is full of glycogen, but no fat. So here you can see the white liver. Normally the liver and spleen are about the same. Notice here, the psoas muscle and spleen are about the same, but the liver is brighter, okay? So glycogen hepatopathy seen in poorly controlled type 1 diabetes. Aminotransferases usually between 100 and 1,000, and they improve quickly with control of the diabetes. And the CT scan shows a white liver. What are the other causes of a white liver on non-contrast studies? Amiodarone, that's because of the iodine in the amiodarone. Wilson disease, so metal in the liver makes it look white, so Wilson and hemochromatosis. And then otherwise it's glycogen storage disease because it's glycogen in there, or glycogen hepatopathy. So white liver, non-contrast study, small differential diagnosis only. Let's look at the liver biopsy. See no fat at all. Just liver cells all laden with glycogen. So let's summarize diabetes in the liver. In type 1 diabetes, you can get glycogen hepatopathy. In children, you'll call it Mauriac syndrome or Mauriac disease. Celiac liver disease associated with type 1 diabetes. And hepatosclerosis, which I showed you before, that's the microangiopathy of the liver seen in patients with long-standing type 1 diabetes and other vascular complications. In type 2 diabetes, now these are studies which I'm showing you are not population studies, but in the diabetes clinic, 70% of patients in diabetes clinic have steatosis. 21% will have fibrosis. About 3% have 4. So asymptomatic, previously undiagnosed liver disease, 3% will actually have cirrhosis. and 6% will have each of F1 to F3. So fibrosis is in about 1 in 5 patients in diabetes clinics. And note, ALT elevation is not common in these patients. Even in those who have fibrosis, only a third have elevation in the ALT. And this would be important for you to read this paper on in diabetes care, goes over all this. So that is the reason some societies recommend that patients in diabetes clinics need to be screened for liver disease. Okay, let's take yet another case. So we have moved on from diabetes. Let's take another case. It's a 51-year-old female professor. She came to us with abnormal liver enzymes noted during evaluation for abdominal bloating. She was in a normal state of health till November 2020 when she had intervention for carpal tunnel syndrome. And she says soon after that, she started getting abdominal bloating. BMI was 35. She had iron deficiency, which was thought to be related to menorrhagia, and she was given iron infusions. She took non-steroidals intermittently, but really not consistently. And she would have a few glasses of wine a week. So these are her tests. November 2020, normal. She comes to the emergency room with abdominal bloating, AST 691, ALT 1214, alkaline phosphatase 230. She was asked to follow up next month. AST, ALT, alkaline phosphatase normal. In June, when she went to the emergency room, so between January and June, it was thought she was okay. In June, when she went to the emergency room with severe rectal pain, AST 783, ALT 1170, and alkaline phosphatase 240. So during the emergency room visit in December 2020, she had an ultrasound that showed the gallbladder was normal, common bile duct not dilated, and some hepatic steatosis. So nothing for biliary obstruction. So she's on closer follow-up now, and AST and ALT spikes continue for 2 to 3 months, intermittently elevated, intermittently completely normal. She's had an ultrasound, CT, and MRI, which shows steatosis, and we know that, showed that from the ultrasound before. She has viral, immune, metabolic causes of liver disease, all investigated are negative. So the question for you is, what are you thinking of? What could be the cause of intermittent AST and ALT spikes? And what are you going to do next? What is your next test? Think about it, okay? If some of you thought it was a liver biopsy, the question you have to ask yourself is, when do you want to do the liver biopsy? Do you want to wait for a time where the AST and ALT are elevated and immediately do a liver biopsy? Or you want to say, okay, let everything settle and then I'm going to do a liver biopsy. So the question is, what test will you do next? And the answer is, it's not a liver biopsy. So let's go over causes of intermittent AST and ALT elevation. So go up and down. So biliary obstruction will cause that. So suspect that when a person has biliary type pain associated with AST and ALT elevation, rises quite rapid, typically within 24 to 48 hours, and can reach over 1,000. But this patient has no abdominal pain. Recurrent drug exposure. So maybe has a problem related to medications, an idiosyncratic reaction, and is taking it multiple times. But this patient here has not been doing that. She's just taken non-steroidals and not that frequently. Remember this, when you see hepatitis A, when a patient is recovering from hepatitis A, the AST and ALT can go up. And I'll go over that in a little more detail later. Autoimmune hepatitis, flares up and down and can return to normal even without treatment. That's the feature of autoimmune hepatitis. Runners, it's not from the liver, but it's from muscles. So marathon runners, soon after marathon, will have a marked elevation in the AST and ALT. And remember, marathon runners can also have diarrhea and some gastrointestinal bleeding too, following a marathon. Or is this a recurrent ischemic phenomenon? And is this obstructive sleep apnea? So let's look at relapsing hepatitis A, because you might be seeing some case of hepatitis A. Relapses are not infrequent. So 3 to 20% may have multiple relapses. So typically, the relapses are in a short period of time. So within that 6-month period after the onset of acute hepatitis, typically within the first 3 months, you can have AST and ALT go up. But typically, AST and ALT are not as high as it was in the initial presentation. So typically in the low 100 or 200s. And they tend to have cholestatic pictures. So bilirubin goes up during this time with alkaline phosphatase too. Those who have multiple relapses may have some immune manifestations too, purpura, nephritis, arthralgias. And the clinical course is benign. So if there's a lot of cholestasis and they're itching, then you might try just a short course of steroids. Just 3 to 5 days is typically enough. So this patient has obstructive sleep apnea, which causes intermittent liver enzymes. So the test being done here is an overnight oximetry. So let's discuss this further. The true mechanism is unclear, but is biologically plausible. Patients with obstructive sleep apnea tend to have hypoxia in target tissues. And we know chronic intermittent hypoxia can modulate a necroinflammatory response in the liver, and there are animal studies which show this. And hypoxia induces factor 1 alpha, so it's called hypoxia-induced factor 1 alpha, and that is a mediator of fatty liver and fibrosis in animal models. So patients with obstructive sleep apnea have been studied prospectively. So this is a study of patients requiring bariatric surgery, so BMI greater than 40 or greater than 35 with comorbidity. And those who are interested can read this study. So liver enzymes were elevated in about half the patients, NASH in 1/3, obstructive sleep apnea in most of these patients. And those with obstructive sleep apnea were older, higher BMI, and they had more elevation in liver tests than those without obstructive sleep apnea. Another prospective study. 85 patients with sleep study, liver biopsy was performed at the time of obesity surgery. All but one patient had histological evidence of NAFLD. So obesity and sleep apnea, they almost invariably have fatty liver disease. 51% of the study population had obstructive sleep apnea. Those with obstructive sleep apnea had higher ALT levels compared with those without obstructive sleep apnea. So remember, when I say most patients with fatty liver disease who require obesity surgery, so that is BMI greater than 40 or greater than 35, will have some element of obstructive sleep apnea. 19% had fibrosis on liver biopsy, and some had bridging or cirrhosis. And generally, when you look at the patients who progressed, more severe fibrosis, more progressive liver disease, they more likely had sleep apnea than those who did not have sleep apnea. So if sleep apnea causes elevation in the AST and ALT, then if you use positive airway pressure as treatment for obstructive sleep apnea, the question is, do you get improvement in the liver biochemistry? So this is a study from Japan. 40 obese men with obstructive sleep apnea, They checked AST, ALT, triglyceride, glucose, insulin, leptin in the afternoon and immediately before sleep, before and after nasal CPAP treatment. So aminotransferases were normal in a third of patients, so 14. Without CPAP, there was an elevated AST and ALT in the morning or early afternoon, depending on when they checked it. But after nasal CPAP, they had lower AST or ALT in the morning. So with CPAP, they did better. And the improvements in AST and ALT were maintained for 1 and 6 months after nasal CPAP treatment. So obstructive sleep apnea associated with elevation in the test, improvement with CPAP. Now this is important studies from Phil Mathuran, who does the work on alcohol-associated hepatitis. He reported this when he was a fellow in Paris. 61-year-old woman admitted to the ICU with acute liver failure. She had obesity and arterial hypertension, was on nifedipine and acebutolol. AST on elevation on admission 3,000, next day 1218 and then 670. ALT 698 went to 1069 and then 935. So AST, ALT in the thousands. And we personally, I have many patients whom I've seen where the AST and ALT gets into the thousands. And that's the reason I'm presenting this case. All known case of acute liver failure were ruled out here. No evidence of pulmonary hypertension, no evidence of right heart failure, HVPG normal. Liver biopsy showed massive centrilobular necrosis and mild venous distension. So no inflammatory infiltrate. So suggestive of ischemia, not suggestive of right-sided heart failure. And this patient with polysomnography with multiple desaturations, lowest saturation was 50%. This is really, it's difficult to live with this low saturation, but if it's chronic, patients can manage. And cumulative time spent with saturation less than 85% was half the time. So this was really severe sleep apnea. So main takeaway from this patient, sleep apnea is an under-recognized contributor of elevation in liver enzymes, and it's independent of NAFLD and diabetes mellitus status. So suspect that in obese patients with intermittent elevation of AST and ALT and otherwise negative workup. And it's really quite satisfying because if you put them on CPAP, all their fatigue, not all their fatigue, but their fatigue improves significantly, and they're happy that the AST and ALT have improved. Okay, let's take yet another case here, okay? 62-year-old male, come with elevation of liver enzymes. First presentation was when it was 7 times the upper limit of normal. It was not known to have liver disease prior to this presentation. So his past medical history, he had seropositive rheumatoid arthritis with Sjogren's syndrome. This was diagnosed 15 years ago, and he was on adalimumab for 12 years. It's a drug that is also used for Crohn's disease. Occasional joint and soft tissue swelling, had a dry mouth, denies dry eyes. Alcohol use prior at regular use, 18 to 24 units per week. Now he's been abstinent for 6 months. Medications, naproxen twice per week. So here is the timeline of the elevation in the liver test, okay? So first in April, he had completed the Pfizer vaccine, routine blood work for adalimumab dosing. ALT was 512, AST 339, alkaline phosphatase normal, bilirubin 1, albumin 3,4, platelets 244, INR 1.2. So his home doctor said, let's repeat in a month. Month later, AST 752, ALT 1287, alkaline phosphatase, bili, platelets, really not that much different. So follow-up, viral serology negative, ANA just positive, smooth muscle antibody weakly positive, antimitochondrial antibody negative, hemochromatosis, protein electrophoresis, quant gold, which is a test used for tuberculosis, all this is negative. So just high AST and ALT, positive ANA, weakly positive, smooth muscle antibody. So what will you do next year? Think of what you would do. And if you said liver biopsy, you are absolutely right. The question is, what is your diagnosis? Few things I want you to focus on. Focus on the infiltrate and these cells, little more pink. These are the hepatocytes. So what is your diagnosis? Look carefully at the hepatocytes. Normal hepatocyte will have one nucleus, maybe two nuclei. This hepatocyte has rarely multiple, probably 10 or 12 nuclei. Here with 8 nuclei. So you can see multiple hepatocytes with multiple nuclei and these pink cells. So look at that carefully. Again, look at that cell carefully. And the biopsy shows prominent giant cell transformation of the hepatocytes. When you get multiple nuclei, that's called giant cell transformation of the hepatocytes. And the portal tract show mixed inflammation, lymphocytes. There are neutrophils here, lymphocytes, and see the eosinophils. So these findings are consistent with what's called post-infantile giant cell hepatitis. On the histology, it's difficult to say what caused this. Now, the reason it's caused post-infantile is giant cell hepatitis is typically seen in neonates. So when you get it beyond the age of infancy, the question is, what is the cause? So this patient had giant cell hepatitis. This was all on the outside. Started on prednisone 50 milligrams, but could not manage it. It got significant side effects. So 1 week after starting prednisone, ALT was somewhat higher, AST 373, bilirubin 1.6. So he came to us, seen in our liver clinic, found that the liver tests were rising despite prednisone. Again, nothing for chronic liver disease. We ruled out all other causes. Had a pathologist review. Pathologist confirms this is giant cell hepatitis. Ultrasound normal, Doppler normal. And so patient has persistent liver enzymes still. So what are you going to do for this patient? Think about what you're going to do. You're going to go up on prednisone. Are you going to add on any medication? Do you want to do any further tests? So we added azathioprine. I like azathioprine. It's cheap. A lot of experience with that. Didn't want to go up on prednisone because already patient had significant side effects on prednisone. Other options, of course, would be budesonide. Not sure if systemic prednisone doesn't work, whether budesonide would be that effective. It's possible, but wanted the patient to feel better quick. Cyclosporin and tacrolimus, we would consider only if patient had failed azathioprine. So started on a little high dose of azathioprine, dropped the dose of prednisone to 40, liver tests had improved. Next month, further improvement in liver tests, dropped the prednisone. And in October, when we saw the patient was feeling great. No problem at all, he said. Decided to keep him on azathioprine, was down to 10 milligrams of prednisone. The patient was time for the booster COVID vaccine, November 2021. So about 6.5 months after his initial dose. So his question is, can I get the booster vaccine? So question for you is, what will you tell the patient? Yes, take the booster. No, don't take the booster. So let's look at reported causes of post-infantile giant cell hepatitis. They can be infectious, can be seen with multiple viruses, autoimmune, like in our patient, medications, hematologic, endocrine, infiltrative. In our patient, it may have been autoimmune. Question was, is it related to adalimumab? Or was it related to the COVID vaccine? Okay, think about it. What's your answer here? So when we look at liver toxicity of adalimumab, it's a monoclonal antibody to TNF-alpha. Typically, ALT is about 3 times the upper limit of normal and not that frequently reported. Hepatocellular injury is more likely, typically occurs within 3 months. And can you think of why this occurs? Because those who've had elevation in the ALT, that's been linked to reactivation of hepatitis B. So those are people who are typically E antigen negative, normal AST and ALT, and no or low levels of HBV DNA. And that's the reason you check for hepatitis B before starting treatment, because this can flare occasionally. So our patient, of course, did not have hepatitis B. So can the COVID vaccine cause autoimmune hepatitis? So to date, at least there are 24 reported cases. And I think this is important because you would probably be seeing this. I'm not sure, but you might be seeing it. So there are case reports of vaccine-induced immune-mediated hepatitis with rapid onset of AST and ALT elevation after the first dose. But after the second dose, the autoimmune hepatitis tends to be more severe. At least the AST and ALT tend to go much higher. Liver tests show AST and ALT elevation, and they may normalize in 2 weeks. There's eosinophilic infiltration, so that suggests DILI, at least in some patients. So the question is this vaccine-related DILI with autoimmune features, for which steroids might be recommended short-term? Or is this vaccine causing immune dysregulation, in which case you would think of steroids long-term? So this paper is online in Journal of Hepatology, Hepatic Complications of Post-COVID Vaccine. The lead authors are from Northwestern in Chicago, but they've collected 16 patients from all over, 25 to 74 years of age, presenting 5 to 46 days following their vaccine dose. 12 had the Pfizer vaccine, 4 had the Moderna vaccine, which are the messenger RNA vaccines. 75% of patients presented after the second vaccine dose. Remember I said that's when it tends to go higher, the AST and ALT. 6 patients had a previous history of chronic liver disease, including autoimmune hepatitis. The majority demonstrated hepatocellular pattern of liver injury with peak ALT ranging from 96 to 5,000. There was no acute liver failure. Liver biopsy showed portal inflammation and significant plasma cell infiltrate in these patients. And cholestasis was only prominent in 1 case. I had a phone call from a hepatologist a few days ago who said they had a PSC-like picture on liver biopsy in one of their patients. And steroids are used in the majority of these patients. I personally have had 4 patients. I used steroids only in 1 patient. They seemed to do well. Liver biopsy was not that severe in the 2 patients in whom we did the biopsy. In 1, it was more severe, and we started steroids. So in many, it gets better, and in many, it might be a delay, a sort of vaccine-related delay with autoimmune features. So these are the side effects of COVID vaccines. But please remember the most important. Make sure everyone you know gets the vaccine. The benefits of COVID-19 vaccine outweigh the known and potential risks. So the common side effects are local. So they're systemic with flu-like symptoms. Myocarditis and pericarditis are rare. And this is from the New England Journal 2 weeks ago with the messenger RNA vaccines. Allergic reactions are rare. If a person has a history of allergies, especially with the first dose, then when they get the second dose, they should be monitored. ITP mimicking autoimmune heparin-induced thrombocytopenia would be with the Janssen vaccine, and I think that is the vaccine that you probably have. And so what did we do for our patients? So 6 months later, so that is after the second dose. So when he came to us November, is down, prednisone down to 10, azathioprine 150. And we recommended he go ahead with the vaccine, and there's no flare this time. Okay, so remember, if you've had a patient with vaccine, that could be one of the causes of AST and ALT elevation. I don't know about reports from the Janssen vaccine, but those of you who are investigators would probably want to look at that. Let's see how we're doing for time. Okay, we probably have about 10 minutes more. So 69-year-old with autoimmune hepatitis and cirrhosis has an indeterminate liver mass. COPD, feels well, not thought to be a transplant candidate. Has been on azathioprine 50 and prednisone. Platelets are 35. ALT normal, bilirubin 1.6, INR 1.4, albumin 3.5, alpha-fetoprotein 8. Ultrasound shows an ill-defined 2 centimeter mass left lobe. MRI, ill-defined 2 centimeter enhancing mass, no clear washout. So this would be a LIRADS 4, meaning highly suspicious for malignancy, but not definite. So what would you advise now? Platelets 35, so would you advise to biopsy the mass? Or do you want to biopsy the mass and ablate at the same time? Or you just want to ablate? Just go ahead and ablate. Or would you say, look, I'm not sure it's a LIRADS 4. Let's repeat MRI in 3 months. So these are the things you will discuss with the patient. So think about what you would do. So we reviewed options with the patient. I personally thought we'd biopsy and ablate at the same time, saves the patient 2 procedures, but a little higher risk. The patient did not want the little higher risk and said, no, let me get the biopsy first. And if you're convinced that requires ablation, then we'll get an ablation later. I like to ablate because, biopsy may not always be representative, and a negative biopsy does not rule out malignancy. And typically LIRADS 4, I like to treat them in most cases as malignant. So what would you advise now? So patient wants to biopsy the mass, platelets are 35. So would you say, yeah, we'll go ahead and biopsy? Or would you say, no, the platelets are 35, so we'll use a thrombopag. So whatever you have available, you can use and then biopsy the mass? Or would you say, no, let me just use platelets because thrombopag will take 8 to 10 days for the platelets to go up. You just transfuse platelets and I'll biopsy the mass right away. Or would you say INR 1.4, platelets 35, so I want to be extra careful, so I'm going to transfuse platelets and then FFP and then biopsy mass? Or you say 69-year-old COPD, I don't want to overload them with volume, so I won't give them FFP, so I'll just transfuse platelets and then give vitamin K. and then biopsy the mass. So what would you do? So let's go over hemostasis in cirrhosis. Again, PT, APTT, and platelets do not adequately capture hemostatic changes. TEG, and I know Shalimar has done some good studies at AIMS, and thrombin generation of viscoelastic tests such as TEG have been used. They are a more global assessment of hemostasis, but have yet to be validated for use in patients with cirrhosis, meaning we do not know what the transfusion cutoffs are. So for instance, platelets, if you want to use platelets in this patient, would you say maximum amplitude 30 and below, I'm going to use platelets, or would you say 40 or 50, or is it 15? Those are yet unknown. And if you have any further information on this, please do let me know. So essentially, I don't think there's a good test to measure whether clotting is adequate or inadequate in patients with cirrhosis. So how do you assess bleeding risk in patients with cirrhosis? Remember, there are procedural and technical factors. So is this a high-risk procedure versus low risk? How good is your person going to do the procedure? So liver factors besides, the clotting factors, if they have advanced portal hypertension, they're more likely to bleed in the abdomen. If there's inflammation, they're more likely to bleed. If they've got acute and chronic liver failure, again, they're more likely to bleed. Then there are systemic factors. Renal failure. I'm always more worried about renal failure than prothrombin time of platelets. Infection. Patients with systemic sepsis, much more likely to bleed. If they've had antithrombotic drugs before, again, more likely to bleed. So this is from the AASLD guideline on vascular diseases. And I want you to focus here on high-risk procedures. For our patient, we're thinking of a liver biopsy and tumor ablation. And what is a high-risk procedure? If bleeding is expected in greater than 1.5% of procedures. But any bleeding in the eye or spinal cord or in the brain is also considered high-risk procedure, even small amount of bleeding. What we know about platelets and bleeding risk? So generally, patients don't bleed if the platelet count is above 30,000. And even those who bleed when the platelet count is below 30,000 are probably related to portal hypertension. So that means platelets are a marker of severity of portal hypertension as opposed to being independently associated with bleeding for a certain degree of portal hypertension. Okay, so they bleed probably not because of low platelets, but because of portal hypertension. So if you want to improve platelet count pre-procedure, what are the options? You can transfuse platelets. Platelet count may increase, but it may cause bleeding by increasing intravascular volume. You can use the thrombopoietin receptor agonists. So in the US, we have avatrombopag and lucitrombopag. So they require 2, 8, 10 days for the platelets to come to where you want them. That's over 50,000. But these improve platelet count, but we really don't have any indication that they decrease the risk of bleeding. So there are no studies done for that. You just feel better that the platelets are elevated. And there's a small risk of portal vein thrombosis. So may not be that attractive an option. You can release endothelial von Willebrand factor with DDAVP, and these are as effective as platelets and FFP transfusions. What about the procoagulant deficiency? So we talked about platelets. Can you target procoagulant deficiency? FFP, remember we talked about volume. There's a risk of lung injury, increase in portal pressure, and there's really no clear effect on reduction in bleeding. Vitamin K, when the liver disease is bad, vitamin K does not really help that much. So there's a limited effect on INR. Vitamin K helps only if there's an absorption problem. Recombinant 7A, it can normalize the INR, studied in varicose bleeding and was no benefit, and there's an increased risk of thrombosis. Fibrinogen levels below 100 are associated with bleeding. Lowest levels are seen in critically ill patients. You can use cryo and fibrinogen replacement, but again, it's not clear whether they decrease bleeding risk. So you're going to biopsy this mass. You've talked to the patients, and now what you're going to do. Are you going to biopsy the mass? Going to use thrombopag, platelets in FFP, or platelets in vitamin K. So I've discussed the different options, and now you finally have a choice what you're going to do. So this is again from the practice guideline. These are recommendations from different professional societies, and you can see that they're quite variable. The AASLD, which is from this paper, the Society for Interventional Radiology, AGA, and American College of Gastroenterology. So AASLD says no platelet correction, no INR correction, no fibrinogen correction, okay? So you could probably go ahead and biopsy. The problem is that the radiologists tend to follow this guidance, and you may not get a radiologist willing to biopsy. Let's take the last case. A patient with PBC and cirrhosis, ascites, non-bleeding large esophageal varices on carvedilol. Diagnosed with PVT based on ultrasound and Doppler, was started on apixaban. Feels well, looks well. Platelets 85, bilirubin 1.2, albumin 3.7. So generally, patient looks well. Ultrasound done as follow-up, no mass. You can see a non-occlusive portal vein thrombus. Patient has no ascites. So what do you want to do now? So there was a PVT, but it looks like PVT is still present at the end of 6 months. Patient is on apixaban. So do you want to continue apixaban and follow up in another 6 months? Do you want to change to warfarin? Or do you want to change to heparin? Or do you want to say, I'm not sure what this non-occlusive mass is. I want to make sure there's no tumor, so I'm going to get a CT or an MRI. So we decided on a CT. So this is the previous CT, little thrombus here, right portal vein thrombus. But now you can see expanded vein, central lucency. You can see the rim here, probably going to be extending into the superior mesenteric vein. So the clot, in fact, is probably increased. See, the spleen has gotten a little bigger, some ascites too. So no clinically detectable ascites. You've got a thrombus. Not doing well, probably extension of the thrombus. So what will you advise now? Continue apixaban, change to warfarin, change to low molecular weight heparin, or get an MRI, look for tumor. So we're not really clear here based on guidelines. I was involved in writing the guidelines for the American College, and we decided against apixaban, and we thought warfarin was a better drug for these patients. There's only limited sort of evidence and on retrospective studies on 10A inhibitors. Warfarin, there's a lot more experience. So we had recommended warfarin because we are monitoring these patients. We probably get a little better idea about whether it's working or not. With the apixaban, there's no regular monitoring, and we may miss. Low molecular weight heparin It's a good idea, but patients really don't like it. It's very expensive and getting shots every day. They tend to get ecchymosis wherever they're given the shots, and they don't like that at all. So this patient we shifted to warfarin. So just a few slides to summarize portal vein thrombosis and cirrhosis. If the ultrasound shows portal vein thrombosis, you do a CT MRI, and that's to rule out hepatocellular carcinoma. If this is an acute portal vein thrombosis, you get a thrombophilia screen. If thrombophilia is present, you're going to use long-term anticoagulation. If there's no thrombophilia, but the patient is a transplant candidate, we'll anticoagulate indefinitely. Not a transplant candidate, we'll anticoagulate for 6 to 12 months. Important, do an endoscopy for varices. And if they're large varices, then you put them in beta blockers. I don't like endoscopic variceal ligation in these patients. If the varices are not large, then you can repeat endoscopy in 1 to 2 years. If it's chronic portal vein thrombosis in a patient with cirrhosis, CETPA, remember thrombophilia and clotting in cirrhosis is related to advanced liver disease. So if they're CETPA well compensated, they may have a thrombophilia. So if you find a thrombophilia, then that's long-term anticoagulation. If there's no thrombophilia, you can monitor. So chronic portal vein thrombosis in cirrhosis, you may monitor them. You will do an endoscopy for varices. If they're large varices, good beta blockers. If there are no varices, repeat endoscopy in 1 to 2 years. In some transplant centers, if patients have got a portal vein thrombosis and no thrombophilia, they may anticoagulate to transplant, stating that the results with transplant are better. So it's not finalized. We don't routinely anticoagulate these patients. In general, acute portal vein thrombosis management without cirrhosis, patient presents with abdominal pain, inflammation, and thrombophilia. We'll do a CT scan to confirm portal vein thrombosis. You look for local and systemic causes. Start low molecular weight heparin first, maybe antibiotics, and you treat the underlying cause. Patient has continued abdominal pain or peritonitis or gastrointestinal bleeding, that clot is progressing. You may want to get a surgeon involved here. Not saying you have to do surgery, but you need to get a surgical opinion here. On the other hand, you started heparin and patient is doing better. Then you anticoagulate for 6 to 12 months. If they have a thrombophilia, then you anticoagulate them indefinitely. If there's chronic portal vein thrombosis, you'll do an endoscopy to screen for esophageal varices. You'll do a thrombophilia screen. When large varices, you're beta blocking them. If you don't have large varices, you'll repeat endoscopy in 1 to 3 years' time. Thrombophilia screen shows you that the thrombophilia is present. Indefinite anticoagulation. No thrombophilia. But from the history, you note that previously the patient may have had an intestinal ischemia that clearly had an acute portal vein thrombosis previously. In such patients, even if we have not detected a thrombophilia, we would anticoagulate indefinitely. Whereas if they've got chronic portal vein thrombosis, nothing for intestinal ischemia, just incidentally found, we do not anticoagulate those patients. So we will monitor. So I hope you have some take-home points. Type 1 diabetes and type 2 diabetes, what are the liver complications? Remember obstructive sleep apnea. Remember COVID vaccines. And remember clotting and bleeding in patients with cirrhosis. Okay, thank you.
Thank you. Great talk and very interesting cases also. Professor Kamath is not here with us because it's early, very early morning there. But can I request the panel to take up some of the questions which have come in the chat box? One is the recent confusion about relabeling NASH and MASH. And another question is someone with routinely elevated AST and ALT, and someone who's been investigated for GERD and F2 fibrosis score. So what next? Do we investigate or leave this patient alone? Can we have the panel?
I think we should request Dr. Sareen to look at the nomenclature problem of, in recent Journal of Hepatology, there's a couple of nice articles. I don't know what Professor Sareen says.
It's a very burning issue. The problem is mild to moderate alcohol. Should that be part of MAFLD or not? Besides that, most people now are turning towards the MAFLD. But having NASH and MASH is a challenge because both will require biopsy. While MAFLD, in simple terms, does not require a biopsy and includes both diabetics as well as overweight. In the recent classification of obesity, which is, sorry, not part of this, is just in one line, is a lean or normal, metabolically healthy, lean and normal, metabolically unhealthy. Obese, metabolically healthy, obese, metabolically unhealthy. So these are the new things which have come up. Rest I will leave to the moderators to answer very interesting questions.
Any comments from the moderators? Dr. Saraswat and Dr.
I think
Ramesh.
the presentation that Professor Patrick Kamath has made, I don't think we should be making any comments. We should simply be enjoying the wonderful cases, the systematic analysis, and the unusual issues that he raised in what are run-of-the-mill patients. Obesity, diabetics with the raised ALT is not an uncommon problem, and the way it was discussed and analyzed, and relatively new entities, at least many of them are not very well known to many of us, about diabetic hepatosclerosis, glycogen hepatopathy, glycogenic hepatopathy, etc. I think these were wonderful learning experiences right throughout.
Dr. Setubabu. Yeah.
So one entity I was looking is, incidentally detected portal vein thrombosis. Our patient is asymptomatic. Then you are really stuck. Should we really give him oral or when did he start actually the thrombus? Because it gets fast recanalization as well. So I was actually thinking apixaban probably is a better alternative rather than suddenly giving them high dose anticoagulants or low molecular heparin. I don't know. Do you have something like asymptomatic portal vein thrombosis?
Any comments from the moderators on this?
I mean, I think the anticoagulation is best done within 4 to 6 weeks of known acute thrombosis. And if a patient just asymptomatically, incidentally is discovered, if there is any evidence of chronicity in the form of collateralization or the net collaterals appearing, then obviously it is too late to consider anticoagulation in this situation. So I think incidental discovery of without collaterals, there would be no evidence to support your decision to use anticoagulation in this situation. So I would probably not be too keen on that.
I think, yeah, Gian, yeah, go ahead.
Yeah, I thought you can actually broadly divide them into two categories. Of course, one is where you know the history and you can date the portal vein thrombosis. So even if the patient is asymptomatic, but it's a recent onset, I think there would be probably a role for anticoagulation, or a chronic portal vein thrombosis where the patient is still symptomatic. I think there would be a role for anticoagulation. And of course, apixaban would be something which is much more simpler to handle. But if despite apixaban, as Patrick mentioned, a patient continues to be symptomatic, then probably we'll have to go in for monitored anticoagulation. My comment, of course, is with respect to the liver complications occurring in diabetes. We have been told about a totally new picture. I was wondering if I could get more information on whether there is a difference in implication. Now, if you have a patient, very often we do get consultations from diabetologists, endocrinologists, diabetes with abnormal liver functions. Now, we usually push them under the carpet of non-alcoholic fatty liver disease, or NASH, or as you would call it. But with this hepatosclerosis and glycogenic hepatopathy, it adds a totally new dimension. But my question is there an implication in giving this particular label? Is there a different implication? Maybe Dr. Sareen or Vivek, if you could just take that up.
Well, I don't know about the implication, but you'd basically want to identify any treatable, reversible factors. I think the OSA bit we've overlooked here. The OSA also was mentioned clearly, and if the person is hypoxemic, and correction using CPAP, correction the OSA improves the transaminases, that is a correctable factor that should not be overlooked. I don't think for the sclerosis, hepatosclerosis, or for the glycogen hepatopathy, there is any specific manifestation. I mean, for glycogenic hepatopathy, tight control of sugars and diabetes in the type 1 diabetic was what was apparent, and that is a general dictum you would follow in any case. So
thank you. I have to now thank all the moderators because we are running behind time on the next session. Thank you everyone for being with us, and have a great evening. So we move on now to the next session, which is India at the AASLD. So many of our investigators have been going to the liver meeting. They have been presenting, and we have about 11 outstanding papers here up for discussion. And to moderate this session will be Dr. Abraham Koshi from the Lakeshore Hospital. He is the head of the department there. We have Dr. Gayatri Ramakrishnan, who's from the ILBS, and Dr. Rajiv Khanna, Associate Professor of Hepatology, Pediatric Hepatology from the ILBS. So may I request the presenters to stick to the time of 6 minutes so that there is a 2-minute discussion window. So the first presenter I call upon is Dr. Nipul Verma, who is associated with the ILBS as an associate professor. So, he's from PGI Chandigarh. I'm very sorry. So let's have the first presentation, please.
At the outset, I would like to thank our consortium, Professor Sareen, and organizers for giving me this opportunity to present the topic on AASLD Research Consortium Artificial Intelligence-Based Model in precisely predicting outcomes in ACLF patients. ACLF is a distinct syndrome with high short-term mortality by any definition we use. It's a dynamic syndrome where the final grade of ACLF defines the outcomes. AASLD-defined ACLF constitutes 25% of all incident ACLFs in the United States. Precise prediction of outcomes is important for all stakeholders in the healthcare, including clinicians, patients, policymakers, and administrators. Existing standards, that is MELT and ARC model, are inaccurate in up to 20 to 40% of patients. Artificial intelligence-based models are more precise and can handle complex and multidimensional data. Therefore, we aim to develop a precise AI model to predict mortality and compare its performance with existing standards in AASLD patients. We recruited an anonymized cohort of ACLF patients from our consortium aged more than 18 years between 2009 to 2020 across 50 Asian medical centers and followed them for 90 days. We excluded patients with prior decompensation, pregnancy, acute liver failure, liver transplantation, experimental therapies, hepatocellular carcinoma, and other malignancies. Data was collected at day 0, 4, 7, 14, 30, and 90 days, and that included demographic, clinical, laboratory, medication, severity, and outcomes-related data. Data validation was done as appropriate. Patients were managed as per APASL guidelines and all had an access to ICU care. ML modeling was done as per standard MI claim criteria where the target variable was 7, 30 or 90-day mortality with 30-day mortality as a primary objective, and predictors were clinical data. Briefly, the pipeline involved the data preparation phase where error rectification, trimming, outlier detection, and missing data treatment was done, followed by a feature engineering and selection phase where data was improved by using domain expertise and separate set for severity scores, correlations was done, decomposition of variables into categories of interest, and finally application of Baruta algorithm for selection of variables. Data was further split into training and validation set into 16 to 40 ratio, and various AI models were developed, including extreme gradient boost, random forest, deep learning, that is artificial neural networks, naive-based decision trees, fast large margin, and support vector machine, including MELD and ARC model. Further, the models were internally validated using 10-fold cross-validation and 3-time repetition, and optimization using hyperparameter tuning with grid search for hyperparameters, which was done in RStudio. Different models' performance was compared based on AUC, accuracy, sensitivity, specificity, and class precision. Out of these, the best model was selected based on the AUC and accuracy values. Finally, the selected model underwent model interpretation using feature importance and shapely additive explanations. And finally, we developed a simple decision tree and web-based model for easy application at bedside. Coming to results, out of 3,624 patients, we included 2,481 patients after necessary exclusions. Baseline data was compared between train and validation set, and most patients were of age 45 years, with 15% being females and alcohol as a dominant etiology of ACLF. Survivors and non-survivors were compared, and amongst non-survivors, there were higher grades of ascites, sepsis, organ failures, severity scores, ammonia, creatinine, HVPG, jaundice to ascites duration, lactate, and prothrombin time, while non-survivors also had a lower hemoglobin, bicarbonate, mean arterial pressures, platelet, albumin, beta blocker use, and viral hepatitis as an etiology of cirrhosis. Amongst the feature selection phase, we reduced from 146 variables to 65 variables after using domain expertise as well as Baruta algorithm. Comparisons of different models were done, and we found that extreme gradient boost cross-validated model had the highest AUC and accuracy parameters. As compared to MELD score, it was better than 12.8% and ARC model by 7% for 30-day mortality prediction. Likewise, for 90-day mortality prediction, this extreme gradient boost model was 14.5% better, and as compared to ARC model, it was 5.2% better. Similarly, for 7-day mortality predictions as well, this extreme gradient boost model was better than MELD score by 15% and by ARC model by 6%. Models calibrations for all time points, 30-day, 90-day, and 7-day was very good. And when we classified patients based on high risk or low risk based on AI and existing standard, that is ARC model, we found that AI-based predictions were significantly superior compared to the ARC models. Finally, based on the model interpretation, variable importance, and Shapley additive plots, we found top 10 variables making the model's outcome, which included day 7 variables such as creatinine, INR, circulatory failure, leukocyte count, platelet, sodium, and grade of HE, and day 4 variables such as sepsis, platelet, and HE grade. These were the variables which were significantly important for making the artificial intelligence-based model, which is the extreme gradient boost. Finally, we derived using top 3 variables a decision tree for simple application at bedside, where day 7 creatinine of more than 1.5 and with a circulatory failure were deemed high risk for mortality. And whereas day 7 creatinine of less than 1.5 with an INR of less than 3.1 was deemed low risk. and in between was an intermediate risk with a 60% mortality. Using top 10 variables, we derived an RKI model using refitting of these variables using multiple generalized linear models as well as random forest and extreme gradient boost models. We found that GLM model had a significantly better AUC compared to existing standard, that is MELD and the ARC score. And looking at the exact numbers also, the patients actually predicting alive was significantly superior by ARC model as compared to other models, and the variables was significantly better with RKI model. Finally, we deployed this AI model using web-based RShiny application where just a simple input can be done using handheld device and outcomes can be predicted in real time. Finally, this was the first study of AI and ML models in ACLF patients from Asia Pacific region. ML models were more precise than existing standards. Simple decision tree can guide referral to liver transplant centers. Web-based AI model can guide management of ACLF patients in real time. Standard methodology, that is MI claim criteria, was used for modeling, and it was based on fairness and reliability. Attempts were done to overcome the black box nature of ML models through model interpretation and its utility. Good external validity for APASL defined ACLF patients because of wide number of patients from 15 Asia medical centers. Weaknesses may include errors from database studies. AI models are computationally expensive. Certain unaccounted variables such as treatment response, genetic predisposition, and biological status was not incorporated into modeling. Ethical concerns still remain for artificial intelligence-based modeling, needs further validation and optimization, and multi-centric cross-industry collaborations are warranted for effectively deploying the AI models. Finally, concluding that the performance of ARC-AI model exceeds the existing standards for outcome predictions in ACLF. An AI-based decision tree can reliably undertake severity-based stratification of patients for timely interventions. Thank you.
Thank you, Dr. Nipun. And since we are running behind schedule now on this particular talk, I can just probably have one comment from any of the moderators on this talk, and then we go on to the next talk.
No, it's an excellent study. I would just like you to reiterate in the handheld model, what are the parameters that you are putting in INR along with that?
Thank you, sir, for the question. The basic parameters include the creatinine, INR, the circulatory failure, the leukocyte count, and the sepsis.
For the handheld model?
Yes. And grade of HE also. These are the major things which are required for prediction.
Thank you, Dr. Nipun, for clarifying an excellent study. Now we move on to the next research paper, which was presented by Dr. Rakhi Maiwal. And I have already said in the morning, she's a very dynamic researcher associated with the ILBS along with Dr. Sareen. And may I have her present her data, please? Dr. Maiwal.
And I would like to thank the organizers for giving me an opportunity to talk about our work titled Severity of Liver Failure and Renal Biomarkers, Predict Early Present Non-Response and Dialysis in Patients with Acute and Chronic Liver Failure. So I have no disclosures and no conflict of interest. Now we know that liver failure drives AKI in patients with acute and chronic liver failure, and it is the most frequent extrahepatic organ which is involved secondary to the severe systemic inflammatory response syndrome, which determines both survival and AKI development and progression. And these patients have higher incidence of structural AKI and poor response to vasoconstrictors and rapid AKI progression. So there is a need of biomarkers, and cystatin C is a well-studied marker of glomerular function, while urine NGAL is a marker which is established for determination of tubular injury. However, there are no studies in patients with acute and chronic liver failure evaluating the role of kidney biomarkers in predicting the early present non-response and dialysis. So investigated in a large cohort of acute and chronic liver failure patients, the role of cystatin C and urine NGAL in predicting early present non-response, dialysis, and 28-day mortality. So this was a prospective cohort of patients enrolled from February 2015 to February 2019, and patients with ACLF with or without AKI were followed until death or liver transplant. And the patients were included and defined according to the Asian Pacific Association for the Study of Liver Disease. We excluded all the pediatric and organ transplant patients, patients who had HIV, patients with severe extrahepatic diseases, who had contraindications to terlipressin or were treated with artificial liver support, pregnant patients, patients with malignancies or acute or subacute liver failure, obstructive uropathy, and patients who were having CKD or were extremely moribund at presentation. The cystatin C and urine NGAL was done using a nephelometry, and NGAL was done using spectroscopy. And we used the standard guidelines for defining HRS, AKI, pre-renal and acute tubular necrosis. We calculated the ARC score, which was a composite score of 5 variables, that is a bilirubin, INR, creatinine, hepatic encephalopathy, and arterial lactate, and graded it into 3 grades based on the ARC grade 1 with a score of 5 to 7, 8 to 10 as ARC grade 2, and 11 to 15 as our grade 3. We defined HRS, AKI, terlipressin response, and dialysis was done for standard indications. The response was defined based on the response to AKI according to the International Club of Ascites. We performed the binary logistic regression for predictors of terlipressin non-response and did a survival analysis using a Cox proportion regression, and used the Kaplan-Meier survival curves, and also used a classification tree approach for use for risk stratification of patients based on urine NGAL and cystatin C. So a total of 1,452 patients, of which 1,212 were excluded. And finally, 240 patients were included, of which 46% had AKI at enrollment. 1/3 of these patients required dialysis, and another third had died by 28 days. So these were all middle-aged males, predominantly alcoholics. And we can see here these patients had high MELD and SOFA score. Almost 4% had diabetes and 15% had diabetes. Hypertension and diabetes was present. SIRS and sepsis was present in almost more than 2/3 of the patients, and majority had clinical ascites. Now we can see here 45% of these patients had AKI due to HRS, 18% had ATN, and volume response of AKI was seen in 37%. Majority of, again, these patients had stage 2 or 3 AKI. Cystatin C was high. Mean levels were 2.04, and urine NGAL levels were 376 in these patients. Now we can see here 240 patients, of which 50 had HRS, of which 29 had non-response, and majority of non-responders required dialysis, while 13 of the 20 patients with ATN, 11 of the 41 in the pre-renal group, and in the no AKI, 27 patients, so a total of 78 patients had required dialysis by 28 days. The response to terlipressin, as has been seen in previous studies, we found that it was associated with higher 20-day a better survival, and patients who were non-responders had worse outcomes. And we can see here that there was a direct and a positive correlation between the urine NGAL and cystatin C. And therefore, they were separately considered in different multivariate models. For predictors of terlipressin non-response on univariate analysis, on multivariate analysis, we found that in separate models, NGAL along with ARC score were identified as independent predictors. And so was for patients with dialysis in the model 1, NGAL and low bicarbonate, and in the model 2, cystatin C was identified as a significant predictor. When we graded these patients based on the ARC grade, we found that patients with ARC grade 3 had the highest incidence of terlipressin non-response and requirement of dialysis. The biomarkers had a good area under the ROC with a cutoff cystatin of 2.5 and an NGAL above 907, which predicted also mortality, as can be seen here in the curves, and which were also also identified as independent predictors on survival analysis, along with the ARC and the SOFA score. When we did a classification tree approach, we found that we can stratify in 2 steps based on the urine NGAL above 900 and an ARC grade 3 with 70% accuracy of patients who would require dialysis and will fail terlipressin therapy. And for cystatin C in step 1, we can see a level above 2.5 in our grade 3, and 78% of the times we are accurate in identifying the non-responders and who would require dialysis. So AKI is very frequent, and kidney markers can accurately predict the non-response to terlipressin and the need of dialysis and 28-day mortality with a good area under the ROC and the cutoffs that we showed here. However, the limitations of a study is a small sample size, and we started only 2 biomarkers, and these were performed only once. And I would like to thank you for your very kind attention.
Thank you.
Thank you, Dr. Maiwal. Can we have comments from the moderators on this study or any questions? She is online. Dr. Raki is online.
Good,
and thank you for keeping it in time, Dr. Raki.
Good study. What do you think its clinical application will be?
So the clinical application would be like we have to stratify which patients would require artificial liver support. I feel that is the main challenge when we are managing AKI, because the response to terlipressin is very poor.
You mean earlier dialysis?
35%. So early artificial liver support, which will include either a plasma exchange or maybe
you mean
a
they
dialysis.
Should go into a trial for liver support?
Yes, sir.
Any more questions or any more queries to the investigator from the moderators? I think that was excellent, and I'm sure that a lot of clinical applications will come out of this study. Thank you, Dr. Maiwal, for your time. And now we have to move on to the next presentation, which will be by Dr. Madhumita Premkumar, who is an assistant professor of hepatology and a super specialty teacher. So let us get on with her talk, please.
Hello, my name is Dr. Madhumita Premkumar. I'm an associate professor of hepatology at the Postgraduate Institute of Medical Education and Research, Chandigarh, India. I'm here to present the interim analysis of our work, the point of care echocardiography with IVC dynamics, lactate clearance, and novel biomarkers like NT-proBNP are best predictors of hemodynamic status, diastolic dysfunction, response to fluids, and outcomes in cirrhosis with shock. I have no relevant disclosures, and the project is supported by an ICMR research grant. We have started using point-of-care echocardiography to determine diastolic dysfunction in patients, and we have found that use of IVC dynamics is a better method to assess response to fluids and vasopressors in our intensive care unit. And we prospectively evaluated the use of POC echocardiographic data and IVC dynamics in patients with cirrhosis with shock, and we correlated it with conventional tools like central venous pressure, lactate clearance, and we also assessed the utility of cardiac biomarkers to assess hemodynamics in critically ill patients with cirrhosis. Usually, we used CVP and NT-proBNP as markers, but now we find IVC dynamics and novel biomarkers are much better predictors of response and outcomes. Consecutive patients who were admitted to our intensive care unit were screened by 2D echocardiography with tissue Doppler imaging to assess LVDD, stroke volume, cardiac output, and IVC indices. The IVC collapsibility indices, that is, the percentage difference between the maximum and minimum IVC diameters expressed as IVC max minus IVC min divided by the IVC max into 100, were measured every 6 hours till we had fluid resuscitated patients, and we also used it to titrate vasopressors and achieve hemodynamic stability. We used the following cardiac biomarkers, including galectin-3, troponin I, NT-proBNP, aldosterone, epinephrine, and plasma renin activity. The POC algorithm in our ICU uses the parasternal long axis view and short axis view, which gives us the LV, LA, the RVOT and the LV outflow track. We also looked at the contractility of the left ventricle, thereafter switching to an apical 4-chamber view and then to a subcostal view to get the IVC dynamics. And this was found to be a much better predictor. Very briefly, the apical 4-chamber view is used to see the end diastolic and end systolic volumes, and we also assess the VTI in the apical 4-chamber view. And the primary outcome measures of our protocol were to assess the methods of determining whether the patient was volume resuscitated. This meant we looked at the achievement of an IVC diameter more than equal to 18 millimeters and an IVC collapsibility index of less than 40% with achievement of a mean arterial pressure of more than 65 millimeters of mercury after fluids or with vasopressors. The secondary outcome measures were to look at the need for inotropic support, the incidence of AKI, new organ dysfunction, and the total duration of hospital stay. Of 88 patients with shock, we finally recruited 45 patients who met our criteria because 40 of them were already on vasopressors, and we did the POC echo and assessed their outcomes. The echocardiography was performed at admission 6 hours, 24 hours and 7 days later, and we looked at the time to recovery from shock, incidence of AKI, survival, and the utility of biomarkers. The survival in our cohort was about 40%. The mean CVP measured was 12.8 and the mean IVC collapsibility index was around 34% in patients with shock, which means that most of them already had received fluids elsewhere. The mean IVC diameter correlated best with lactate clearance but did not correlate with the CVP. So it appears that the dynamics of resuscitation and tissue perfusion were better correlated with IVC dynamics and lactate. A negative linear correlation was observed between the CVP and the collapsibility index. That means the higher the CVP, the lower would be the collapsibility index. An IVC diameter which was less than 1.4 centimeters predicted a CVP of less than 10 millimeters of mercury and indicated the need for further volume resuscitation, whereas an IVC collapsibility of less than 20% needed the indication for use of vasopressors rather than giving additional fluids. So the response to fluid challenge was then noted by serial increase in the cardiac output and stroke volume. Although our numbers are small, this table actually shows the variation in the collapsibility and size in patients who were grouped with a CVP less than 8, 8 to 12 dubbed as euvolemic, and more than 12 that is already having adequate volume resuscitation. And we found a very good correlation of the collapsibility with actual outcomes of attaining resuscitation. The scatter plot shows the association between the CVP and the collapsibility index in patients with shock, which shows a negative correlation. Then also in patients in diastolic dysfunction. Remarkably, even patients with diastolic dysfunction could be assessed better with IVC collapsibility. Even in patients with ascites, albeit there was a slight dampening, there was a correlation observed between CVP and IVC collapsibility. Again, when we look at the IVC expiratory and inspiratory with the CVP, again we found a reasonable correlation for judging hemodynamic status. One of the outcomes was to look at the echocardiographic parameters as a function of the outcome. So in patients who did not survive, we notice a higher CVP, which means that they had already been resuscitated to some extent, perhaps elsewhere, but they also had a higher collapsibility index, which meant that they required more of resuscitation and early use of vasopressors. When we look at their cardiac output, they were already in a hyperdynamic state at presentation, but they were unable to sustain a higher cardiac output at 24 hours. This suggests the presence of LV diastolic dysfunction also had some effect on mortality. Briefly looking at the neurohormonal activation, patients who did not survive had a higher aldosterone level and a higher plasma renin activity level, suggesting activation of the renin-angiotensin aldosterone system. On multivariate analysis, the presence of hepatic encephalopathy in patients with shock was a strong predictor of mortality. Also, an elevated serum lactate was a predictor of mortality, And grade 2 diastolic dysfunction was also an independent predictor of mortality in patients with shock. In conclusion, the ultrasound measurement of the IVC diameter and its collapsibility provides a rapid point-of-care non-invasive test for volume status assessment and can impact bedside clinical decision-making regarding the use of more fluids versus the use of vasopressors. Endpoints like the collapsibility index and lactate clearance are better targets to guide fluids and vasopressors than conventional CVP targets. So it would be better to assess patients with shock with the ultrasound probe rather than worrying about getting a central line in. A point of care echo also gives predictions for outcomes like HRS, recovery from shock, and overall survival. The role of LV diastolic dysfunction and cardiac biomarkers needs further evaluation in patients with cirrhosis and shock, and we will be able to provide this information after the study is completed. I will be happy to take any questions, and you may contact me at the following email address. Thank you.
Thank you, Professor Madhumita. Any questions or any comments on this paper from the moderators?
Yes, ultrasound, you have done 1 point estimation, but to manage a patient, you will need continuous information. You know, as you give fluids or as you give vasopressors, you will need more information. So how frequently will you need to do a test like this, which requires specialized expertise?
She's not available. Do not think that she's online, but we'll forward that question to her. In any case, now we are short of time, so we have to move on to the next presenter. And may I call on Dr. Moinak Sen Sharma, who is an associate professor in the Department of Pediatric Gastroenterology at the SGPGIMS Lucknow, to present his work. Dr. Sharma.
Good morning. Can we predict survival of Wilson's disease using exchangeable copper? I am Dr. Moinak Sen Sharma from the Department of Pediatric Gastroenterology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, India. I have no conflicts of interest or potential financial disclosures. We know that copper is distributed in our body with various proteins. Transcriptine and ceruloplasmin-bound copper are non-chelatable and are heavy particles. Since ceruloplasmin is deficient in Wilson's disease, the copper is preferentially but loosely bound to albumin, peptides, and amino acids. This copper is labile and easily exchanged in various tissues. This is known as the exchangeable copper and is now thought to be the crux in the pathogenesis of Wilson's disease. Free copper, though ideal, is unsuitable for estimation. There are no gold standards for the diagnosis of Wilson's disease and the adequacy of chelation. All tests have various fallacies in the estimation and interpretation. Hence, can exchangeable copper and relative exchangeable copper, REC, be used as an alternative option? REC is the ratio of exchangeable copper to the total serum copper. A few studies in the past have shown that exchangeable copper can be used as a tool for diagnosis of neurological and hepatic Wilson's disease. In addition, it is thought that the exchangeable copper can also be used in predicting the severity of neurological Wilson's disease. However, there are no studies to date to show the impact on hepatic Wilson's disease. This is the first part of our paper that received the Best Abstract Award in the United European Gastroenterology Week 2020. We showed that 61 follow-up patients of Wilson's disease who were already on exchangeable copper for a very long time, that exchangeable copper had a favorable role to play in the assessment of and reduction of the copper load and liver stability. In the second part of our paper, we wanted to show whether exchangeable copper and relative exchangeable copper have any role in the diagnosis and prognosis of a fresh cohort of newly diagnosed pediatric Wilson's disease. This is an interim analysis and the ethical approval was sought. Newly diagnosed Wilson's disease were prospectively enrolled. Their exchangeable copper was assessed using a special filter paper that filtered out heavy copper and bound proteins that were more than 30,000 Daltons. We compared the cohort with the controls who were non-Wilsonian's disease, which were autoimmune liver disease, cryptogenic liver disease, Budd-Chiari syndrome, hepatitis B and C. Subset analysis was performed in the survivors and the non-survivors, responders and the non-responders, and those who showed an improvement of more than 50% in the PEL score were deemed as responders. Patients underwent clinical assessment, biochemistry, assessment of the copper status, severity of the liver score, and exchangeable copper estimation. 31 Wilson's disease and 20 controls were assessed. Age-matched controls had similarity in the liver disease. REC was significantly higher in Wilson's disease as compared to the controls. 50% of the patients were decompensated Wilson's disease and a third were compensated cirrhosis. Lowest exchangeable copper was seen in the compensated and the highest was seen in the acute liver failure groups. 83% of the Wilson's disease were responders and showed response in about 11 months. And these are the violent plots. And between the two groups, you can see that the responders and the non-responders, there was no difference in the exchangeable copper, REC, and the PEL score. However, in the survivors and the non-survivors, it was seen that the survivors had significantly lower exchangeable copper as compared to the non-survivors. In addition, exchangeable copper had a good correlation with the baseline NCC, which is the non-ceruloplasmin copper, and the PEL score. And using a multivariate analysis, predictors of survival were PEL score and exchangeable copper. Prediction of mortality, exchangeable copper of a cutoff level of 2.03 had an area under the curve of 84% with 87% sensitivity and 67% specificity. This is a predictive model, and if we use exchangeable copper in the armamentarium for the diagnosis of Wilson's disease, in addition to the routine investigation, it is seen that there is an advantage of approximately 25%. We use the Breyer score, and this model has an area under the curve of 83%. Hence, our conclusions are that exchangeable copper has a promising role in the diagnosis of Wilson's disease, and the baseline pre-chelation exchangeable copper is a new modality in the predicting the survival other than the PEL score. Pre-chelation exchangeable copper more than 2.03 may predict survival, and we understand that we need much better numbers and larger cohort to validate our findings. One of our major limitations is that we did not have the follow-up values of exchangeable copper to show in this paper. The values were processed later and hence could not be incorporated into the analysis of this abstract. Also, there was no objective way to assess compliance. We hope to look at serial exchangeable copper values later and also see the effects of various chelators and various Wilson's disease phenotypes. Thank you.
Thank you, Professor Sarma. So the panel, any questions to Professor Sarma on his talk or any comments?
Yeah, thanks, Dr. Moinak. Can you hear me?
Yes, sir.
Yeah, that was an excellent presentation. I have a short question. That was, have you done any comparison of relative exchangeable copper with the new Wilson index, which is actually a known predictor of mortality in Wilson disease? So was that comparison done? PALD, you have shown that PALD, it was related, slightly better than PALD, but what about new Wilson index?
No, sir, we've not formally done it, but that's a very good idea. We can incorporate easily into our paper. Only thing that, sir, I'm not sure about your experience, but sometimes we feel that the new Wilson's index does not give us the prognosis as well as the PEL score does. But obviously we can explore that area, sir, no doubt. Yes, sir.
So thank you very much. Great presentation. Dr. Koshi, you're saying
no, compliance is the most important, I think, in long-term follow-up as far as prognosis is concerned. But unfortunately, you have not really brought out that data.
Yes, yes. We are in the process of showing the rest of the compliance data. So the follow-up values we could not incorporate into this particular abstract.
Thank you very much. Thank you. Those are excellent papers. So we move on now to the next presentation, which is by Dr. Piyush Upadhyay, who's with the Pediatric Hepatology Unit at the ILBS. So, Dr. Upadhyay, please.
Honorable judges, I will be presenting my paper. Splenic stiffness is the best non-invasive significant varices in children with chronic liver disease. There is no conflict of interest. Disclosures are none. Now, prediction of varices is important as variceal bleed can result in up to 14% of mortality in children with chronic liver disease. Invasive procedures are the investigation of choice. However, non-invasive procedures like transient elastographic measurement of splenic and liver stiffness, laboratory indices and Doppler indices are the need of the hour. Because invasive procedures have various drawbacks, which includes limited experience in children, they are expensive, and there is risk of procedural complications. Hence, this study was conducted with this aim to study the role of splenic stiffness by transient elastography and portal hemodynamics to predict the presence of clinically significant varices in children with chronic liver disease. It was a prospective cohort study conducted in the Department of Pediatric Hepatology, ILBS, over a period of 2 years. It included children between 6 months to 18 years of age of chronic liver disease who underwent upper GI endoscopy. However, patients on endotherapy who were obese, or had grade 2 or more of ascites, had malignancy, were a status post-liver transplant, or shunt surgery were excluded. Now, although this was a pilot study, yet a sample size was calculated, assuming the sensitivity of splenic stiffness by transient elastography is 80%, specificity of 90%, alpha of 5%, permissible error is 10%, prevalence of clinically significant varices in children with chronic liver disease is 50%. Hence, we needed to screen 120 patients. Now, children with chronic liver disease who were less than 18 years of age were evaluated by baseline clinical, laboratory, and radiological evaluation, upper GI endoscopy for varices screening, transient elastographic measurement of splenic and liver stiffness of abdomen for portal hemodynamic parameters. Now, children were then classified as having or not having clinically significant varices, which was defined as esophageal varices of grade 2 or more, with or without gastric varices with stigmata. Now, splenic stiffness was measured in the 10th intercostal space in the left posterior axillary line, while liver stiffness was measured in the 10th intercostal space in the right mid-axillary line, as per the standard protocol. Now, at least 10 valid values with a success rate of more than 60% and with an IQR of less than 30% was deemed as successful. If no value was obtained after at least 10 shots, it was considered as failure, and at least 10 value and a median of at least 10 valid values was taken. The portal hemodynamic parameters included portal parameters, which included portal vein size, flow volume, velocity, direction, portal vein congestion index. Splenic vein size, flow volume, velocity, direction, splenic vein congestion index, ratio of spleen vein area to portal vein area, ratio of splenic vein flow volume to portal flow volume, splenic artery resistive and pulsatility index, hepatic artery resistive and pulsatility index, and liver vascular index. Coming on to the results, a total of 120 children of chronic liver disease were recruited. 14% of these children were bleeders. Now, etiological distribution was complete and reflective of the chronic liver disease etiological spectrum seen in these children. The splenic stiffness measurement and the liver stiffness were found to be significantly higher in children having clinically significant varices compared to those where it was absent. Now, among the portal hemodynamic parameters, spleen size on ultrasound, splenic Z-score, spleen vein is to portal vein area, splenic vein congestion index was significantly higher, while the splenic vein peak systolic velocity was significantly lower in children with having clinically significant varices compared to those where it was not found to be present. On logistic regression analysis, splenic stiffness was found to be the only independent predictor of clinically significant varices in children with chronic liver disease. This model improved prediction from 52.5% to 83.9%. Now, at a cutoff of 27.6 kilopascals with a sensitivity of 90.6% and with a specificity of 80.4% and a likelihood ratio of 4.6, splenic stiffness measurement by transient elastography predicted clinically significant varices with an excellent AUROC of 0.914. Whereas a cutoff of 37.8 kilopascals with a sensitivity of 88.2%, a specificity of 78.8%, and likelihood ratio of 4.1 predicted variceal bleed with an AUROC of 0.873. The strength of the current study is that this is the largest pediatric data on splenic stiffness measurement by transient elastography exclusively in children with chronic liver disease. While the limitation is that it's a single center study, and although it is the largest in the pediatric literature, still the sample size can be improved upon. Hence, I conclude that splenic stiffness measurement is the best non-invasive predictor of clinically significant varices in this cohort and can be used for decision-making for endoscopic screening of varices in children with chronic liver disease. Now, splenic stiffness measurement at a cutoff of 27.6 kilopascals predicts clinically significant varices, while at a cutoff of 37.8 kilopascals predicts variceal bleeds in children with chronic liver disease. Thank you so much.
Thank you, Dr. Upadhyay. Really very interesting, and it will save us so much time and effort if this really materializes into everyone's clinical practice. So can I have some comments from Dr. Setu Babu? Yes.
Do you actually need to measure splenic stiffness when you have enough data on liver stiffness alone, which again correlates with the severity of portal hypertension and the chances of bleed? Why do you want to make two sites, two measurements and give them? Because if you compare again FibroScan versus MRE, MRE scores much better and gives a much more better data in NASH.
Can you answer that? I don't think he's online right now. So maybe I think we could send him the question and find out more about this.
This group questions cannot be missed because, you know, these are the
I know, I understand.
Yes. No, it's okay. It happens. Even
I know.
Fine.
It would be nice to have the investigator here, but unfortunately he's not here.
No problem.
So I think we'll pass on the question, and then we'll move on now to the next presentation, which is by Dr. Anushka Saxena, who's a PhD and a research scholar at the ILBS. So can we have the talk, please?
Good afternoon, everyone. The title of my study is The Metabolome Profiling of Patients Infected with Hepatitis E virus Unravels the Role of Nicotinate and Nicotinamide Pathway and D-glutamine-glutamate Metabolism in the Development of Acute Liver Failure. So, hepatitis E virus was first identified in India in the year 1978. The virus is basically transmitted by the fecal-oral route. There are mainly 4 genotypes of the virus that infect humans: genotype 1, 2, 3, and 4. Out of these, genotype 1 and 2 are transmitted via the fecal-oral route. Genotype 3 and 4 have a zoonotic transmission. This figure shows the worldwide distribution of the different HEV genotypes. Hepatitis E virus infection appears in a subclinical form, that is self-clearing, self-resolving acute hepatitis, chronic hepatitis, which is mostly common with genotype 3, and fulminant hepatitis, which occurs during pregnancy. So, hepatitis E virus replicates primarily in the liver. However, studies have reported HEV replication in the placenta as well. It is due to this that maternal death is seen with fulminant hepatic failure. Also, fetal mortality is observed. Coming to the underlying mechanisms of acute liver failure, it could be the altered status of immunity, the hormonal factors and viral factors which may be related to the severity of the disease. However, other host factors such as metabolic adaptations that occur during pregnancy may also influence the severity of HEV infection in pregnant women. This table shows the various metabolic adaptations that occur on the maternal side, anabolic adaptations and the catabolic adaptations. The key question of the study was, does hepatitis E virus infection alter the overall host metabolome? Second key question was, are the metabolic changes playing a role in the pathology of HEV-induced acute liver failure? Aim of the study was to identify changes in metabolome associated with fulminant liver failure and self-clearing acute HEV infection during pregnancy. For this, 4 groups of patients and 1 group of healthy pregnant subjects was enrolled. Plasma was separated from the whole blood and it was subject to mass spectrometric based metabolomic profiling. When we performed a comparative analysis of pregnant females with acute HEV and HEV-ALF, it was distinct that in both the patient groups, the nicotinate and nicotinamide metabolic pathway was being induced. However, the level of enrichment progressively increased from healthy pregnant to acute HIV to HIV-ALF pregnant females. This answered the first key question of the study, that the hepatitis E virus infection alters the host metabolome by inducing nicotinate and nicotinamide metabolic pathway. So in the nicotinate-nicotinamide metabolic pathway, NAD plus serves as an enzyme cofactor which reduces to NADH and drives the various cell metabolic pathways. It is also used by the NAD plus dependent enzyme like the sirtuins. It is through these activities, NAD plus metabolism also regulates the inflammatory responses. NAD plus levels regulate T cell activation and also the differentiation of T cells into Th17 subset of T cells. It is due to these functions of T cell activation and differentiation into Th17 which could be responsible for the fatal outcomes during HIV-ALF in pregnancy. To address the second key question of the study, we compared the metabolomic profile of pregnant and non-pregnant females with ALF. We found that D-glutamine-glutamate metabolic pathway was downregulated in HIV-ALF pregnant women, which could be one of the critical reasons why mostly during pregnancy females are unable to clear the virus and progress to fulminant hepatic failure. So the schematic diagram illustrates glutamine and glutamate levels in the maternal and the fetal compartments and the exchange between the placenta and the fetal liver. It is already known that glutamate metabolism helps in activation of immune cells and also regulates the anti-inflammatory effects by the NF-kappa B pathway. Also, on the fetal side, it provides metabolic fuel source for rapidly dividing cells in placenta and fetal liver. Literature review shows that impaired glutamine metabolism is known to cause intrauterine growth restriction, embryonic loss, and fetal death during gestation. Thus, the conclusion of the study is that hepatitis E virus infection alters the host metabolome by inducing nicotinate-nicotinamide metabolic pathway, which in turn might be modulating the immune responses. Also, D-glutamine-glutamate metabolism is downregulated in HIV-ALF only during pregnancy, which is why females are unable to clear the virus. At last, I would like to acknowledge my Institute of Liver and Biliary Sciences, for letting me perform the experiments, the funding agency ICMR, patients for the consent, and my supervisors, Professor Shiv Kumar Serene, Dr. Nirupma Trihanpati, and Dr. Jaswinder Singh for the scientific inputs. Thank you.
Thank you, Dr. Anushka. And new window on an old problem. So thank you very much. I think Dr. Setu Babu has a question and maybe Dr. Koshi has a comment after that.
I think what happens to non-pregnant HepE? Does the same metabolic change occurs? Or again, their susceptibilities? Because is it a hepatitis E phenomenon or E plus pregnancy, or, at least pregnant people behave differently. So what's hepatitis E alone does in non-pregnant?
Sir, can I answer this question?
Yes.
So I'm Dr. Nirupama Trihanpati. So we have done the hepatitis C non-pregnant patients metabolomics also. And we found in another study that nicotinamide pathway is also upregulated in the even non-pregnant. However, we have not linked with the hormonal disbalances. So we yet to, but the HIV only controls the nicotinamide pathway. So that is with the non-pregnant and the pregnant both.
Now, do you find similar one with other hep virus also?
We
because it should be the same because
yes, we didn't do the analysis yet, but we are on to it.
You think you guess and predict that similar thing happens with, say, what, A hepatitis?
Sir, can't say, please.
Okay.
Yes.
I can understand.
Yeah.
I have a question. When you say metabolic profile, are you talking about the mRNA upregulation or downregulation in blood?
It's a metabolome, sir. It's a plasma profile of the metabolome.
Metabolome means you are measuring the proteins, or are you measuring the RNA?
Metabolites.
Okay. So you are doing some mass spectrometry.
Yes, mass spectrometry, metabolites.
Byproducts.
In blood. In blood.
In plasma. Yes, in blood, in plasma.
And Dr. Nirupma, were these HEVs genotyped?
These HEV were genotyped. Yes. It was
So which genotype it
1.
is?
It was genotype 1 and the genotype 3, both. The most of the
So
patients
do you
were
find any,
genotype 3.
So if you can deconvolute and see whether there is any distinct difference between the metabolites in both the genotypes?
Most of our patients were genotype 3, Dr. Gayatri.
Okay, thank you.
Yeah, so thank you, Dr. Anushka. That was a very eye-opening presentation. And now we have to move on to the next presenter, who is Dr. Sukriti Baweja, and she is an assistant professor at the ILBS New Delhi. So let us hear from her about her study.
A very good morning, ladies and gentlemen. Thank you so much for giving me an opportunity to present my work at Hot Topics at AASLD 2021. And I'll be presenting in India at AASLD 2021. So the study entitled Fecal Microbial Transplant Suppresses Hepatic and Systemic Inflammatory Responses and Gut Leakiness in Severe Alcoholic Hepatitis Patients. The study was conducted at Institute of Liver and Biliary Sciences, New Delhi, India. I have nothing to disclose. So fecal microbial transplant, as published by our group in 2017, showed a beneficial effect in terms of survival. And also we have shown that microbial changes helps in the better outcome of the patients with severe alcoholic hepatitis. But so far, we do not know what is the mechanism of fecal microbial transplant in terms of circulating, intrahepatic, and gut immune responses. So in the meanwhile, there are many studies which shows that immune responses plays a very significant role in alcoholic liver diseases, and the new invariant T cells, which are the new guardians of the liver cells, as shown by Sophie Lottestein group and Shilpa Choksi's group, they represent almost 1 to 10% of the peripheral blood lymphocytes and 20 to 40% of liver lymphocytes. And they recognize specifically the bacterial antigens. They secrete inflammatory cytokines, and they've already shown that mast cells actually link the intestinal immunity with antibacterial immune defects in alcoholic liver disease. So, depending on this, we aimed our study to investigate the alterations in T cell subsets, their function, and their association with gut-liver permeability before and after FMT and SAH patients. So for this study, we have enrolled 27 of severe alcoholic hepatitis patients, which were part of undergoing clinical trial under the mentorship of Professor Shiv Kumar Sareen, and 20 healthy controls, which were compared. And in severe alcoholic hepatitis patients, which were going FMT, the blood was collected before FMT and after FMT, day 7, whereas the repeat of liver biopsy and duodenal biopsy was done post-FMT. And in all these biological samples, we looked at mucosal invariant T cells, T helper cells, cytotoxic cells, B cells, neutrophils, and monocytes, and also looked at the histology and intestinal permeability markers. So this was the inclusion and exclusion criteria. The patients with sepsis, HIV, extrahepatic malignancy, on anticoagulants, pregnancy with no consent were excluded from the study. So the fecal microbial transplant was given by nasoduodenal tube for 7 days in histopathologically diagnosed SH patients. The patients were studied at the baseline before and after FMT and followed at day 7 and day 28, whereas peripheral blood mononuclear cells were isolated and enumerated using flow cytometry. Liver biopsy was taken at the time of transjugular liver biopsy, part of the protocol for inclusion into the FMT trial. So this is the baseline characteristics of severe alcoholic hepatitis patients with a MELT of median 24. Interestingly, what we have found is among all the T cell subsets and the lymphocytes, B cells, and CD8 and CD4 and CD25 positive cells, only the MATE cells were interestingly, after day 7 of post-FMT, were increased in the blood circulation. When we looked at the dimensional reduction plot, we found MATE cells exclusively won out at post-FMT. When we looked at the functional profile of MATE cells, we found they are functionally less inflammatory in nature, as we found insignificantly low level of IL-17. When we looked at MATE cells activation by CD25, we found their activation was lower after giving the FMT, as seen by CD25 and CD69 expression. When we looked at the MATE cells in the liver, we found that after the post-transplant or post-FMT, we found the MATE cells were significantly reduced, which shows that there is an egress of MATE cells in the circulation. When we looked at intestinal permeability by ZO1 and Claudin-1 expression after FMT, we found the increase in expression, which shows that there is an increased expression of tight junction proteins post-FMT in the intestine, which reseals the barrier function after 1 month of post-FMT. The inflammatory markers such as IL-17, IL-22, ROR, gamma, FOXP3, they all significantly reduced after FMT. The extracellular vesicles, which are the stress markers of the cells, we looked at EVs associated with B cells, T cells, hepatocytes, endothelial cells, and epithelial cells. And among all those EVs, we found epithelial cell EVs were significantly reduced after giving the FMT. So our study concludes that blood CD8 T cells and MATE T cells, which was severely depleted in severe alcoholic hepatitis patients, showed elevation after FMT. The activation was declined 50%, and the inflammation activity of the MATEs. The intrahepatic MATEs decreased after 1 month of FMT, which depicts the egress of MATE cells in the circulation. The gut permeability was reversed. So it provides a clear evidence that improvement in SAH patients after FMT by day 7, MATE cells may aid in antimicrobial activity in circulation and increases the overall mortality. Thank you so much for your attention.
Thank you, Dr. Baweja. And right away, I think Dr. Setu Babu has a question.
I'm surprised what happened to these healthy controls. Number one, healthy controls cannot be taken as controls because you need to have non-FMT patients. Could be a better comparison to prove your point rather than taking healthy controls, though you haven't described what happened to the healthy controls. I agree, the study is good, the biomarkers are good. I think you should have taken people who have alcoholic hepatitis and you did not do FMT and see what happened to them. Maybe I'm actually feeling that you'll get similar changes when they go into remission.
Yes, that is the reason I have not put the healthy group in this data, and I'm comparing only the pre and post FMT situation. But I agree with you, maybe we can use the standard medical therapy and then see what happens to the MATE cells. We do have the data and we can put it in the comparison here.
The caveat is don't mention healthy controls. You say that you have only 2 groups. Otherwise, what happens? Your study has a big flaw, and what you're hiding the data on healthy controls. Sorry about it. But I mean, it's a very good one. I'm very keenly following. Thank you very much.
Thank you, sir.
So that's a very nice presentation, and Dr. Sukriti, I just was wondering why there should be an egress of the MATE cells in view of the fact that actually the gut permeability is actually improving out.
Yeah, that's very, very valid point, Dr. Gayatri. The best part is I have already mentioned initially, the larger population of MATE cells resides in the liver. So we are speculating when the patient is improving, there is an egress of MATE cells which are less inflammatory and they are less activated and goes into the circulation and involved in recognition of the bacterial antigens. So that's a speculation.
Yeah.
Thank you.
Thank you, Dr. Baweja. And now we have to move on to the next presentation, which is by Dr. Ashok Kumar Chaudhary, who is again an associate professor at the ILBS. So let us have the presentation, please.
Very nice day. Thanks to the organizers for giving me opportunity to present my piece of work, that is neutrophil lymphocyte ratio NLR, to predict the severity and mortality of SARS-CoV infection among liver transplant recipients. This has been considered as a poster of distinction in AASLD 2021, and the work is from the AASL COVID task force under the APCOL study group, that is APASL COVID liver injury spectrum. So COVID-19, as we know, in solid organ transplant recipients has a chance to develop severe infection by virtue of being immunosuppressed. Presence of comorbidities as well as chronic immunosuppression has been shown to increase the risk of severe disease. And also recent study has shown that the SARS-CoV-2 infection in liver transplant patients has a high risk of acquiring the infection. However, phase studies has refuted this claim. Recently published multi-center data from US have suggested that liver transplant recipients had a prolonged hospitalization, higher mortality, increased risk of thrombosis, and they require more of intensive care than the non-LT patients when they have a COVID-19 as far as the concerned. So when this COVID-19 happened, so there is a spectrum of disease severity, and has been shown that liver injury in this group of patients is little bit on the higher side and is more common among younger age, Hispanics, those having metabolic syndrome, those are on vasopressors and antibiotics. And this presence of liver injury in a liver transplant recipient is associated with high mortality and high requirement of ICU care. And similarly, the treatment for SARS-CoV-2 infection in liver transplant recipients is still yet to be protocolized, and center-to-center approach different. So we have published with a suggestion of severe COVID who needs to be stopped of antimetabolites, tacrolimus may be stopped or reduced. However, they have been managed in this period being with a with the steroids in various form, maybe dexamethasone, maybe prednisolone, or maybe methylprednisolone. However, this lacks a unified approach across all the centers. So with this, we thought to explore the possibility of liver transplant recipients with SARS-CoV-2 infection in Asians, how they behave, what are the predictors outcome in COVID-19, and the practice of immunosuppression is largely unknown. So our aim is to identify the predictors of severe disease and all-cause mortality among liver transplant recipients who are infected with COVID-19. So the study was a multinational observational cohort study, which has been conducted from April 2020 to May 2021. The data was collected on a web-based proforma under APASL COVID-19 task force, and we analyzed the results as below. So coming to the results, we have enrolled 130 patients with a mean age of 53 years, being 90% as male, with a wide range of follow-up, including from 2 months to 77 months, with a median of 54 months, about 26% having less than 2 years after transplant being infected with COVID, and majority is 71% being the live donor transplants in our cohort. Among these patients, once they have a COVID-19, about 46% can be managed from the home with close monitoring. 41% requires admission to the ward. However, 13% required ICU care. And the various organ failures in this group are seen in 13% of the patients. Respiratory, kidney injury, and shock and altered system has been counted. However, respiratory is the most common among the patients. Out of 17, 16 have a respiratory failure. And the respiratory failure is mainly requiring ventilatory support in 9%, of which 7% required for the ARDS and 2% required for the non-ARDS causes. and major disease can be managed in the home. So when you come to the immunosuppression in our cohort, we saw that patients before this illness, about 30% in nearly only CNI, another 31% with CNI and MMF, another 30% being with mTORs with without CNI, and triple regimen, that is steroid, MMF and CNI only 11%. However, during illness, we have seen this drastically change in practice to consider steroids as the preferred agent in nearly half, and alone CNI has been considered in 32%. Only minimal, that is 60%, is requiring CNI and MF in this group of the patients. And the start of immunosuppression was to the pre-COVID dose in 70%, close to 70%. However, at discharge, 28% has been considered with low dose of CNI, and another 4% who requires augmented immunosuppression regimen because of the graft dysfunction. So when you compare the survivors with the non-survivors, I apologize for this busy slide. The age, presence of diabetes, presentation with shortness of breath, NLR, and acute liver injury at baseline, new onset of liver injuries, or development of graft failure as more commonly noticed among the non-survivors. So with this, when you consider to analyze for the predictors of severity, the age, presence of dyspnea at presentation, and NLR found to be independently predict the severity of disease. So whenever the patient presents, if they are having dyspnea and a high NLR and the higher age group associated with a more severe protracted course, and the mortality in this cohort was independently predicted by age, dyspnea at presentations, NLR again, COVID-related organ failure, and the graft injury. So COVID-related involvement organ and graft injury as a poor outcome, and age and dyspnea has a poor outcome, and most importantly, NLR is also predicting poor outcome with a high mortality. So when you consider the NLR for the severe and non-severe, you can see here for the severe, there is an exponential rise in NLR from baseline of 8.4 to 17.94, those who had a severe illness at the peak. Similarly, those non-survived, the baseline NLR is 4.8, but over the time, the final peak is gone up to 25. And this both correlates to the NLR correlates both to the severity as well as to the mortality. So in our cohort, the dysfunction was noted as 16% of the patients. Now of 21% of these, 13 is because of the SCR, and the all-cause mortality is in 8%. So to conclude and summarize my talk, 20% liver transplant recipients had a severe course of COVID-19, leading to mortality in 8%. The COVID-related organ failure, graft injury, and NLR predicted the mortality in the current study. NLR in liver transplant who are infected with COVID-19 is a simple bedside test. It is easy to monitor even while in domicile care and can guide the prognosis. With this, I want to share that the study has limited data on details of the transplant. The protocol-based unified approach is difficult to follow in this study, and cause of that we are not able to analyze as the data is limited for the computing risk analysis. I want to thank whole AASLD team and the R group in particular to be helpful in guiding and maintaining the study successful. Thank you.
Thank you very much. And we have gone beyond time. So very brief comment, Dr. Setu Babu. Very brief comment, please.
No, if you compare transplant cirrhotics and non-transplant cirrhotics, your NLR is going to behave the same. That's a comment. Thank you.
Thank you very much. And since we are running behind, I think we move on to the next presentation right away. That is Dr. Anand V. Kulkarni is going to come up with his research presentation. He's a senior consultant in hepatology and transplantation. Dr. Anand.
Hello, everyone. I'm Dr. Anand Kulkarni from AIG Hospitals, Hyderabad. I would like to thank Dr. Shiv Sareen and Manisha Amarpurkar, who has given me this opportunity to present our study at Hot Topics at AASLD 2021. The title of the study is Neuropsychiatric Manifestations Are Common in the Post-Transplant Period for Patients Undergoing Early Living Donor Liver Transplantation for Severe Alcoholic Hepatitis. The data on living donor liver transplant for alcoholic hepatitis is limited. There are only hardly few studies. The first study, which was published in 2014, said that the patients who undergo transplant for alcoholic liver disease, they have a higher incidence of psychiatric and neurological complications, but did not highlight anything much about this. There is a lack of data comparing direct steroid therapy versus early LDLT for severe alcoholic hepatitis. None of the studies have evaluated the role of tobacco abuse in these patients on the perioperatic outcomes. So we aim to compare the outcomes of patients who received steroid therapy with those who underwent early LDLT for severe alcoholic hepatitis. The included patients were steroid ineligible patients who underwent early LT versus the outcomes were compared against steroid eligible patients who had no LT feasibility due to either personal reasons or lack of a donor. The objective was to compare the 6-month survival in patients undergoing early LDLT against steroid responders and non-responders versus the incidence of recidivism in all the 3 groups versus the complications following transplant. As we can see here, more patients in the LT group had higher incidence of acute kidney injury, acute variceal bleed, encephalopathy, and sepsis. That is, they were ineligible for steroids, and those in steroid group had no transplant feasibility whatsoever. Most of the donors were females in the study, and the outcomes: 16 patients underwent early LDLT. The median time from alcohol abstinence to LT was 1 or 2 days. Among them, 4 patients succumbed, 1 to fungal pneumonia, 1 to sepsis, 1 to graft failure, and 1 because of COVID. 35 patients received steroid therapy, 20 responded to therapy, 15 did not respond. Of the patients who responded, 4 succumbed, and of the patients who did not respond, 11 succumbed. On Kaplan-Meier curve analysis, at 6 months, we found that patients who did not respond had poorer survival compared to those who responded to therapy and those who underwent early LT. Recidivism was common in patients in steroid responders. Almost 25% had slips by 6 months. We agree that the duration of follow-up is smaller. Probably we are continuing the study and trying to assess the recidivism till 1 year. We noted that 37.5% of patients who underwent early LT developed neuropsychiatric manifestations. All the patients had tobacco addiction. They were chewers and smokers and chewing. The symptoms we noted were irritability, tremors, headache, and suspiciousness. The time from abstinence to time from abstinence to LT was lower in the patients who developed symptoms, that is around 72 days, compared to those who did not develop symptoms, which was around 22 days. Interestingly, the tobacco addiction was significantly short. Abstinence from tobacco addiction to neuropsychiatric manifestations was significantly lower in the patients who developed symptoms. 9 days compared to almost 1 month in the patients who did not develop symptoms. These symptoms were transient, lasting for around 5 to 7 days. We had to use haloperidol in 3 patients. Baclofen was given for thrice daily for around 14 days. And the nicotine patch was also used in 3 patients. On follow-up, 9 tobacco abusers underwent early LT. I had resumed tobacco for 6 months. 3 had already succumbed, and only 1 had remained abstinent. On the other hand, in the steroid group, 11 out of 19 patients in the steroid group had resumed tobacco use by 6 months. 8 were chewers and 3 were smokers. In summary, in our settings, liver transplant is not a feasible option in most patients. Non-responders have a poor survival, which has been already shown in multiple studies, starting from the first study which was published in NEJM. And the LDLT is a reasonable option for steroid ineligible patients, and the survival is excellent in those patients. However, transplant is not feasible for most patients in the settings most patients have because of financial constraints or the lack of donors. The transplant is not an easy option for us. Females are the usual donors. As shown in our study, tobacco addiction significantly increases the risk of neuropsychiatric manifestations. However, we agree that this is just a causal symptom which have been noted. Further studies are required to highlight the reason behind this. Thank you.
Thank you, Dr. Anand. Quick comments or questions from the moderators?
No comments. No comments.
Okay, so we then move on now to the next presentation by Dr. Arun Walson. He's a DM fellow at the PGI Chandigarh, And let's hear it from him.
Warm greetings from PGI Chandigarh. At the outset, I would like to thank the organizers of the Hot Topics at AASLD for giving us this platform to showcase our research. Our study is titled A Pragmatic Study Comparing the Efficacy of Early Empiric versus Preemptive Antifungal Therapy in Acute and Chronic Liver Failure Patients with Suspected Invasive Fungal Infection, or the PEP-ACLF study from our group at the Postgraduate Institute of Medical Education and Research, Chandigarh. I am a senior resident in hepatology at PGI Chandigarh, and my areas of interest are infections, portal hypertension, and ACLF. I have no disclosures to state. Moving on, invasive fungal infections are reported in 5% of cirrhotics and up to 48% of hospitalized ACLF patients. IFIs lead to higher organ failures, treatment failures, increased morbidity, drives up the healthcare cost, leads to delisting, and leads to high attendant mortality up to the tune of 100%. Early diagnosis and treatment of IFI is an unmet goal. The IDSA recommends treatment based on risk factors, clinical suspicion, or surrogate mycological evidence. Currently, however, there is lack of data on the most effective type of antifungal treatment strategy in cirrhotics and ACLF patients. Before moving on, I would like to discuss the various treatment strategies based on this infographic. A patient can have risk factors, clinical or radiological evidence, mycological biomarker positivity, or definite evidence of fungal infection, like a positive culture or a tissue sample. If you have a definitive positivity, it is called as a proven IFI. If you have only risk factors or clinical radiological factors, it is called as a possible IFI. And in addition, if you have mycological evidence, it is called as a probable IFI. Now, when you treat a patient with only risk factors, it amounts to prophylactic treatment. And when you treat a patient with definitive positivity for fungal infection, it is called as a definitive treatment. And if you treat a patient based on risk factors and clinical factors, it amounts to empiric treatment. And in addition, if the patient has got radiological or mycological evidence of IFI, it is the preemptive strategy. In our trial, we compared the empiric versus a preemptive approach to systemic antifungal therapy. Our study stems from the clinical observation and the dilemma of as to when to start antifungal therapy in ACLF patients who are having a worsening course despite being due to presumed sepsis, despite being on appropriate antibiotics. So our primary objective was to see the impact of early empiric versus systemic preemptive systemic therapy on 28-day survival. We also studied secondary surrogate endpoints like new onset IFI, all cause in hospital and IFI attributable mortality, the evolution of ACLF in the hospital, and the development of new and worsening organ failures, the effect of mechanical ventilation free days, the effect of length of ICU stay, hospital stay, and the trends of fungal biomarkers. And we also measured the treatment success rate and the incidence of adverse events. Ours was a single center, pragmatic, prospective randomized controlled trial, open label trial with blinded endpoints. We included all adult critically ill ACLF patients who fitted either the APASL or the EASL definition. And to avoid the injudicious use of antifungals, we made very stringent inclusion criteria. The patient needed to have significant healthcare contact, had to have any of the two of the risk factors, and any one clinical risk factor. The risk factors were previously established risk factors like mechanical ventilation, broad spectrum antibiotic usage of more than 3 days, invasive lines, diabetes, total parenteral nutrition, renal replacement therapy, steroid use, high disease severity scores, GI surgery or anastomotic leak, and moderate to severe sarcopenia. Clinical factors include unresolved sepsis or despite broad spectrum antibiotic coverage, recrudescence of fever despite being on appropriate antibiotic, tracheobronchial or sinonasal infection, and unexplained HE after an initial improvement without any apparent precipitant cause. We excluded neutropenic patients, patients with significant antifungal exposure in the past 1 month, malignancy, hypersensitivity to antifungal products, HIV, pregnancy, and moribund patients defined as 4 or more organ failures with signs of imminent death and expected ICU stay of less than 48 hours. We assessed around 277 patients for eligibility, and we excluded 216 patients for these reasons. And finally, we randomized 61 patients, 30 into the empiric group, 31 into the preemptive group, and followed up them till 28 days or death or transplant. Interestingly, none of our patients for either the group were excluded from the final analysis. Our patients included young males of around 40 years of age whose acute precipitant and chronic predisposition was predominantly alcohol. The empiric group had low systolic BP and higher total leukocyte count at randomization, and all the rest vital and laboratory parameters were comparable at baseline, as was the bacterial infection rates. Coming to the results, in the primary objective, the empiric group had significantly better survival of around 47% versus 13% in the preemptive group, with an adjusted hazard ratio of mortality of 0.37, being the hazard ratio being adjusted for the CLIF COF and the days from admission to randomization, with a number needed to treat of 2.96. The empiric group also had better IFI attributable mortality and in-hospital mortality, and also better improvement in disease severity as measured by the MELD and the CLIF OF score, as also was a mechanical ventilation free days. And this was achieved without any significant difference in the adverse events, either serious or non-serious, between the two groups. The strength of our study was ours was the first study to assess the efficacy and safety of 2 strategies of systemic antifungal therapy in ACLF patients with suspected IFI. We addressed a specific subgroup of sick cohort of patients who have dismal prognosis without transplantation, and there was high intervention adherence and no patient was lost to follow up. The risk of bias due to an open label was minimized by probe assessment and a robust primary outcome that was less likely to be influenced by observer bias. We had limitations being a single center study and being conducted at a tertiary referral center. The empiric therapy may have got delayed due to delayed referral from the peripheral centers. And due to the ongoing COVID-19 pandemic, the recruitment was difficult and we were forced to report pilot data. And our recruitment rates of patients were lesser than expected due to a high mortality of high grades of ACLF. So what are the key takeaways from our research? The fungal sepsis in ACLF is associated with high mortality. Prompt institution of systemic antifungal therapy based on risk factors and clinical suspicion improves survival in ACLF patients, also decreases the disease severity, IFI attributable and in-hospital mortality, and also the ventilation-free days.
Thank you, Dr. Arun. There's a question already as to which antifungals were used. Is he online? No. Unfortunately, I think the presenter is not online. And
may I answer, sir?
Yeah, sure. Go ahead. Yeah.
I was actually the lead corresponding for that. Actually, he was my student.
Yeah.
So, in majority of patients, we used liposomal amphotericin B, and which was 70 to 80% of the patients, because we didn't had any clue on whether it was the site of infection was. But and the rest of the patients, it was Anidula fungin. So it was mainly predominantly liposomal amphotericin B.
Thank you. Very commendable that you could get a student of yours to present at the AASLD. It's really commendable.
Yes, thank you.
Any short comment, please? We are behind time, Dr. Sethubabu.
Oh, I think it became now a standard of care, preemptive or proven care, because it's very difficult to prove the existence of fungal infection. So if you see a serious patient or patient transferred on day 3, day 4, you're actually very much tempted to use antifungal as a standard of care. I agree.
So just one point I would like to add here is that it is not that once we start antifungals, we should also de-escalate. There is antifungal stewardship now, looking at the biomarkers or evidence of mycological cultures at day 5, we can step down or stop the therapy if there is no evidence. That is what we are also doing. Thank you.
Yeah, very valid. Thank you very much. And we now move on to the last presentation in this session. That's by Dr. Impreet Kaur, who's a PhD scholar and ICMR research fellow. So let us have the presentation, please.
Greetings to one and all. I would first like to thank the organizing committee for giving me an opportunity to present my work under the category of Topics AASLD 2021. So the title of my study is Lithocholic Acid Modulates Angiographic Profile and Functions of Liver Sinusoidal Endothelial Cells During Liver Regeneration. I am Impreet Kaur, pursuing PhD at the Institute of Liver and Biliary Sciences, New Delhi, under the supervision of Dr. Savneet Kaur. The keywords of the study are liver regeneration, L6, and the bile acid. So there are several studies which have reported that certain endocrine signals like HGF and Wnt2 are released from the L6, which have a role in liver regeneration. These L6 serve as a gatekeeper of the liver, as anything which is coming to the liver via the portal vein first interacts with L6. And one such component that is coming from the portal vein is the bile acid that also has a role in liver regeneration. So based on this background knowledge, the rationale of the study is growth factors such as HGF and Wnt2 released by L6 induce the proliferation of hepatocytes during liver regeneration. Bile acids in the portal blood closely interact with the L6. However, how bile acids affect the endocrine functions of L6 in liver regeneration remains largely unknown. So we hypothesize that portal blood bile acid pool affects the endocrine functions of L6, which further modulates the hepatic regeneration. So we aim to study the interactions of bile acids with L6 during liver regeneration. So this is the overall study design that has been followed. So firstly, we prepared a 70% partial hepatectomy model and studied the liver regeneration at different time points by the assessment of liver regeneration, expression of bile acid receptors, bile acid profiling in portal serum, and the peripheral serum was also performed. Liver regeneration was studied both at the level of liver tissues and the liver cells. Further, we also modulated the gut microbiota that converts the primary bile acid to secondary bile acids, and then studied the expression of bile acid receptors, endocrine factors in L6, and the proliferation of hepatocytes. Moving on to the results, in the liver tissues, we observed a marked cellular proliferation after partial hepatectomy. Further, there was a high expression of both FXR and TGR5 at day 2 post-PHX. We observed that immediately after PHX, there was an increase in the bile acid pool after 5 minutes, which continued to increase after 48 hours of PHX. In the case of liver cells, we observed that the expression of FXR was increased in the case of hepatocytes and the L6, while the expression of TGR5 was significantly raised in the case of L6. We observed a difference between the portal and the peripheral serum bile acid profiles, and interestingly, they were exactly opposite to each other. In the case of portal serum specifically, we observed that lithocholic acid and taurolithocholic acid showed increased expression in the portal blood at day 2 post-PHX as compared to the control. We also studied the effect of lithocholic acid on the endocrine properties of L6, and we observed that it increases the expression of endocrine genes and the factors in L6. Next, we looked at the proliferation of hepatocyte proliferation by proliferation of the hepatocytes by LCA-treated L6 conditioned media, which was observed to be increased. Hepatocyte proliferation was increased in terms of pCNA positivity in the case of LCA-treated L6 conditioned media in comparison to control and L6-CM. Next, to further validate the effect of secondary bile acids in liver regeneration, we modulated the gut microbiota by the treatment with antibiotics like vancomycin and imipenem, and then we observed the expression of TGR5, which was significantly decreased after PHX in the antibiotic-treated animals. Next, we studied the effect of antibiotics on the endocrine signaling of L6 and hepatocyte proliferation, where we observed a significant reduction in the endocrine factor genes after 48 hours of PHX in the antibiotic-treated models. Further, we observed that in terms of cyclin D1, cyclin E, and FOXL 1b hepatocyte proliferation was decreased in the case of antibiotic-treated PHX models. So the key takeaways of this study are bile acids in the peripheral and portal serum showed different levels in control and PHX models. Secondary bile acids such as lithocholic acid and taurolithocholic acid were increased in the portal blood at 48 hours post-resection in the PHX models. The expression of PGR5 was highest in the L6 after 48 hours of PHX. Lithocholic acid significantly enhanced the expression of endocrine genes and factors in L6, which promoted the hepatocyte proliferation at 48 hours in PHX models. Modulation of gut bacteria and portal blood secondary bile acid pool by antibiotics reduced the expression of endocrine genes in L6 and hepatocyte proliferation in the PHX models. Thank you for your attention.
Thank you, Dr. Kaur. And we can have one quick comment because we are already behind schedule. Moderator.
Very nice work. Very nice work, Impreet. I was just wondering, in your LSEC conditioned media, those LSECs were actually treated with the bile acids?
Yes, ma'am. Those were treated with the bile acids.
Okay, excellent work all around. Thank you. Thank all the participants for their presentations. Thanks to the moderators for being here with us. And thank you, the audience, for being here. The next lecture coming up is Professor Shiv Sareen, whom you all been eagerly waiting to hear. So I think sir may be online.
I'm online, Dr. Vinay.
Yeah. So a brief introduction to Professor Sareen, of course, requires no introduction. He's the person who made India's stamp on the world hepatology map for all of you. He has been my teacher, the V. Pant Hospital, after which he established the Institute of Liver and Biliary Sciences, which is now going to be a deemed university. Recipient of the Shanti Swarup Bhatnagar Award, which is the highest civilian award in science, the Padma Bhushan. He has been the chairperson of, the list is unending, a great human being, great researcher. Thank you, sir. I would invite you to go ahead with your talk.
Thank you, Dr. Vinay, and the moderators for allowing me to start. I bring greetings from ILBS. I'll cover the area of liver failure at AASLD. The courtesy slides from all the speakers. The first is diagnosis in ALF, role of PET-CT. We diagnose HE by clinical, by ammonia. Now, PET scan is an imaging technique based upon the detection of positron emission, and it can detect neurotransmitter activity changes in HE. In animal model, the cannabinoid receptor, especially one cannabinoid one receptor, gets upregulated by day 3 in the thiacetamide-induced liver failure. And if you see in the basic pathogenesis, the two main endocannabinoids, one is 2-arachidinoglycerol, the 2-AG. In the liver disease patient, it increases, and this correlates with increase in ammonia levels, and also it upregulates the CB1 receptor and decreases the neurotransmitter release and can cause cognitive deterioration. A new tracer, MK9470, is a PET tracer which can pick up cannabinoid 1 receptor. So in this study, the question was whether using 9470, which binds to CB1 receptor, can you assess HE animals? They used two models, bile duct ligation and thiacetamide-induced liver injury, and an experimental PET was set up. This is the control animal. This is day 1 after thiacetamide, day 2, and then subsequently after giving a blocker. All this activity shows that cannabinoid receptors are upregulated. When you give a blocker, it disappears. Same was in bile duct ligation compared to control. There is an increase over time in 2 weeks. This was day. In 2 weeks and 4 weeks, there is a increased CB1 receptor expression. Now, the CB1 receptor expression correlated very strongly with liver inflammation, bilirubin, ALT, brain aquaporin 4, AST, CB1 receptor expression, plasma ammonia, and brain water content. Same was seen in BDL. So it correlates, uptake of CB1 correlates with physiological and biochemical changes. My takeaway is CB1 receptor expression has not received its due recognition. It's very important both for fibrosis and for HE. You can detect it by using PET and by a special tracer, which I hope can be made available. It's now in the US. And diagnosis of acute or chronic HE can be done. And if you have a blocker, you can monitor the therapy that CB1 has been suppressed. Second is an interesting work, correlation of liver volume for the development of a prognostic score and outcomes in non-acetophen-induced liver failure, the LIV score done by Dr. Hirsch, who is our assistant professor. Correlating liver volume with mortality and outcomes in ALF is known. And a score, if we can correlate this, Roger Williams used to say, if it is less than 35% of liver volume of the original, patient should get a transplant done. This hasn't been possible because you can't do a transjugular biopsy in ALF. So we took patients from 2010 to 2021. 75 of them had CT abdo at admission. What is interesting to see that non-survivors versus survivors, patients had higher ammonia, higher INR expected. Jaundice to HE was longer. Meeting KCH criteria was common. The HE grade at admission more than 3 was there. Liver volume on CT was 815. A univariate analysis showed that a liver volume of 980 was minimally required for survival. A multivariate was done where HE, liver volume, meeting KCH, and a constant, they were calculated to develop a score, LAV score, which when used was found to be superior than KCH or LIV score or a MELD score. The advantage is it can give you reliable, at least 85% of the times, that this patient will survive or not. Liver volume correlates with worse outcomes if it is less, and LIV score includes. My takeaway is calculate liver volume and develop better scores than KCH. This is just to give you 2 more slides. This is portal hypertension in acute liver failure. 30 years ago, Navasa studied 25 ALF patients. HVPG, which we think is less than 5, also was high in ALF. Those who had a higher HVPG had renal failure and developed ascites. HVPG correlates with the amount of reticulin collapse. So this is HVPG. Suppose the HVPG is 15. You can see that 25% of the liver has collapsed. However, they did not find a difference in survivors and non-survivors. The bottom line is a patient who has ALF will have an increased pressure in the liver, and that can determine blood flow and outcomes. So we need to be aware of the liver volume. If it is less, there would be more chances of high pressures. This is a very interesting study, simple anti-HBC IgM and cytokines in ALF. Spontaneous survival occurs in 30% only in HBV ALF. To determine transplant-free survival, various variables were studied. They found that ALF patients who remain transplant-free have a detectable anti-IgM, anti-HBC, irrespective of nucleoside or nucleotide analog therapy. The cytokines which showed that there is an increased liver regeneration was VEGFR, higher in transplant-free survivals, CD40 or platelet-derived growth factor or epidermal growth factor, IL-4, or those where it was low, means the pro-inflammatory or an inhibition to regeneration were there, were MCP1 or IL-15. These are markers which were low, other cytokines were high. So using a cytokine panel and simple IgM anti-HBC, my takeaway is anti-HBC IgM indicates an immune rebound. Enhanced regeneration markers indicate regenerative potential. We should do a cocktail. However, in my opinion, there is no acute hepatitis B unless you have a blood transfusion or needle stick. Everyone has an HBV reactivation. Therefore, we need to see much more, including liver biopsy in these patients. About prognosis in ALF. What are the predictive factors? This is a very interesting, simple study. Acute liver failure from acute liver injury. So people had ALI, whether they will develop acute liver failure. So patients with ALI have coagulation abnormalities, but no HE. Severe ALI precedes ALF, means development of HE. What are the factors and biomarkers? So the ALF study group of US took out these, about 10 years, 59 ALI, 34 females, 11 patients evolved to ALF. 9 of them died. DILI was amongst the commonest etiologies. Interestingly, if a patient is upgraded to ICU or has developed ascites, what I was telling you just a little while ago, if an ALF develops ascites or ALI develops ascites, the patient is not likely to survive. And etiology of ALI, if this patient has etiology of ALI being drugs, it can have higher prediction. So the conclusion is progression from ALI to ALF or death is more common in patients who present with ascites at presentation. Now, sometimes you call this as ACLF or subacute hepatic failure. Subacute actually is after 4 weeks to 6 months, but has ascites as an integral part. But if it is within 4 weeks, we may say ALI to ALF. Unless there is a biopsy, we cannot exclude the chronic liver disease. But ascites is a bad sign. Patients who died had a tendency to be more inflamed. They have increased CRP, I have not shown you, poor renal function. And NAC had no advantage. Acute portal hypertension, one more time, in ALF, which is due to cell death and inflammation, determines the outcome. Therapy. N-acetylcysteine in non-acetophen-induced ALF. Obese versus non-obese. So the design was a retrospective, more than 100 or less than 100. Non-obese versus obese, you can see the weight was higher, MELD sodium was same. In patients who were obese, somehow the survival was a shade better. I am not surprised, but many of you may be surprised. This is the remaining fat mass that prevents death in ICU. Length of stay was shorter. They could not give the required dose of NAC, but still it was more, but less than they required, optimal, but still less. Therefore, there was no difference in mortality or transplant rate at 1 month between the two groups. 1 month transplant-free survival, there was a trend to be better for obese people. My takeaway is NAC is not very effective. And the other part is these people included alcohol-associated liver disease, put them into ALF, which is a bit challenging. However, Don't be depressed or feel bad if you have an obese ALF, unless patient has underlying liver disease. I'll try and cover acute and chronic liver failure, something on diagnosis. Anand has shown this in another study, but here he represented the ARC study group on total leukocyte count and a simple HDL. The aim was to compare procalcitonin, CRP, HDL, TLC, and NLR, and those who die or survive. This data shows that those who die have a higher MELD in ACLF, their white cell counts are higher, their CRP is high, HDL is low, and NLR is high. When a multivariate is done, a high TLC and a high TLC associated with high mortality and high HDL with reduced mortality. This is what it shows. White cell count above 9,500 and HDL above 15.8 gives you high sensitivity and specificity. So they concluded that high TLC and low HDL at baseline can predict mortality in ACLF. My takeaway is do HDL anyway, it might be of help. TLC we are already doing. Let's learn from this. This is a abstract bile in blood predicts higher risk of organ failure and mortality in ACLF, done by our second year fellow Srinivas. Background is bile acids are powerful signaling molecules. They regulate lipid, glucose, energy homeostasis, Y, FXR, and G protein coupled receptor TGR5. However, accumulation of bile acids could result in cell injury and death. We studied the effects of bile acids on organ failure and outcome in ACLF. 250 patients in 1 year, 83 in whom serial bile acid levels were available included. Extrahepatic organ failures correlated with bile acid levels was to be assessed. As you would see that at presentation, the bile acid levels were about 200 micromole. Normal is less than 10, so 20 times higher bile acid levels. Patients who had a bile acid at 186 micromoles increased the risk of AKI and also increased the risk of cerebral failure, means HE and kidney injury were bile acid dependent because it breaks the blood-brain barrier. Mortality was higher in these patients. My takeaway is add bile acid to the shopping list of tests. So we have added HDL and we have added bile acids. Pathogenesis of liver injury in ACLF. Statins are associated with reduced development of ACLF in a large national cohort, and they are using CLIF definition. Nadeem and Raj and David Kaplan are involved into this study. Statins have been shown to reduce cirrhosis-related decompensation and mortality. But on ACLF, its impact is unknown. So they took retrospectively the vocal database, Veterans Affairs Cirrhosis Cohort, and they evaluated association between statin exposure and ACLF development. 124,000 patients were included. Finally, no statin 46,000, baseline statin 22, and new statin initiator 15,000. Overall, the statin exposure or no exposure was calculated. 10.1% had ACLF. No statin 11, with statin exposure 8. This is the data. However, I want you to see that infections, no statin versus any statin exposure. Infections were more. Kidney failure, no statin versus statin, this was more. Circulatory, they were more. Overall, there may be benefit, but here were 3 examples: infection, kidney, and circulatory. They developed a model where statin exposure overall gave a survival benefit. Cumulative means 5 months of statins also gave an advantage. Other lipid-lowering medications did not provide any other advantage. They use an inverse probability treatment-weighted Cox regression model. Conclusion is statins reduce risk of ACLF. My takeaway is we need more data, we need mechanistic studies, retrospective studies have limited role. Safety and preliminary efficacy and pharmacokinetics of an intraperitoneal VSO1 infusions in patients with decompensated liver cirrhosis. A very innovative, very interesting study from the group of Jonel Trebica. So in the abdomen, once there is circulation and there is acidic fluid, the ammonia releases and other drugs can come into the acidic fluid. We have never given attention to the peritoneal fluid or acidic fluid ammonia. So here what happens, ammonia in the bowel or in the blood will leak out. Now it will leak. There is a liposome which is containing citric acid. So what will happen is the ammonia will be converted to NH4. Similarly, drugs which come out from this, their hydrogen will be taken away. So this is the basis of it, that a drug called VSO1, which has liposomes with encapsulated citric acid, if you give it intraperitoneally, you're taking out the acidic fluid and you can inject it. What it will do, it will protonate. It will convert drugs which will be hydrogenated, and the ammonia will be converted to ammonium in the aqueous acidic core, and the thing will remain trapped there. What they did was, this is a phase 1 study, single ascending dose, 15 ml or 30 or 45 ml, or they give multiple dosages. I'll take you to the crux of the matter. So you are tapping and injecting, tapping and injecting, tapping and injecting. So what happened is the animal naming test improved in these patients. Sorry, what happened to this slide? It just got frozen. Sorry, apologies. Can you see my slides still? Hello?
Yes, sir, we can see the
Yeah,
slides.
okay.
Sir.
So animal testing, animal naming improved. Critical flicker frequency, the green one is after the injections and this. So critical frequency improved. Number connection improved. Plasma ammonia levels came down. And peritoneal fluid ammonia clearance also improved. So in crux, there is an improvement in ammonia clearance through peritoneal fluid. So this novel liposomal drug administered intraperitoneally has the potential to improve HE and ACLF related organ failures. It was found safe and improves several psychometric parameters, reduces plasma metabolites. I think it's a new approach and we should look forward to similar such approaches. While we are waiting, you can give citric acid, which will also go from the bowel into the peritoneum. This is a work done by Anand and Professor P.N. Rao. Primary norfloxacin prophylaxis prevents bacterial infections and prolongs transplant-free survival in ACLF and RCT. The aim was to assess the safety of Norflox prophylaxis, and it was a simple study with clear objectives: incidence of infections at 30 and 90 days, transplant-free survival, and safety and tolerability, 72 in Norflox, 71 in placebo. At day 30, 18.1 in Norflox and 33.8% in placebo, they had bacterial infection, significantly reduced. And at day 90, similarly, the infection rates were reduced, and E. coli was most common, and their UTI was the commonest thing. When you look at the cumulative hazards of bacterial infections, those who received Norflox had significantly lower compared to placebo group. And that showed up into transplant-free survival. Norflox had a better survival than placebo at day 90. My takeaway is you should start antibiotics. The choice is yours. At least we have now data of one good antibiotic as a prophylactic. Why not start with Norflox and assess for yourself? This is my last pickup on therapy. Mesenchymal stem cells resuscitate monocyte bioenergetics and function and ameliorate liver injury and potentiate regeneration. And I'll take a few minutes to explain this new concept. In patients with cirrhosis, due to any etiology, cell death occurs, and also the gut and the bacteria stimulate Kupffer cells. Finally, the inflammation and oxidative stress cause a lot of deaths. The major player is your monocyte and macrophages. In fact, Kupffer cell in a way is a macrophage. So whether it is hepatic macrophage or peripheral blood, both are injured in this. So the question is why? And can we resuscitate monocytes? So healthy and ACLF patients were taken. There was blood of the ACLF patients, and liver tissue and living donor transplant was also available. Kupffer cells and monocytes were studied in liver, and plasma and monocytes in the blood were studied. Baseline, there were some interesting differences. Patients who had no SIRS had SIRS or ACLF with sepsis. I just want to say patients who had ACLF with sepsis had higher lactate, AST, higher, the neutrophil counts were high in both the groups. Lymphocytes were low, and neutrophil to lymphocyte ratios were high. And these are interesting slides. This is liver tissue and this is blood. In the blood, ACLF patients had a higher CD14, more monocytes. In the liver, they had higher monocytes. They had higher macrophage. So why not? What is wrong? They are good. But when you look at the functionality, the phagocytosis, these macrophages in ACLF had poor phagocytic function. Even in the blood, their phagocytic function. So both liver and the blood phagocytosis was poor. Now, this you have to understand, this is cellular bioenergetics, cellular respiration. This is the oxygen consumption rate. More the oxygen is consumed, more viable the cell is. A patient who has sepsis has no capacity to consume oxygen. Patient who has no SIRS has a capacity to consume oxygen. Their basal respiration at rest, hardly cells can respire. They can't get the oxygen in. Oxidative phosphorylation is dead. Their ATP production is almost finished. Their maximal respiration in non-survivors is very, very poor. So you can say, and this is now one of our routines, coming to be a routine, those who have ACLF, you do their cellular bioenergetics, results are available in 6 hours. Those who have a very low, less than 26 picomoles of their OCR, they are unlikely to survive. Do plasma exchange and they can get better. Or now here the second part is, here is the amount of mitochondrial biomass. 10 raised to power 5 or 4.5 is healthy, while 10 raised to power 3 in ACLF. Similarly, mitochondrial transmembrane potential generation, much lower than in healthy. You can see here mitochondrial functionality in healthy, in healthy is much better, high mitochondrial functionality in transmembrane, while it is much lower in ACLF. So overall, mitochondrial mass is reduced and functionality has gone down. Can you augment it? And I know my time is running out. So what you can do is give the mitochondria into this. So here, if you use umbilical cord mesenchymal stem cells, they will give the monocyte their mitochondria. Total mitochondrial mass and functionality will improve. This results in less liver injury, inflammation, cell death, improves the liver regeneration, the PCNA levels will improve. So my takeaway is mitochondrial mass and function is reduced in ACLF monocytes. It is due to energy failure. Mesenchymal stem cells can improve, give their mitochondria, and can restore immune function in the ACLF monocytes. Thank you so much for your kind attention.
Thank you, sir, for that very amazing talk. And we have a very august panel of moderators for this particular session. And Professor Govind Makharia, who is a senior professor at the All India Institute of Medical Sciences. Then we have Dr. V. Jayanti, who's been a teacher to many students, and now she is at the Global Hospital. And we have Dr. P.N. Rao, who was one of the founding members of the INASL and one of its very initial secretaries, and who chairs the hepatology unit at the AIG Hyderabad. So this over to the panel to for the questions and for any comments and the analysis.
Thank you, Professor Sari. Yeah, thank you, Professor Sari, for the wonderful coverage of the, I think, the most latest and the hot topics at the AASLD 2021. You've given us wonderful take-home messages, which are practical, I think, especially the HDL and the bile acid assay. And I think the one of the papers that you mentioned about acute liver injury progressing to acute liver failure. I was wondering what would happen to the AST-ALT in patients with acute liver injury vis-a-vis acute liver failure. On one hand, we have the INR, the other hand, we have the ammonia. But what happens to the AST-ALT in these patients?
The study I also looked at very carefully. There was no difference. My personal experience is they will come down after a few days and will not be very helpful. Higher the AST-ALT, better is probably regenerative potential.
Thank you very much, sir. Over to Dr. P.N. Rao and Professor Govind.
Govind, please go ahead. If you have any. No, you have to unmute.
I think, thank you so very much for a wonderful presentation. I think I'm so happy that the kind of research being done in our country is remarkable. Many centers like ILBS, PGI, AIG, AIMS, and many other institutions are doing wonderful work. So happy to see such kind of work coming from our country, especially the basic and fundamental sciences in hepatology. We heard 8 abstracts earlier also in Best of AASLD. They are remarkable papers. I had one question from Dr. Rao, or maybe Dr. Sareen. The study from Dr. Rao, that in patients with ACLF, when do you start norfloxacin for prophylaxis? After the patient discharged, or because once they are in hospital, most of them are on antibiotics. So what's the timing of starting norfloxacin in these patients?
May I take the question, sir? I'm here, Anand.
Yeah.
Sir, actually, we started antibiotic 5 days after discharge.
After discharge.
We excluded those patients who had antibiotic exposure in the past 5 days.
Right. Perfect.
And we did not give them rifaximin. We did not take any patients with hepatic encephalopathy as well.
Dr. Sareen, where do you place this our subacute hepatitis, subacute hepatic failure in the current scenario? It used to be a buzzword, for a few years before, and there was a workshop also on this by Professor Tanker.
1981, there was a workshop, and I was one of the rapporteurs at that time, young lecturer. The current place for this is a very small group of patients who are having ascites developing 4 weeks after jaundice, with or without HE, with a normal liver at liver biopsy, what others would call as delayed resolution of ALF or delayed onset ALF. So I think if I would see 100, maybe 500 ACLF, I would see 1 or 2 subacute. It's a distinct group, but diagnosing it requires a liver biopsy to say there is no underlying liver disease.
Thank you.
Yeah.
Setu Babu, you wanted to ask something?
I think whenever I see Sareen, I don't know, I feel like questioning, but he also gets annoyed with me. But then I have a very important question that if you do in a, liver volume survivors in liver failure, we could use probably ultrasound volumetry with a Doppler, where, which is more beneficial than CT, which cannot actually do the portal flow.
It's a good question. I have not done it as far as blood flow is concerned, but one can look into what is known as a congestive index of the portal vein, which is if it is more than 0.65, it says that there is resistance. What we currently do in all our patients of ALF, before they move up from the ER, they get a CT brain and a CT liver. Volumetry is done, and we feel volumetry is very helpful. If there is a ONSD above 5, liver volume less than 980 or so, that patient with high INR is early referral for LT.
Whatever benefits we are getting with statin is probably specific to simvastatin rather than other statins. That's even genetic as well.
It's a hydrophilic. So a hydrophilic statin is much better than the hydrophobic, and it causes benefits. However, I'm not too sure if it can be given in to prevent ACLF. This will be requires more studies.
The third point is, we used to remove large volume of ascites, go through a, renal dialysis cartridge, and then put back the albumin. I think acetic fluid reinfusion of albumin. There was a paper in hepatology some time back, and when we did about 6 patients, 4 patients showed marginal benefit.
Yes, it is possible. The technique is very good, and Chinese use it as a pump. They will take out the fluid, they will concentrate, and they will also remove the bacteria and reperfuse it through the antecubital vein. It is underutilized, and I think we should all try to evolve it further. But the novelty of Jonell's work was that using citric acid as a liposome, he was able to trap ammonia, and they showed significant ammonia reduction, which is something which we want to have. So if you're just removing acetic fluid and also remove ammonia and leave that liposome inside for days, up to 11 days, the ammonia was trapped inside.
I think the albumin has got a toxin binding happen. That's also is another advantage.
Yes.
Another advantage.
Albumin has a toxin binding, but within 15 minutes of giving intravenous albumin, there is a structural change, so it becomes a little less useful.
So that is why we don't want to give IV albumin. We would probably give intraperitoneal, which will stay. In fact, you remove some fluid, it can stay, and it doesn't add ascites because this increases the intra-abdominal oncotic pressure.
That's a brilliant idea to give albumin in the peritoneal.
We did that in 6 patients.
Oh.
And the only problem which we were worried about infection, unless you're very careful, like as if you are doing a surgery or something because of the sterility and all. Thank you, sir.
Leave that study. Very good.
I had another question regarding using CT scans in patients with acute liver failure. So certainly this is for triaging for early transplant if the liver volume is less. So the question is that as per general practices, that patient with ACLF should be given least amount of stimuli. Any kind of extraneous stimuli should be avoided because it may lead to increase in intracranial pressure. So doing such kind of strategies like doing a CT scan or so, does it also have a negative aspect?
Well, it normally would take about 10 minutes or so. From the ER, fortunately, our CT room is about 20 meters, 25 meters. So the patient is just like walking, rolled in before he goes to the elevator. So elevator. So that's why, but you have a point. The movement should be minimum. And especially if the patient is in grade 3 or 4 and non-intubated, all care has to be taken by the SR for this. But I take your point on that.
Or an eye closure, because it's an orbital stimulation that matters. So if you put a dark iPad or something might, I don't know, they just a thought.
Yeah.
Do you think this MK 9470 will be a clinical applicability? It's not available in India, I found out from, but it's available in USA for a very long time. In 2007, I found some papers.
Yes. We just need to demand, but it's an eye-opener that a PET CT and the cannabinoid receptors, they can be extremely helpful in our knowledge about HE and the drugs to use it, like anandamide blockers, agonists can be useful. CB1 agonists can.
I think these in an MRI also can show, because there was a paper which showed even MRI, some specific areas showing the uptake which is different because of the gadolinium uptake is different. I think MRI is as useful
MR
as
spectroscopy, where you have the choline shifts or sodium shifts and others. MR spectroscopy is the basis in all brain electrophysiology.
So that
You're
should be
absolutely on the dot.
The paper on norfloxacin, is it a primary prophylaxis? Is it prophylaxis given after bleed, or you have some information on that? Norfloxacin.
Anand is there, maybe Anand.
I couldn't get the question, ma'am. Sorry.
Norfloxacin, is it given as a primary prophylaxis or secondary prophylaxis? Or
Primary prophylaxis.
Primary. Or prevention of?
Infections. Any infection.
What is the sensitivity and resistance pattern in the population?
Actually, we had around the equal distribution of MDRs in both the groups, where around 30% were infected by MDRs in both the groups. There is no increased risk of MDRs by norfloxacin prophylaxis. However, we noted that the norfloxacin might increase the risk of candiduria. There are little higher risk of developing candidal infections and albinans in these patients.
But that is
because we had more of alcohol-related patients who had ACLF.
And duration, how long can you give it?
30 days, madam. 30 days.
30 days. Thank you.
I think we have a fancy towards rifaximin rather than quinolones.
Yes.
Thank you very much. I don't see anything in the chat box. Over to you, Vinay. Thank you.
Thank you.
Questions? We continue the session. Thank you very much, sir. Thank you.
I thank Professor Sareen and all the August moderators for taking part in this very lively discussion and making this session so exciting. So now we break off for coffee, and to all our viewers who are out there, and thanks for being with us on a Saturday. And we'll be back at 5 o'clock with updates on viral hepatitis and NAFLD and much more. So see you at 5 after the break. Thank you. Hello, everyone, and welcome to the session of Hot Topics at the AASLD 2021, and welcome back after the coffee break. So now we have exciting sessions going on for the next few hours, and now the session that's coming up is by Dr. Rajendra Reddy, whom we fondly call as Dr. Raj Reddy, and who is a professor of medicine at the University of Pennsylvania, especially interested in transplantation and also in viral hepatitis. He is a widely known personality both in America and India. He has passed his MBBS from the Osmania Medical College in Hyderabad. Very much our own person who takes all opportunities to educate us and keep us updated. And thank you for your time, sir. And of course, we have a very august panel here of moderators, Dr. S.K. Acharya, of course, who was previously the head of the department at All India Institute of Medical Sciences, and Dr. Taran Gupta, who's the professor of hepatology at the PGIMS, and Dr. Madhumita Prem Kumar, also assistant professor of hepatology at PGI Chandigarh. So, sir, Dr. Reddy, we are awaiting your talk.
Well, thanks very much. I'm sorry I couldn't be there, but I have recorded my talk, and hopefully you'll get the message about all the important aspects of presentations at AASLD on viral hepatitis. So can you put up my recording? Hello? Or did you want me to speak again?
Do we have the recording? Can we put up, sir, the recording?
I wasn't sure if I was expected to talk. I can do that.
So it's coming on.
No, there's a recording, sir. They are bringing it on.
The recording is coming on.
Right. Okay. Thanks. Welcome. Hi, this is Raj Reddy. I'm sorry I can't be with you all today, but I'm delighted to give you all a bit of a flavor of AASLD highlights with regard to hepatitis B, C, and D. This is my disclosure. I'm going to talk about hepatitis B first, followed by hepatitis C, and then talk about delta hepatitis. I must say there's not been much new information on hepatitis C. Most of my focus will be on hepatitis B. First, this is a global burden of disease study. This shows results from 2019. The idea behind this analysis was to look at progress towards the interim WHO target for HBV elimination of a 10% reduction in HBV mortality from 2015 to 2020. In 2019, there were an estimated 555,000 deaths related to hepatitis B infection globally. Unfortunately, between 2015 and 2019, hepatitis B related mortality had increased by about 3% among the 20 countries with about 80% of the global hepatitis B virus mortality burden. Now, if you were to look at the various countries, what is interesting is that Russian Federation and DRC had greater than 10% decrease in HBV mortality during this time period. And quite importantly and interestingly, India had about a 6% decrease in HBV mortality during this time period, whereas several countries such as Bangladesh, Myanmar, Korea, African countries, Pakistan had an increase in mortality during this time period. Seemed like, at least based on this estimate, India is doing well. Now, I want to talk about a couple of studies that looked at the prodrug of tenofovir alafenamide, with regard to efficacy and safety in preventing perinatal transmission of hepatitis B. This was a study, a multi-center single-arm retrospective study that looked at tenofovir alafenamide that was introduced in the second or third trimester. This was in mothers who were E antigen positive with a viral load of greater than 200,000 international units per ml, and they received tenofovir alafenamide along with HB and immunization. And in essence, the main findings were that tenofovir alafenamide dropped maternal viremia by about 3.7 logs at delivery. And then at age of 24 to 28 weeks, none of the infants had surface antigenemia. So it tells you that tenofovir alafenamide works as well as tenofovir in preventing perinatal transmission of hepatitis B. It's been looked at in studies with tenofovir, and this basically is a validation of previous observations, but with tenofovir alafenamide. Here is another study that looked at tenofovir alafenamide for the same objective, preventing perinatal transmission, and again used a threshold of viral DNA of 200,000 international units in pregnant women for TAF to be introduced. And in essence, if you were to look at maternal to child transmission rate, it was 0%. So a mother to child transmission rate was essentially prevented in all mothers who were treated with tenofovir alafenamide during the third trimester of pregnancy. Now, this is a nice study that looked at abnormal ALT persisting in patients with hepatitis B after tenofovir treatment, and as to why they had persistent ALT despite viral suppression. They used machine learning technology, and then in essence, what they noted was in those who had normalization of ALT with viral suppression in hepatitis B patients, there was no steatosis, ballooning, or lobular inflammation. But then in those who had effective viral suppression, defined as a threshold of less than or equal 69 international units per ml, there were features of steatosis, ballooning, and lobular inflammation. And very likely, these were the features responsible for abnormal ALT persisting in hepatitis B patients despite effective viral suppression. And we've known about this for some time, but it's a nice study using machine learning models to kind of validate our clinical suspicion or impression. I'll focus a bit now on hepatitis B therapy. There are any number of drugs in various classes that are being looked at. To set the stage, I must say that most, if not all of these studies are in early phases of evaluation and development. Yet you'll notice that there are a number of antivirals in various classes, such as small interfering RNAs, antisense oligonucleotides, HBV core inhibitors, capsule assembly modulators, HBV entry inhibitors, drugs that use CRISPR technology, gene slicing technology. And then you have immunologic approaches through PD-L1 inhibition, TLR agonists, monoclonal antibodies, and therapeutic vaccines are immunologic strategies. And then I'll talk a little bit about what we have seen with cessation or stopping nukes in these patients with chronic hepatitis B. That's, of course, with standard of care that's available out there. Now, if you were to look at a small interfering RNAs, I'll just highlight some of the features this one study with J&J 3989 using siRNA caused a dose-dependent drop in surface antigen. It was more effective in dropping surface antigen than J&J 3989 plus J&J 6379, which is a capsule assembly modulator inhibitor. Then another study, again, it's a phase 2 study that looked at siRNA VIR-2218 along with interferon that was also effective in lowering surface antigen levels. But again, as I emphasized, you can see that there are early phase studies 2 or 2B in this case here with siRNAs. Now, antisense oligonucleotides. And here, this drug, which is bepirovirsen, it caused a dose-dependent change in biomarkers associated with adaptive and innate immunity. It correlated with increased ALT and or decreased HbSAg levels. Another one, ALG 020572, it showed potent dose-dependent antiviral activity both in vitro and in vivo. HBV core inhibitors, CAMs, you have a few studies that were presented, looked at VBR plus nuke therapy for more than 1 year. It led to significant suppression of HBV DNA and pre-genomic RNA. Then, of course, when you stop the drug, it subsequently led to an increase in HBV DNA and pre-genomic RNA. Another one, EDP-514, it appeared to be safe and in patients treated with nuke therapy, and it led to a reduction in HBV DNA. And so there are, signals that suggest that these core inhibitors could be effective. And also I want to point out these studies come primarily from China. And then this one study by Jordan Feld is from Canada. PD-L1 inhibition. I'll just talk about one phase 2A trial of subcutaneously administered PD-L1 antibody, envafolimab, and it's a single dose study. It caused a dose-dependent reduction in surface antigen levels and was well tolerated. And there's another one with envafolimab, and again, it caused modest reduction in surface antigen levels and was well tolerated. Therapeutic vaccines, very interesting. One study I particularly want to point out is with a nasally administered therapeutic vaccine containing surface antigen and hepatitis B correlated antigen mixed with a mucoadhesive. This was an open label study in 71 patients. There's some patients were on a nuke and some patients were not. And it led to some reduction in surface antigen, but was more effective in patients not receiving nuke therapy. So if they had nuke therapy, they were effectively already suppressed and had maximal benefit. And adding this did not lead to any further reduction in surface antigen levels, but it did in those who were not on a nuke. So it's interesting, but not very promising. Now, what about data presented with stopping nukes? As you all may recognize that there is this desire to stop nukes in e-antigen negative patients after a certain period of viral suppression to see if they stay in remission and, of course, if they would have loss of surface antigen through immune rebound. So this is one study that looked at withdrawal of nucleotide analogs in patients with chronic hepatitis B. And this is called the RETRACT-B study. the rationale, as I pointed out, is that with immune rebound, if they do relapse, that they would have loss of surface antigen, or if they don't have an immune rebound, or that they would have durable off-treatment response. It's a retrospective study. It's a global study of 1,557 patients. All these patients were virally suppressed and E antigen negative at nuke cessation. They defined sustained remission as DNA below or equal to 2,000 international units per ml with ALT less than or equal 1.5 times upper limit of normal. Virologic relapse, obviously, was a DNA greater than 2,000 international units per ml. Biochemical relapse, ALT greater than 1.5 times upper limit of normal. And clinical relapse was there was both virological and biochemical relapse. And now there were 11% cirrhotic population in this study, and about 91% were Asians. And what you saw is over time, over 4 years of follow-up, about 30% stayed in sustained remission or had loss of surface antigen. 20% had sustained remission without surface antigen loss over time. So majority relapsed after stopping drugs that suppress the virus. Now, if you were to look at virologic relapse, you'd find that about 65% had virologic relapse defined as a HBV DNA more than 2,000. And then if we were to look at a threshold of 20,000, it was 44% of patients who had such virologic relapse. Clinical relapse was in 40%. Then biochemical relapse defined as more than 1.5 times upper limit of normal if ALT was at 50%, and then about a third of patients had to be retreated. So basically, not many stay in sustained remission over a 4-year period. Only about 30% remained in sustained remission. This was lower in Asians, more than non-Asians, but then 90% of them were Asians in the study. So the study kind of raised the question on the long-term benefit and safety of nuke cessation, and that perhaps they should continue on nukes. But I think, regardless of the study, I think in a non-cirrhotic, it still would be reasonable under protocol and a close observation to stop a nuke after a certain period of viral suppression, preferably at least a year or longer. Ideally, perhaps should be 3 years of viral suppression or longer before you attempt to stop the nuke and see what happens. Now, this is another study from Australia, a 96-week prospective trial. We looked at patients who were E antigen negative, non-cirrhotics, who had viral suppression on nukes for at least 18 months, and that had at least 2 years of treatment. And they looked at cessation of nukes to see what happened. And here are some of the baseline characteristics. They either had entecavir or tenofovir use. Very few had surface antigen level less than 10 international units per ml. And then these are the outcomes. At week 96, after stopping HBV therapy, 31% had to have a nuke restarted, 57% remain in biochemical remission, 28% in virologic remission, and about 6% had surface antigen loss. So you could see that here, again, majority relapsed virologically, in that 72% relapsed, and then half of them had biochemical relapse. What is interesting is that the surface antigen loss was more often in those who had low level of surface antigenemia at the time of stopping the drug. They had HbSAg level less than or equal 10 international units per ml. There's a much higher loss of surface antigen. So what this tells you is that if you had someone who was chronically suppressed, non-cirrhotic, and you had a low-level surface antigen, it might be worth trying to stop the nuke to see if they would lose their surface antigen. Rather interesting. Now, this is a North American study that looked at 192 weeks of tenofovir with or without pegylated interferon for the first 24 weeks, followed by protocolized withdrawal in adults with chronic hepatitis B to see as to what the rate of relapse was and also what the rate of surface antigen loss was. The tenofovir was stopped. Obviously, pegylated interferon was for a short period of time initially, but they continued tenofovir for 192 weeks, and tenofovir was discontinued if the patients were HBe antigen negative, anti-HBe positive, viral DNA was less than 1,000 international units for 24 weeks. And what they found was that it was quite safe to stop tenofovir in these patients who met these predefined protocol criteria. And if you were to look at surface antigen loss, it was similar, 4.5% in tenofovir alone, was 5.7% in tenofovir pegylated interferon. E antigen loss was a little higher in the tenofovir plus pegylated interferon group, and viral DNA plus normal ALT persisted in 45% of the tenofovir withdrawal group and 41% of the tenofovir withdrawal group, but initially also had received pegylated interferon. What is important here is in this study, unlike in a European study, tenofovir plus pegylated interferon did not lead to any greater loss of surface antigen compared to tenofovir treated alone group that had withdrawal of tenofovir after 192 weeks, and this was at 240 weeks of follow-up. Talk about hepatitis C. Well, we all recognize we all participated in a lot of work on hepatitis C, and I must admit that I had been engaged in hepatitis C drug development for quite some time. Disappointingly, there was not much at the annual meeting, and rightly so. We've really done very well with therapy for hepatitis C. The challenge is now identifying patients with hepatitis C and having them treated and then obviously cut down on costs of treatment, etc. So this is again a global burden of disease study looking at 2019 results. And the idea behind this analysis is to look at country-level HCV-related deaths and mortality rates from 1990 to 2019, and also see as to how the progress was towards WHO elimination targets. In 2019, there were about 540,000 deaths attributed to hepatitis C infection in the countries that were part of this analysis. If you were to look at 75% of global HCV deaths, they occurred in the top 20 burden countries in 2019. And only one of these countries on track to meet 2020 targets, which is at least a 10% reduction in mortality. And that's in the Russian Federation. You look at all the other countries, and if you look at India, there has been about a 16% increase in hepatitis C related mortality. So we have really a lot of work to do in efforts to decrease hepatitis C related mortality globally, while we have very effective drugs. Now, this is another analysis from Center for Disease Analysis Foundation that looked at the prevalence of hepatitis C infection globally. In 2015, if you were to look at prevalent viremia, it was about 64 million. And during this time period from 2015 to 2020, about 7.5 million new infection cases were added that evolved under chronic infection. Only about 8.8 million been cured. 5.5 million died, either liver-related or from other causes. And it's 2020, an estimated 57 million viremic individuals were estimated to be in the world. And if you look at prevalence of viremia, I tell you, you'll notice that there are some countries still in the red where there is a high prevalence. A fair number of countries are in the green. And what is important is, given the size of the population in India and China, there are a large number of viremic individuals in these countries that are part of the 59 million infected individuals globally. The red represents, as of 2020, 4.5 to 9.5 million viremic individuals in these countries, India and in China, whereas other countries, it's relatively low. If you were to look at, say, for instance, Australia, they've done a terrific job. It's 0 to 0.2 million viremic individuals estimated to be there. Then it's only a matter of time before they meet WHO target for elimination of hepatitis C. Now, this is a great study, and I think some of it is perhaps already being done in India. I know it's being done in Egypt. It's called the MINMON study. Basically, very minimal evaluation and treatment follow-up to see a sustained virologic response. This is an open-label, multi-country trial in 400 treatment-naive participants with active hepatitis C infection. There's no pre-treatment genotyping done. All 84 tablets of sofosbuvir and velpatasvir were dispensed at baseline. No scheduled on-treatment clinic laboratory visits. 2 remote contacts at week 4 and 22. Bottom line is that 95% achieved sustained virologic response. This is perhaps similar to the Punjab experience, and this is really great, that you give them a course of treatment and then you have a high chance of achieving sustained virologic response without cumbersome or too frequent assessments. I think this should be adopted around the world, even in countries where there are good resources for viral assays, etc. This is an interesting study that would not apply to physicians and patients in India because glucapavir and pibrentasvir are not available in India, I imagine. But it's helpful for patients who have access to drugs. In essence, the ultimate treatment of all virologic failures is sofosbuvir, velpatasvir, and voxilovir. But there are some patients who fail, and this is a retrospective study of patients from UCSF and Kaiser Permanente, but only 12 patients who had failed sofosbuvir, velpatasvir, and voxilovir. And these are patients who had various multiple regimen failures. 8 patients had 2 regimen failures, 2 had 3 failures, and 1 had failed 4 regimens. There were some comorbidities in these patients, but the bottom line is 11 of 11 who had reached SVR 12 point when treated with sofosbuvir, glucapavir, pibrentasvir, and ribavirin achieved a sustained virologic response. This basically opens up another treatment option for patients who failed sofosbuvir, velpatasvir, and voxilovir. And this is the data here of 11 patients who achieved SVR. There were some genotype 3 patients. Genotype 1A was the more common. A few patients who had cirrhosis, and the 12th patient at the time of presentation, the SVR12 data was pending. Now, a bit of data on pregnancy in the context of hepatitis B and C. This is a 7-year nationwide inpatient sample study from 2012 to 2018. This is a US-based study. This involved pregnant women with hepatitis B and hepatitis C diagnosis. Of 28 million pregnant women in this database, 52,000 had HPV infection, 133,000 or approximately had hepatitis C infection. What they noticed was that the disease prevalence increased, that is hepatitis B or C in this pregnant woman from 2012 to 2018. HPV increased sadly from 0.15% to 0.21%. HCV increased as well. While we should have seen a decrease, there was an increase. Patients with HPV are more likely to be Asian or Pacific Islanders. HPV had a higher rate of gestational diabetes. That's an important aspect. And those who had HPV infection, the pregnant women had a higher rate of gestational diabetes. And then those who had HCV and pregnancy, there was a higher rate of preterm labor, all-cause hospital mortality, and a longer length of stay. Now, finally, I want to end up with Delta hepatitis. This may be uncommon in India. Perhaps it's not being looked for commonly in India, and perhaps if we were to look for it, you might find it to be the case in some of your hepatitis B cases. And the experience that's been presented here is with bulevirtide, previously known as miricludex. It is an entry inhibitor, and there is data now that's emerged with this drug. And here is data from a phase 3 clinical trial, MYR 301. There are 3 arms where patients who had no treatment for 48 weeks and then received bulevirtide 10 milligrams a day. There's a 2 milligram per day arm for 144 weeks and a 10 milligram a day arm for 144 weeks. And the primary outcome was undetectable hepatitis D viral RNA, or a decrease by at least 2 logs from baseline ALT normalization at week 48. The key observation is that in the no treatment group, because there were biopsies done, there's no change in the number of hepatitis D antigen positive hepatocytes from baseline. In the 2 milligram dose group, they saw a good number of patients have an undetectable delta antigen positive hepatocytes, and also saw in the 10 milligram group, 14 of 31 had a decrease in delta antigen hepatocyte burden. In the 2 milligram, it was 11 of 21. So clearly, although serologically there is a decrease in delta viral RNA, histologically in a good number, you see decrease in delta antigen positive hepatocytes. And here, if you look at RNA, you can see with 2 milligrams dose, you see a decrease in intrahepatic delta virus RNA, and also at 10 milligrams, you see a decrease in intrahepatic delta virus RNA with treatment, no treatment group, pretty much flat. And then they show a good correlation between delta antigen hepatocytes and the clearance of delta antigen hepatocytes and delta virus RNA in the hepatocyte. So they show a good correlation. In essence, what they concluded was that delta virus replication directly correlated with intrahepatic innate immunity. Now, this is a real-world experience that looked at safety and efficacy of 2 milligrams of bulevirtide in patients with Delta co-infection along with hepatitis B. It's a French early access program. They had patients with compensated cirrhosis or F3 fibrosis, or if it was F2, they had to have an ALT greater than 2 times upper limit normal for at least 6 months. They had patients who received either the oral drug or the oral drug plus pegylated interferon, and viral efficacy was defined as delta virus RNA undetectability or decline of at least 2 logs from baseline, and biochemical efficacy was defined as ALT less than 40 international units per ml. There's a good sized cohort, 77 in the bulevirtide alone group, whereas 68 in the bulevirtide plus pegylated interferon group. And here you can see first here the virologic response defined as undetectable HDV RNA, or at least a 2 log decrease in HDV RNA from baseline. The blue bars represent bulevirtide, and the orange bars represent bulevirtide with plus pegylated interferon. And here at 12 months, particularly with bulevirtide and pegylated interferon, there was higher rate of achieving the virologic endpoint. It was 94% as opposed to 68% with bulevirtide alone. And if you were to look at normalization of ALT, it was relatively more common with bulevirtide compared with bulevirtide plus pegylated interferon. So as you recognize, pegylated interferon is an immunomodulatory drug that enhances cytotoxic T lymphocytes, etc. And so that may be the reason why you see relatively fewer patients having normal ALT, more having abnormal ALT, while there is immunologic attack on the hepatocytes. The response, while it's better with bulevirtide and pegylated interferon, one has to recognize that interferon does have some tolerability issues. And then, of course, will this persist once interferon is stopped is the question. This was a study done until interferon was continued. So we don't know what might happen when interferon is stopped, whether you could see maintenance of such good response. Now, this is another real-world study from Austria, 17 patients who were treated with bulevirtide or with interferon that was added on in those who did not respond to bulevirtide. And here you can see the response to bulevirtide therapy, more than 2 log drop. It's here, blue bar, close to 80% ALT normalization, 90% both. Obviously, 90%. Yeah, 4 patients achieved great suppression. That's what they show here. And then in those non-responders, when interferon was added, there was a further suppression. So the bottom line is bulevirtide works well in suppressing Delta virus RNA. The challenge here is long-term maintenance of such suppressed viremia when you stop the drug. And that has been the challenge with interferon as well in Delta hepatitis. So it's really a tough nut to crack when it comes to treatment. So my take-home points, when I look at what's being presented at AASLD with regard to hepatitis B, C, and Delta virus, hepatitis B and C infections continue to be major global health issues and responsible for huge burden. Still much work to do. We have great therapies for hepatitis C, but still delivering it to the people who need it is the challenge, and hopefully we'll make more progress as time goes by. There are multiple therapeutic strategies that are evolving for hepatitis B, but they're all in early phase development. It may be that you'll need combination therapy, and I don't see anything there in the immediate horizon that one could say has hit the jackpot to lead to eventual loss of surface antigen. There's no major news on hepatitis C virus therapeutic front, some refinement of existing treatments, but again, as I pointed out, it is access that is important that we need to work on. Delta virus is the new kid on the block with new therapeutic strategies. I believe while we've made some progress, there's still a challenge in treatment. So I'll stop at this stage and we'll take any questions. I thank you very much for your attention. And once again, I'm sorry to have missed you all in person, and I hope to see you all perhaps at future meetings in India. Always love to be there and engage myself in talking to you all.
Thank you, Dr. Reddy. And there are a host of questions here already. And one question is that whether the quantitative HbA1c of less than 100 is a good level to stop nukes in EAG negative patients. That's a question from Dr. Sareen. And there are other questions also. We'll take them up.
Yeah, when I guess you can hear me, I'm on mute. So the data I presented from the Australian cohort suggests that the best response of loss of surface antigen was seen in those who had surface antigen level less than 10. But I guess you could certainly use a threshold of 100 or below to stop therapy, but one might not see a similar rate of loss of surface antigen. But I guess any loss of surface antigen is a great one. And then I guess the question is, how well does data in Caucasians apply to others, Asians particularly? So we need to generate good data, but certainly nothing wrong in stopping a nuke with a surface antigen level of less than 100. I'd like to hear if there's any data from India as to what the loss of surface antigen rate might be in such patients.
Another host of questions is whether you should consider the quantitative DNA, or is it better to wait for surface antigen loss before stopping nukes? So isn't it better to have a surface antigen loss than very low viral DNA? So that is a question from many people.
So, I mean, then obviously you're talking about long-term treatment. So if you were to look at surface antigen loss, there are some who do lose surface antigen, and the ones, as I pointed out and is recognized, is the level of surface antigen when you stop the nuke. So I guess if you're a non-cirrhotic and you have suppressed them for 3 years, and you have a low level of surface antigenemia, I guess what is the downside to stopping and seeing as to what happens? You know, will they stay? 20-30% is not a trivial amount. It's not like it's rarely that you see sustained remission. So would you commit a 40-year-old person for therapy for the rest of their life, or most of their life, or would you just give it a trial? That's a big debate, right? So I think if you have the opportunity to follow these patients closely in the non-cirrhotic, I am inclined now more and more to give a trial of stopping therapy and following them very closely. If they have a relapse, well, that's it. You know, they've declared themselves.
Dr. Setubabu has a question.
Yeah, does antibody conversion from HBS loss mean a better result, and does it prevent HCC?
I'll answer the latter one first. I don't believe if patient has had chronic infection and you've facilitated the ultimate cure, that you eliminate the risk of HCC. I mean, we've known that where patients have just had antibody to core, and then these patients had developed liver cancer. The risk might be lower. So that's obviously well recognized. Now, in terms of are you talking about HBsAg seroconversion?
Antibody conversion.
Yeah, right. Yeah,
yes, antibody seroconversion.
Yeah, so loss of surface antigen and developing an anti-HBs. Is that correct? Yes. Well, yes, that's the ultimate cure, right? So that's distinctly uncommon, but it does happen relatively more in Caucasian population than the Asian population. In the Asian population, it's less than 5%. So if that does happen, obviously it is less likely to present a risk of reactivation, but it can happen, but relatively much lower risk. So, but would I continue? If you had the endpoint of surface antigen loss to start treatment, would I continue to develop an antibody to continue treatment to develop an antibody? Now, if you lost surface antigen, after about a 6 months consolidation period, preferably maybe a year consolidation period, I am willing to stop the therapy and not wait for antibody to be present.
We do 6-monthly ultrasound scan. Every 6 months ultrasound scan.
What about it?
Every 6 months we do an ultrasound scan.
Yeah.
There's a question on responder relapsers in hepatitis C towards cirrhotics, and FOX can't be given, and the Abbott drugs are not available in India. So what options do we have for this subset of population?
Someone who's failed soft valpattacivir, right? And then, well, obviously the options are limited, if any, right? I mean, you don't have a GP there. Could you give it for a longer period of time with ribavirin? That's one option. That's a key option that's available. I don't think we really would want to go back to interferon as another drug to add to sulfosylate or valpattacivir. It's just basically you have soft valve for a longer period of time with ribavirin in those soft valve failures, which presumably they're treated for a relatively shorter period of time of 12 weeks.
Thank you, sir. It's been a very interesting and enlightening session. And thanks to all the moderators for being here with us today evening. Thank you very much. And then we move on to the next session now.
All right. Thanks very much. Have fun.
Yeah, thank you. The next session is a talk by Dr. Arun Sanyal. And this is a pre-recorded talk on NAFLD, obesity, and the liver. And Dr. Sanyal is a professor of gastroenterology, specializes in liver diseases, and he is at Richmond, VA, USA. I think let's get on with Professor Sanyal's talk.
Hello, everyone. This is Dr. Arun Sanyal, and it's a pleasure for me to talk to you about the best of the liver meeting with a focus on NASH. Here are my disclosures. So I will cover the new advances and try to place them in perspective with respect to the basic science related to NASH, diagnostics and biomarkers, and where we stand with therapeutic development. So let's start with the basic sciences. A good place to start is to have an overview of the pathogenesis of NASH as it's currently viewed, so that we can frame the new developments in this context. So the disease starts with having a genetic predisposition, but that alone doesn't make you develop NASH. In this setting, when you have a disease initiator, which is typically increased adiposity, whether it is just visceral adiposity, as you see in India, or generalized adiposity, as we see in the West, this leads to two sorts of pathways: disease perpetuating mechanisms and tissue healing mechanisms. And the balance between the two determines the phenotype, whether it is fatty liver or NASH. Now, whether the disease progresses or heals up spontaneously is based on which of these pathways are predominant and what is happening to the disease initiator and how this modulates body's physiology and the balance between tissue injury and tissue healing. And so that leads to either disease resolution, progression, or non-progressive disease. So in this setting, there is growing interest in trying to identify the genetic modulators of disease development and progression. So we know about PNPLA3, we know about other genetic markers related to NASH, but where there's a huge unmet need is to really understand how these different genes interact with each other and whether there is a larger subset of genes which by themselves may not necessarily be that relevant, but could be together maybe more relevant. So also previous studies have been limited by the sample size of the cohorts that have been studied. So this led to this very important, this is I think going to be a very important paper in the field. And this is a GWAS of chronic ALT-based population-defined NAFLD in the Million Veteran Program with histologic and radiological validation. And so they had over 90,000 cases, and of which about 128,000 had normal ALTs. And essentially, they had a phenotype or a phenotypic description of fatty liver disease with elevated liver enzymes, no alternate cause for the elevated liver enzyme, presence of obesity, diabetes, features of the metabolic syndrome, etc. And then they had the controls. And then they had a couple of biopsy-proven fatty liver disease cohorts and a cohort with radiologic hepatic fat imaging. And so this led to development of a polygenic risk score. And as shown on the slide, 7 well-known NAFLD SNPs were reconfirmed over here with PNPLA3 at the top. But then they identified 8 novel SNPs. And these are, I think, very interesting because some of these are targeting metabolic endpoints like SERPIN. Then there is IL-1 receptor, etc., which may be quite relevant. And so these have pleiotropic targets with metabolic and inflammatory readouts. And so they are biologically relevant as well. So these liver traits combined with these metabolic and inflammatory traits are now beginning to give us a larger, more holistic view of how these different genetic polymorphisms can modulate the development and progression of fatty liver disease. Now, the challenge here is that you didn't have biopsy, so you don't really know what the liver looks like. And number two, the real issue is not just whether you get fat in the liver, but do you get the kind of fat that will lead to cirrhosis? And so this is a second paper that came out, but this focuses on children. And this relates NAFLD risk and histological severity with genetic polymorphisms. And this is a nested family trio study from the NASH CRN to investigate candidate SNPs that influence the risk of NAFLD in children. So it's a multi-center study of 822 children with biopsy-confirmed fatty liver disease. And there are 252 complete trios. Now, these trios, when you have the gene from the parents and the child who has the disease, makes it a very powerful genetic tool. And you can really reduce false discovery. So using this, they identified 6 candidate genes and then performed this analysis. And again, reconfirmed not only the PNPLA3 finding, but they identified a novel specific SNP, the PARV-B SNP, which really correlated with fibrosis progression within this pediatric population. This, of course, opens the possibility that we now have to go back and look in adult populations to see whether this also correlates with fibrosis in adults. So I think these are 2 important new additions to the understanding of genetics. Now, talking of fibrosis, which is the most important prognostic outcome feature for NASH, there is another study that was presented as an oral over here, and this is a paper by Matthew Cave showing that environmental pollutant exposures are associated with fatty liver disease severity. And here, essentially what they did was they did untargeted metabolomics in a population of 140 patients with fatty liver disease, and they assessed disease severity with FibroScan, with liver stiffness and CAP. And what they find, as shown in this network analysis on the right, is a correlation with fat and liver stiffness and a number of environmental pollutants, particularly fluorine, PCBs, and diphenylnitrosamine. Diphenylnitrosamine is particularly relevant because of its linkage to hepatocellular carcinoma. We had previously published about 6 years ago data showing increased polyfluorinated fluorocarbons being linked to fatty liver disease. This further confirms that and adds more data to what we had already published. But this really opens up a whole issue of urban NASH versus rural NASH, and whether the environmental exposures in urban settings may lead to different rates of progression in urban setting versus rural setting, and may account for some of the differences in rates of progression in these different areas, even that reported in, say, countries like India. I think this opens up a whole slew of those type of questions and really is quite interesting and needs further assessment both in India and elsewhere. Now, the big story that is emerging in terms of the biology of NASH is this whole concept of metaboinflammation and inflammaging. So inflammaging relates to the physiologic enhancement of inflammation as we all get older. And the biological things that drive this, age-related inflammation, is not only the changes in our body's metabolism, but how our cells handle proteins and can get rid of proteins that no longer are serving a useful purpose, which can lead to macromolecular damage, cell stress, the eventual epigenetic changes that occur, and how all of these impact stem cell regenerative activity, which basically decreases as we get older. And so this network of signaling, which together is called inflammaging, really proceeds sort of in a bow tie manner, where there's an input part which is flared up, there's a central core part that transmits the information, and then there's an output which flares out again. So the fan in basically may lead to activation of receptors that recognize non-self antigens, and these are called PAMPs, which could be viral or bacterial, quasi-self, which could be nutrients or microbiota, and self, which are again misplaced proteins and nucleic acids. And these are assessed by a limited number of sensors, such as toll-like receptors, etc. You have intracellular and you have extracellular receptors, and when they get activated, they fan out into a variety of inflammatory processes with IL-1, IL-18 as part of the innate immune system, NF-kappa B activation, and increase in type 1 interferons. Now, NASH is a prototypic disease of inflammaging where you have accelerated inflammaging. So you change the trajectory of a inflammation. So you are getting the same biology driven by metabolism and metabolic drivers and maybe the microbiome at a much more accelerated rate. And so this is sort of the concept in NASH. To understand the role of these inflammatory cascades, we are actually learning a lot from single-cell RNA-seq, as shown over here, which has identified the relevance of these macrophages, which are positive for TREM2 and are involved with all of these biological processes shown on the slide, from lysosomal activation, endocytosis, MHC activation, etc., which are all linked to lipid catabolism. Now, at this particular AASLD meeting, there's a paper from Anami's group showing single-cell RNA sequencing also further shows Hedgehog signaling to be relevant. So this shows inhibited Hedgehog signaling in hepatocytes as an early event. And in this study, they essentially did deconvoluted liver bulk RNA-seq data from 294 biopsies from patients with fatty liver disease, 68 controls, using single-cell RNA-seq data from 9,600 hepatocytes isolated from smoothened flox mice. And what it shows over here is that in deleting SMO in hepatocytes causes hepatic accumulation of triglycerides and lipids and insulin resistance, whereas in those with high SMO signature, this was significantly depleted in the fatty liver disease cohort compared to controls. I think we need more data because activation of Hedgehog signaling has been linked to fibrosis progression. So these data a little bit go against that. So I think we need more data, particularly to understand how this relates to human disease. Now, the other finding over here is related to regenerative biology, where in this study by Rizvi et al., they looked at VEGF expression and basically VEGF-induced cholangiocyte-driven liver regeneration, which led to reversion of steatosis and fibrosis in a NASH model. So in this NASH model, essentially, they had all these markers over here, and using an AAV8 system, they introduced TBGP21 to mimic impaired hepatocyte proliferation. And then essentially after the injury, injections of nucleoside-modified mRNA encoding VEGF and controls were administered. Now, when you expressed VEGF, which is vascular endothelial growth factor, transiently and in the liver, and this was secreted via liver-targeted delivery, essentially the number of cholangiocyte-derived hepatocytes increased, and there was reversion of steatosis and fibrosis. So this reveals sort of a novel therapeutic pathway linked to cholangiocyte proliferation. We're still a long ways from translating this into any kind of therapeutic approach, but this is an interesting and shows the relevance of this crosstalk between various stem cell compartments, cholangiocytes, hepatocytes, which we historically thought were, if you're a cholangiocyte, you're a cholangiocyte. If you're a hepatocyte, you're a hepatocyte. But now we're learning that there is plasticity in terms of phenotype. And so the cell phenotype can move based on the local environment. And this shows that it is possible to manipulate that. And that is really the potential significance of this finding. And of course, this requires additional work and translation to make it clinically relevant down the road. So where we've landed now in terms of understanding the biology of the disease is that thanks to insulin resistance, etc., you get lipotoxicity, which then leads to ER stress, mitochondrial dysfunction within the hepatocyte, and linked to steatosis. Now this triggers, on the one hand, injury to the cell leading to cell death. On the other hand, it leads to activation of a number of these pathways, of which Notch and YAP seem to be very important pathways, which lead to metabolic reprogramming of the hepatocyte, which if severe enough can trigger again cell death, but on the other hand can trigger osteopontin and downstream of that hedgehog signaling, and of course there's hedgehog ligands being released, and all of these lead to fibrogenic activation and progressive fibrosis. Now YAP-TAZ, these are also linked to cell proliferation and lead to new hepatocytes, and of course this creates the potential for genomic instability and hepatocellular carcinoma, and the activation of hepatocytes and hepatic stellate cells further lead to infiltration of immune cells, so adding a component of adaptive immune as well as innate immune system inflammation within the liver, providing a holistic full picture of how the metabolic changes lead to steatosis, cell injury, and link to inflammatory activation and fibrosis and eventually hepatocellular carcinoma. So next, let's move on to talk about histological assessment and tracking the dynamic nature of fibrosis. And what has emerged first is to understand how we evaluate histology in the setting of clinical trials. And over the last 2-3 years, there's been a lot of interest and focus on the fact that histology is subjective. So the pathologists are reviewing this, and it is in the eye of the beholder. So when you have two pathologists or even the same pathologist look at the biopsy on different days, they sometimes come to different answers. And that leads to problems, because then the evidence that we are generating on the histological benefits of therapy are very muddy and noisy. So this is a study that we did over here from the Regenerate trial, where we took 200 biopsies, and these are the same 200 biopsies. Now we had two panels of pathologists, panel A and panel B, and in each of these we had 3 pathologists in each panel. And what we did was we had all pathologists review the biopsy by themselves and then as a group, and then we looked at their concordance statistics. And as you can see, first of all, that these are just regular pathologists who are board certified in liver pathology, that they're getting kappas that are pretty comparable by and large to what has been described, even when you have well-known academic pathologists reviewing the histology, as shown on the left. Then we compared panel A versus panel B, and you can see very high levels of concordance between these different panels. Now, one of the most important things we did in this was, of the 3 pathologists, if 2 of them agreed, we said that's the mode, right? That's the most common agreement. And so if you want to ask the question, if you knowing that there will never be full concordance between all pathologists, that if you showed the same biopsies to 100 pathologists, would the majority of them agree that a drug is effective or not? So we took the mode, and that's the difference between this study and previous studies. And what we find by doing that, and now we can see a pretty high and good concordance between panel A and panel B. And this is actually quite comparable to concordance of large pathology groups like the NASH CRN, and these are data that we published in 2005, and these are from our 2019 paper. And you can see this panel A versus panel B using just regular pathologists gives you very similar data with appropriate training, and this particular way of looking at histology where you look at the mode rather than a mean. The next story that is emerging in pathology is the idea that fibrosis is very dynamic, and we need to be able to capture that in order to better capture the benefits of drug therapy. So from hepatitis B and use of single harmonic generated images of the liver, what we realized is that it's not just about noting the fibrosis stages. There may be changes in fibril septal thickness as well as cellularity that may change and may also provide additional information. So we tested the hypothesis that a combination of the total collagen burden, the fibrosis septal thickness, and cellularity together, which generates what we call a Q fibrosis score in a machine learned way, may actually allow us greater insight. So we looked specifically in the Topic of AASLD trial that we had published last year, And what we look here is the conventional histology of people who had progression, regression, shown in green, progression in orange, and unchanged fibrosis stage in the gray in the middle. So we now targeted this unchanged group because this is the largest chunk. It's 2/3 of the patients. And then we applied the Q fibrosis score. And what we find over here, that it pretty dramatically changes it, where in the placebo arm, many of these non-changed now are in the progressive arm. And then at the high dose tropifexor, most of them are in the regressive arm. So this provides us 5 scenarios where you went from progressive by conventional histology to progressive by Q fibrosis, no change to progressive, no change, no change, no change regressive, and regressive to regressive. So this now allows us to assess the validity of our approach. So on this slide, what you see are on the left those who went from progressive by conventional histology, progressed 1 stage, and what were the parameters of the Q fibrosis score that went up. And on the right are those parameters in those who had 1 stage or more regression that went down. Now in the middle are the 3 groups who were originally unchanged but now are reclassified as progressive, regressive, or unchanged. And you can see the ones that were progressive, it was the same parameters that went up. Those that were regressive, the same parameters were the ones that went down in those who actually had a 1 stage or more regression, and the unchanged remain unchanged. So very strong proof over here about its validity. And here's one of the parameters of fibrosis measured by single harmonic generation string length, which again shows similar. And this is basically, there are 16 parameters in this formula. All were basically tested. And essentially what you find over here is you can see this nice relative correlation with pathologous fibrosis staging over here. Furthermore, when you look at septal width, you see the same thing. In those who progressed, septal width tended to increase. Those who regressed, septal width decreased. And again, you're seeing the similar pattern in the middle. Similarly, you're seeing changes in the cellularity of the septa. The concordance of these, of course, with pathology fibrosis staging, if you look at the Q fibrosis score based on the individual collagen fibrillar properties measured by second harmonic, it's a nice linear relationship. Similarly, septal width tend to correlate particularly with fibrosis stage 2 onwards because there are no septa in 0 and 1, so you don't expect anything here. And then when you look at the cellularity, you see the cellularity of the septa initially increase, but then as you move into cirrhosis, they start decreasing. And then finally, we looked at an animal model where we were sure we were capturing disease progression because animals were on the high-fat diet with injury. And then we stopped and reverted to chow diet. So we knew we were reversing the disease and the fibrosis reversed. So once again, we see the very same Q fibrosis score. The parameters that went up in our human data are also going up in the mouse data. The ones that went down also went down in the mouse data. And you see similar data for fibrosis, septal width, and cellularity. So together, these provide strong validation that we can now, using second harmonic generated images and capturing these different parameters, get a view of the dynamic nature of fibrosis development and fibrosis regression, where you initially have collagen fibers with inflammatory cells. Then this leads to fine collagen fibers collapsed into denser bundles with less inflammatory cells. The inflammation disappears, leaving tightly packed cross-linked collagen. And then as you start healing, you start seeing regenerative hepatocytes appear, breaking up the collagen fibrils and narrowing down, thinning off the collagen fibrils. So based on this, you can, by looking at a biopsy at one point in time and looking at all these parameters, you can now sense whether the collagen septa is actually in progressive mode or in regressive mode. Now imagine you can use this now in clinical trials to pick only those who are in progressive mode to put them into treatment trials, because previously you couldn't tell based on conventional histology. Similarly, it might allow you in early phase trials to pick up changes that may not be evident, because to move a full stage by conventional histology requires a lot of fibrosis change, which you may not see within 1 year, which is the usual time frame of a typical phase 2b trial. Now, moving on to biomarkers and integration of non-invasive tests into clinical practice. We first remember that a biomarker is an objective patient characteristic that is measured as an indicator of normal biological processes, pathogenic processes, and biological responses. An assay method is needed to measure the biomarker, but the assay method is not the biomarker. And one biomarker can have multiple assays that are capable of measuring it. There are many different types of biomarkers depending on what function they are serving. And this is called fit for purpose. So in the biomarker lingo, you will often hear the word fit for purpose, and it means that the biomarker is specifically being used for a very specific reason in a specific context. And that's called the context of use. And these are the various types of contexts of use. And so the evidence needed to really bring a biomarker all the way to market. First, you have to define the context of use, which defines unmet need, which population, when will the test be used, what will be the readout, how will it be interpreted, what will be the decision making that will occur on the basis of this biomarker readout, and what will be the benefit that will accrue. Then you have to generate the evidence, which requires analytic elements. How robust is your analytic approach? Establishing sensitivity, specificity. And then you have to assess the evidence in terms of the utility, which means based on sensitivity, specificity, what is the positive or negative predictive value? What is the performance across various populations? And what are the implications of misclassification? So not pretty much 99 to 100% of the biomarker literature in hepatology and NASH does not really go through this in a systematic manner. And so most of these, at least in the US, the regulatory agencies will not accept as for approval because there are these huge evidence gaps. So to address this, the NIMBLE consortium was set up, and we just read out stage 1 of NIMBLE. So this is a collaboration between NIMBLE and the NASH CRN, and performed a comparative assessment against histology of 5 blood-based biomarker panels for their respective intended uses. Very important, all tests were run on different aliquots of the same blood sample obtained within 90 days. And all biopsies were read in a masked manner by the NASH CRN committee using a pre-specified protocol and without any information about biomarker or clinical metadata. And the sample set was curated so that you had equal numbers relatively of people with stage 0, 1, 2, 3, and 4, so that there was no spectrum bias, which is a very important problem in developing biomarkers and generating evidence. So there was no spectrum bias. So this is the most rigorously collected data set. Now here are the different contexts of use. So we looked at NIS4, the owl liver, ELF, ProC3, and fibrometer VCTE. Of the readouts and the components are shown at the bottom. Of these, only NIS4 was meant for at-risk NASH, which is NASH, which is as defined by steatohepatitis with a NAS of 4 or higher and fibrosis stage 2 or higher. Owl liver was only for the NASH and activity, whereas the ELF, ProC3, and fibrometer VCTE were only for fibrosis. So here is we had two hypotheses. First, that it had to be better than OROC, had to be convincingly higher than 0.7 and superior to 0.5. The second was that OROC was superior to ALT for the ones for NASH and high NAS, and for FIB4 for fibrosis. So you see over here that NIS4 had OROCs from 0.81 to 0.83, significantly superior to ALT. And these are the Youden cutoffs for sensitivity specificity. Then when you look at it for fibrosis, you can see for greater than fibrosis stage 2, the OROC was 0.87, very high, but declined to 0.78 and 0.72 as you narrowed the population to stage 3 and stage 4 only. And it's only for greater or equal to stage 2 that it was superior to FIB4. As you got to more advanced fibrosis, it was no longer superior to FIB4. So it's front-loaded. Its value is front-loaded to capture people with stage 2, maybe early stage 3. But the further advanced the disease becomes, is not quite as good. But it does pick up active NASH. Now, the owl liver, they provided a readout as a categorical yes or no. So we could not create an OROC. But for at-risk NASH, It provided a sensitivity of 63, specificity of 75.4, not bad, but not terrific either. The ELF test, which is developed for fibrosis. Now, if you look at greater or equal to stage 2, it is 0.82, and then went up to 0.85 for cirrhosis. OROC for Fib is not bad, Fib4. It's 0.79, went up to 0.81. But for all of these, ELF outperformed Fib4. And here are the corresponding sensitivity and specificities, pushing up into the 80 and 70% range. So these are well within the acceptable ranges for the these diagnostic contexts of use. And then with PRO-C3, unfortunately, did not outperform Fib4 for any of the fibrosis parameters. Now, when you look at fibrometer VCTE, it went from 0.84 to almost 0.9. And over here, this is a subset of the population because we had a 90-day very strict window to have fibroscan from the biopsy. And of this total cohort of over 1,000 patients, only 393 actually had a fibroscan within that 90-day window. And so we only did this analysis in this population, but it was balanced in terms of fibrosis severity. And here again, you see the numbers are a little bit different, but it's outperforming Fib4 quite significantly, although Fib4 itself for cirrhosis had an OROC of 0.83, which is excellent. And these are all rigorously compared against histology. So I think this has now given us the tools, and we have initial feedback from regulatory agencies that this may allow for the diagnostic context of use to identify the patient with NASH who's going to get in trouble. That is NASH, high activity, fibrosis stage 2 or higher. We're now pretty much able to diagnose this non-invasively with good accuracy. And so hopefully this biomarker qualification plan will go in the second quarter of 22. And by the end of the year, we hope we will have met this milestone. And we'll see what the FDA has to say. They may ask for more prospective validation. We'll see. So next is there are other approaches. Other groups have been looking at machine learned approaches to identify fibrotic NASH, same population in clinics. And this is a paper from the Cleveland Clinic, where they use a machine learned approach. And basically, this is really, again, a AST-based machine learned approach that essentially provides a very high OROC to identify those who have NASH-related fibrotic NASH. And once again, over here, it tended to outperform Fib4. So this is early data, needs to be confirmed by others. Another tool that's been developed combines MRI PDFF with MR elastography and AST to predict NASH on liver biopsy. And this was looked at in a clinical trial called the Maestro NASH, which is a resmetirom trial. And essentially the bottom line here is that if you look at the distribution of people with high NAS, you can see the mass scores actually can correlate. And also of those in this phase 2 trial who had histologic improvement, a reduction in the mass scores was seen in those who had histological improvement. The sensitivity, specificity, and the precision of identifying histologic response, I think still needs work, although the authors here made a pretty brash, they made a statement that, this allows a robust, non-invasive tool. So I think the robustness we can argue about, but it is very interesting and very, very promising, and the data look very, very good. It just needs a little more validation to say that this is ready for prime time. Now, another new platform, which is more in the early discovery phase, relates to the Glimpse platform. And this is based on the idea that all biological processes are associated with activation of proteases. And if you can capture the protease signature, you know what kind of biological process is going on. So the original platform involved injecting a biotracer into the patient and then collecting urine. These biotracers were cleaved by the proteases in a specific way, and you looked at the cleavage products in urine. And this was originally developed to identify NASH, as well as fibrosis. This is very cumbersome. So there's a new tool that they've developed where they essentially took a sample of blood and they put the biosensor into the blood in the test tube. So it's ex vivo, and then looked at the cleavage, and the appearance of the cleavage product was captured as a kinetic assay to then develop this NASH classifier. And with this, bottom line, what we show over here is that the OROC for identification of NASH versus lean healthy is very, very good. And so you could ask, why look at NASH? Why not compare fatty liver versus NASH, which is a more biological and clinically relevant question? And the reason is this is very early stage. We want to show if you can identify the two extreme phenotypes, because if you can identify the two extreme phenotypes, then the rationale to do a bigger study to see if you can separate fatty liver from NASH is reasonable. If you fail at this, there's no reason to go forward. And so out of this study, it accurately identified 11 out of 12 healthy people and 68 out of 76 patients with fatty liver disease. And the specific proteases that were activated, they're listed over here. We looked at the biological targets of the proteases. And what we see is that these are largely linked to inflammation and fibrosis biosensors. Interestingly, cathepsin and DPP4 emerge as important biomarkers over here. So DPP4 and its relationship to fibrosis is very interesting because, you know, it is quite possible that as you get, you know, the DPP4 is linked to insulin and GLP-1 activity, and that there may be a flattening of the incretin curve because of exaggerated DPP4 activity. And so, again, provides a rationale and maybe a biosensor for GLP-1 based therapeutics down the road. But that's all conjectural. None of this there's the data for. So this is very early phase and have to be confirmed in further studies. We also looked at something called the Metabolic Vulnerability Index. And this is a brand new model that's been developed primarily in the cardiology space and has two subcomponents. There is a what's called a inflammation index based on HDL subclasses, and then there is a metabolic index which is based on sort of a signature of metabolic reprogramming in advanced diabetes and cardiovascular disease. And since the same biology plays out in NASH, we thought we would check to see how it related to outcomes in a NASH population. So we looked at basically 1,663 patients, 75% with NASH, and looked at their outcomes. And what we see is while the lowest three quartiles are clustered together, the fourth quartile was very tightly related to all-cause mortality. It's related to liver-related events, liver-related death, but interestingly, we did not find a correlation with cardiac events or cancer. So, but remember, it was originally developed for a very high-risk population with a 20% cardiovascular event rate. And so, given that our cardiovascular event rates were much lower, it is possible that our cardiovascular risk profile was different, and that's why we didn't see it. But certainly, it's striking and very strong data that this correlates with liver-related outcomes, and we tend to take this forward as a prognostic biomarker. Now, these were all diagnostic and prognostic. Now, in terms of prognostic, there's also something called disease monitoring, where you look at changes in biomarker over time related to changes in risk profile over time. So these are data using MR elastography over time and looking at hepatic decompensation events. And what you see over here is that based on baseline MR elastography, you can see clear separation. So events, cardiovascular disease risk events are again collinearly related to fibrosis progression in the liver. So the stiffer your liver, the more cardiovascular disease you have. And so this is all, I think, shows again what is already sort of known, that there is a collinearity between progression of liver disease and the progression of cardiovascular disease and renal disease and CKD. They didn't study CKD, but they studied cardiovascular disease in this population. Now, the last part of the talk really relates to therapeutics, which unfortunately we don't have a lot of great news from the advanced clinical trials, but some of the early trials are promising, and let me review these with you. So here are the various abstracts that were presented at AASLD, and I will pick on the ones that I think are likely to be most impactful or worth knowing at this point. First, there's a paper on intensive lifestyle management in a pediatric study, and again shows that you indeed can shift the needle with intensive fibrosis improvement, with improvement in CAP score. But again, The issue is, if you have advanced disease, can you actually cause regression of advanced disease? And that really remains the question. So more to come on this. Another study looked at a hypocaloric Mediterranean diet versus standard diet in a biopsy-proven fatty liver disease population. And in this study, small numbers, you will see 27 and 32. And again, you see improvement in elastography. And it's a modest improvement. It's not that dramatic. You have improvement in APRI, and there is the FIB4 really did not shift. And so weight loss is an improved surrogate marker, but when they looked at histology over here, there were some changes, but this is a small study. Whether this is enough to actually make comprehensive statements, I think remains to be shown. So interesting, but not enough to say this needs to go into a practice guideline at this point based on this evidence. Another early phase study looked at berberine, which has been in use in China as a natural medicine for a long time, but essentially over here in this 18-week placebo-controlled study with 100 patients, there was, while weight did not change, there was a significant improvement in A1C and diabetes. So this is now going to move forward, and this has actually come out in press in Nature Communications recently. Another study that has now been presented was vonopexor, which is a FXR agonist from Enya. And essentially, we've seen data with obeticholic acid, we've seen data with tropifexor, we've seen data with metacrin, but these are data with vonopexor, and once again, very similar to what has been seen with the other FXR agonists. You have improvement in liver fat content, ALT, etc., corrected T1, and particularly you can see a fairly substantial decrease in corrected T1 with vonopexor 200 milligrams. But what is different here is that you see a significant improvement in GFR with vonopexor, which is unique because other FXR agonists do not show this. And so given that this is a population with a lot of chronic kidney disease, this is fascinating information. It'll be very important to see whether this translates actually in the next set of studies and is a reproducible set of findings. Because if it is, this will really have an impact on NASH, because many of our patients do have chronic kidney disease as well. The other study that came out is the Proximo study, which is a novel incretin coagonist, and essentially is a GLP-1 and a glucagon agonist. So glucagon has direct hepatic receptors, where GLP-1 only works in the periphery on adipose tissue and muscle, etc., and centrally to reduce appetite. So the idea here is that by including glucagon, you will have additional liver benefits of defatting the liver, improving mitochondrial turnover and generating healthy mitochondria, and also reducing oxidative stress, all of which should reduce fibrosis in the end. So in this phase 2A proof of concept study with 74 patients, what we showed over here is that there was an improvement in liver enzymes, improvement in fibrogenic markers, and of course, significant improvement in steatosis, inflammatory markers, etc. So I think they are moving now into phase 2B, phase 3 combined seamless trials for their more advanced phase. And histology is, of course, where the rubber meets the road. Unfortunately, for trials that are in advanced phase, the results were not very exciting. So Alpine 2 and 3 is a advanced phase study of FGF19, where they looked at 3 different doses, and this is a 6-month study. The baseline demographic criteria are pretty similar to what's seen in other trials. The endpoints were also very similar, and what you see here is that while NASH resolution improved, fibrosis improvement didn't, and their a priori endpoint was fibrosis improvement, so they basically, it was a failed study, and they have stopped development for NASH. But I do believe, based on the stepwise dose-dependent improvement in NASH resolution that I just showed you, and the decrease in liver fat, decrease in ALT, decrease in AST, decrease in fibrogenic markers, that the drug itself is biologically active. So it's my personal opinion that they threw away a good drug, but that's the decision of the company itself. They are still pursuing a cirrhosis trial, so we'll see. So pegbelfermin is the other one, which is FGF21. In the phase 1 study, we showed that it reduced liver fat, reduced liver enzymes, and they went into a histology study. So Falcon 1 is a study based on patients with bridging fibrosis, and it's 197 patients, 3 active arms, 1 placebo, but unfortunately, really no clear benefit either by PDFF, fibrosis improvement, or MR elastography. So this is very, very disappointing. Similarly, Falcon 2, which looked at the cirrhotic population, had a completely negative readout. Now, last year we showed that tropifexor by itself really didn't have much of a readout. So this is a combination study of tropifexor with cenicriviroc, which also in itself has a pretty non-impressive profile of benefit. So when you look at the combination, no surprises here. There was no really significant effect of benefit in this phase 2b trial. And these are the data from the Falcon B2 trial that I already mentioned, where as you can see, no evidence of any histological benefit. Now, another study over here, which is sort of more interesting, is using statins and looked at preservation of liver function as measured using a test called HepQuant, which is based on clearance of bile acids. Now, whether this actually means anything clinically, I think is an open question, but this is certainly very interesting data. As you know, the use of statins in cirrhosis is a very hot topic, and there are multiple trials now ongoing looking at statins to reduce all-cause mortality and liver-related outcomes in compensated cirrhosis. So it'll be very interesting to see over here how this all pans out and whether this particular HepQuant test can be used as a way for an early readout of clinical benefit when treating with statins for this purpose. So in the end, what will it take to reduce the burden of disease? We need more data around population, and we already have a lot of data around the burden of disease. We already have a lot of data on disease biology, but we need to have a cleaner idea of the druggable targets and which ones are relevant in which patient and bring them into human trials. So there's tremendous room for improvement in human trials by targeting the right target in the right patient at the right point in time, and which we have not done so far. And I think this is one of the reasons why so many trials are failing. We need biomarkers to allow us to do that. And so the NIMBLE initiative that I just showed you data from, the Litmus initiative, these will contribute to this process. And once we have simple, non-invasive ways of identifying patients, evaluating patients, finding which drug will work best for which patient, and following whether the drug is working or not for those patients, that will allow us to engage in a larger awareness and access to care, and just like we've done for hepatitis C. And this will be linked to health policy implementation sides, effectiveness, and then which eventually should reduce the burden of disease. So with that,
thank you for the talk, and we have a very eminent panel today here to give us some comments on these talks. Dr. Ajay Duseja, Professor of Hepatology at PGI Chandigarh, Dr. N. Murugan, who heads the gastro department at Apollo, and Dr. Dharmesh Kapoor from Yashda Hospital, Hyderabad, a very senior consultant. So since we are behind time, I think I would appreciate some comments rather than questions, because Dr. Sanyal is not online. So I think that would be appreciated from the panel. Dr. Duseja?
Yes.
Dharmesh? Hi, Ajay.
Okay, hi, Dr.
Yeah.
So I think very nice information, very exciting information by Professor Sanyal on this fatty liver disease. Maybe I just thought small comments on the Indian perspective, I thought, which would be maybe relevant. So he did speak about, the environmental pollutant study, which showed that they could be the culprit in the pathogenesis. And I think he very rightly pointed out, and which would be relevant to Indian population, because in India, we all have shown there's a rural-urban divide in the prevalence of fatty liver disease. So I think environmental, though we have seen that there could be dietary differences, there could be differences in metabolic risk factors, genetics probably is the same. So I think environmental pollutant would be one more thing which probably would need that. He did speak about, the nimble and the various, kind of biomarkers which were used, and then they correlated with the NASH, CR, and histology. The problem with those biomarkers, especially for Indian setup, I would say they are all patented, kind of biomarkers, whatever it's the ELF or the, NIS4 or the all liver or whatever. So I think he also showed that the FIB4 was inferior to these, but FIB4 was not bad. So I think for our setup, and especially for the referral purposes, I personally feel I think FIB4 is a very good test, which I think we should continue. The third thing which he showed a study on the MAST, which is an MRI based, with the MR PDFF, MR elastography, and the AST. But we also have a FAST score, which was published, last year. And we have Indian validation on that, which is based on FibroScan. So you don't need an MR. So we would need to compare FAST with MAST and see, in an Indian setup, whether the FAST is as good or this thing. Absolutely. I think maybe I'll leave it there and yeah, sure.
Yeah. So thank you, Dr. Ajay. I think Dharmesh is also anxious to make some comments.
Yeah, sure.
Dharmesh,
I think they are not very
moving.
They are not very positive ones, Dr. Vinay, because I think
comments are welcome.
A lot of noise and thunder, but hardly any signs of rain from what he's described. So I think all in all, little despondence. I would say maybe something I keep telling to Dr. Ajay, because he's a stalwart in this area and has done such seminal work, that probably we are doing the wrong thing by trying to target what the West is doing. They have got a regulatory authority which wants you to attack the fibrosis. Maybe in our country, where resources are so constrained, we should probably be looking at fat and the cardiovascular outcomes in these patients. And we know that very early on we can target these rather than at a later stage. So I think
very true. Yeah. Thank you, Dharmesh. A quick comment from Dr. Murugan, if he's there, then we move on to the next session. So I think more or less we have wound up. Thank you. Thanks to the moderators, and now we move on to the next talk. Thank you and good night.
Thank you.
Yes, bye.
So we move on now to the next talk now, which is on alcohol-associated hepatitis by Dr. Gyeonggi Sabo, and she's really an academic giant. Actually, you can see on the editorial board of Hepatology and several other journals, and she's based in Massachusetts, where she's the vice chair of medicine, and let's hear it from her.
Hello, my name is Gideon Hirschfeld. I am a hepatologist based at the University of Toronto. And
we need the alcoholic hepatitis talk. In the meantime, Dr. Usha Datta would have joined us. She is the professor and HOD of GI at PGI Chandigarh. Dr. Rajesh Gupta, I invite you. He is at AIG at Hyderabad, and Dr. Mithun Sharma, who is also from AIG, and you're welcome to the panel.
Thank you. I think we can start the lecture from Dr. Gyeonggi Sabo.
Hello, my name is Gyeonggi Sabo, and it's my pleasure to report to you on alcohol-associated liver disease from the 2021 liver meeting of the American Association for Studies of Liver Disease. I wanted to thank Professor Serene for the opportunity to invite me to do this presentation. These are my disclosures. None of them has any direct relevance to the presentation today. During this presentation, actually, I'm going to use some overall themes that emerged during this very exciting remote and virtual meeting. And as you know, alcoholic liver disease and alcohol-associated liver disease has multiple components in the pathogenesis. It is a major cause of liver-related morbidity and mortality in the US and in the world. And alcoholic hepatitis in general is a life-threatening form of the alcoholic liver disease. There are many key manifestations in alcoholic liver disease, and from the standpoint of pathomechanism, one of that is the immune cell infiltration and activation, especially neutrophils, leading to liver injury. And as we well know, there is urgent need to develop safe and effective targeted therapies for severe alcoholic hepatitis in particular, but in general for alcoholic liver disease. So during the liver meeting, several of the components of the alcoholic liver disease have been addressed, including many talks focusing on increased gut permeability and microbial host interactions that potentially could be target in future therapeutic development. We learned a lot about pathomechanisms that I will try to summarize during this talk. So the liver meeting started out with a special session of the alcohol-associated liver disease special interest group that focused on alcohol-associated liver disease in special populations. And Dr. Singhal was the one who introduced this session, pointing out that the estimate on direct patient care for alcoholic liver disease is about $23 billion in the US, which is really a astonishing number. And in fact, if you look at the percent of cirrhosis cases, about 60% of those can be attributed to alcohol, and about 40% of cirrhotic death actually is also related to alcohol, really underlining the importance of this topic. The prevalence of alcoholic liver disease is increasing in the US, and in fact it's increasing in a way that in recent years, between 2014 and 16, we find that the total number of alcoholic fatty liver disease has increased among the in the US population, and also there is some increase in fibrosis with a greater than stage 2. And this is defined as alcohol use greater than 28 grams in women and 48 grams per day in men, with the AST-ALT ratio that's pathognomic for alcoholic liver disease. So this suggests that indeed, if anything, this is a major health problem. And in fact, if you look at the various states, a few state representative states such as Massachusetts, Washington State, Florida, and New York, and looking at the increasing incidence of alcoholic hepatitis hospitalization, particularly among the age group of 20 to 39 years old, then we find that there is an increase, and then there's a very steep increase in the younger population, but there is also a general increase in the ages 50 to 59, 60 to 69, and even in the older population, suggesting that again, there is increased hospitalization triggered by alcoholic liver disease. The other major concern is that the mortality due to alcoholic cirrhosis is rising in the US, especially in young adults. So if you look at the alcohol use disorder frequency, you see that it has actually increased. And it's the highest in the younger adult population between ages 20 to 34 compared to others. And even the cirrhotic-related liver disease and cirrhosis is the average annual percent change in recent years is the greatest in the young adult population compared to the older ones. And based on these observations, it has been recommended by the special interest groups that at-risk individuals should be screened for the presence or absence of liver disease. So with the screening method should include liver chemistry, ALT, bilirubin, and so forth, urgent referral to hepatology for patients with cirrhosis, and also non-invasive assessment of fibrotic risk factors using serological and radiological markers would be recommended for those without cirrhosis. Furthermore, counseling and management for alcohol abstinence for any spectrum of liver disease is recommended. And here it was noted that recommended screening instrument would be the audit or the audit-C questionnaire. Now, in a recent study that is in press from Dr. Singhal's group, there is a really nice algorithms for the multidisciplinary care model, how to manage liver disease and alcohol use disorder in these patients. And the major message, I think, from the meeting and in general in the field is that as hepatologists, we want to manage not only the liver disease, but in fact need to recognize the underlying importance of the alcohol use disorder and try to address that early on in the disease, and even after recovery from an episode of alcoholic hepatitis, then really focus on the alcohol use disorder component to prevent recidivism of alcohol use in patients that very clearly has been shown to increase the future likelihood of repeated episodes of alcoholic hepatitis, and also reduce survival. So the algorithm says that patients without apparent liver disease, if they have harmful alcohol use, then they should be screened for alcoholic liver disease, and they should be screened for fibrosis using non-invasive markers. And if they have a high risk, such as a FIB4 of greater than 3.25 or other indications of fibrosis, then they should be referred to an integrated multidisciplinary clinic where hepatology and addiction teams work together to guide these patients. In patients who do have apparent liver disease and also have harmful alcohol use, then there's obviously need assessment for the with the audit or with DSM-5 for alcohol dependence, and then depending on their score, they either need a brief intervention or a more complex integrated multidisciplinary team approach. Now, the take-home messages from this special interest group was then healthcare burden of alcoholic liver disease is enormous and increasing, especially in young, at the prime of the productive time of their life. Strategies are needed to screen alcohol use at every encounter. At-risk individuals should be screened for liver disease. The amount and harmful pattern of alcohol use is a major contributor, and strategies to better manage alcohol use disorder in patients with liver disease is really important, and potentially federal and state-wide policies to reduce availability of alcohol and targeting youth could be useful. And long-term natural history studies on alcoholic liver disease, particularly in young, are needed to better understand the complexity of this question. This special interest group also looked at various special populations, including women and alcohol-associated liver disease in women. And I had the privilege to actually summarize this particular talk. And it turns out that increasing evidence suggests that women now drink as much as men. And as you know, for nearly a century in the past, women have been considering closing the gender gap, and that is actually true for alcohol consumption. And binge drinking and alcohol use is increasing, and the previous 3-to-1 ratio for risky drinking habits between men and women is now closer to 1-to-1 globally, based on a 2016 analysis. So this means that women who are more susceptible to the untoward effects of alcohol drink just as much as men. And in fact, it has been reported that if you look on the left, the monthly alcohol use in the US between men is about 59% of individuals reported drinking alcohol in men and 51% in women. So really the difference is not that much. And the most recent data from 2019 from the US shows that women in their teens and early 20s reported drinking and getting drunk at higher risk than their male partners, which essentially is a very troubling trend. Now, some of the special consideration is that, and here I'm going to refer to sex, because sex is assigned at birth, whether as opposed to gender, that is how a person identifies him or herself. So sex differences exist in all aspects of alcohol use disorder and alcoholic liver disease. However, these are only partially recognized. And attention to sex difference in the alcohol use and its biological effect is minimal, both in medicine and in the society, which is really concerning. And I think as hepatologists, we really need to change this paradigm, and it's our responsibility to educate our patients and the society in general about these very important sex differences in alcohol use and its biological effects. More importantly, if you look in the literature, then sex differences in alcohol's effects are not considered in most studies and clinical trials. That again is calling for a major change in the future. So just to give some examples, there is no mention of sex-specific differences in some of the recent guidelines. So for example, the ACG clinical guideline on alcoholic liver disease has no mention of sex differences. Even the EASL clinical practice guidelines doesn't include any of this, and this is really an opportunity to change in the future, and particularly because it's very well known that women have a lower threshold for alcohol-associated liver disease compared to men. And as opposed to men, where the kind of threshold is somewhere about 36 to 48 gram alcohol per day consumption in men. In women, it's about 12 to 24 gram per alcohol per day for the threshold that is associated with development of alcohol-associated liver disease, substantially lower. And I think this difference is really not emphasized enough. I want to this session at the liver meeting also pointed out that the biological factors contributing to alcohol-associated liver disease in women and the sex differences is really not well understood. And this is yet another area where further research is needed. So, you know, some of the factors that have been in the textbooks for a long time, including the potential differences in alcohol metabolism, activation of Kupffer cells in females, partially related to sex hormones, is suggested. However, these studies are not really well defined, and further understanding is absolutely needed to explain these sex differences. So summary and recommendations are that there is an urgent need to educate women about sex differences in the effects of alcohol on the liver and other organs, by the way. Particular attention should be given to young adult women about alcohol use disorder and alcoholic liver disease. Women should be included in clinical trials in alcoholic liver disease, and we definitely need new studies to better understand the biology behind sex differences in the effects of alcohol. One of the presentations from Dr. Dunn focused on alcoholic liver disease in obese population, where it was pointed out that the effects of alcohol on the adipose tissue itself is complex and has various effects on the metabolic components, on endocrine effects, and also on immune effects that in turn contribute to the development of alcoholic fatty liver disease and alcoholic liver disease in general. And in fact, the various studies, and here's just one example from the UK Million Women study that showed interaction between alcohol, obesity, and incidence of cirrhosis. And the diagram on the right shows that with the green line that includes individuals with greater 150 grams per week alcohol consumption in women, with increasing body mass index, the likelihood of liver disease and alcoholic liver disease is increased, suggesting that indeed there is a additive, if not synergistic, effect of increased BMI and alcohol use in developing liver disease. There was discussion about potential explanations for these findings, and certainly it has been suggested that genetic factors play a role. That was noted that the difference in the people with East Asian background and genetic composition, that around 30 to 50% of those from East Asian descent carry a mitochondrial RS671 version of the ALDH2.2 allele, which results in less functional acetaldehyde dehydrogenase enzyme. Another candidate is PNPLA3 polymorphism, which is significantly more frequent in individuals with Native American ancestry, and it is a risk factor for the development of advanced liver disease, particularly in the combination of alcohol and obesity. So it has been suggested that obesity is becoming increasingly prevalent in patients with alcoholic liver disease, and really the patient population kind of is shifting and changing its characteristics compared to what we have seen 20, 30 years ago. And patients, the obesity component is playing a major factor in the somewhat of a change in the presentation and natural history of alcoholic liver disease. The inflammation in the adipose tissue caused by alcohol consumption in part accounts for the interaction between obesity and alcoholic liver disease. With harmful drinking, obese patients have disproportionately high prevalence of hepatic steatosis and high incidence of cirrhosis, liver-related outcomes, and including HCC. And it was concluded by early cross-sectional studies showed potential benefits of light drinking. Later prospective cohort and Mendelian randomization studies failed to show benefits. And with obesity, the therapeutic window of alcohol is very narrow. So therefore, when it comes to practical considerations and recommendation to patients, in general, the safest is to recommend very limited alcohol use in those who have increased BMI. We also learned new things about alcoholic liver disease ethnic minorities, and this was a nice presentation of Dr. Arab, who pointed out that there are global disparities in alcohol consumption. So compared to the US, some countries have some different amounts of liters of pure alcohol per capita consumption, but we recognize that the United States actually is among the leader ones, although it looks like Uruguay, Argentina, and then some of the other countries may have a higher incidence compared to the US, and here particularly focused on the Americas in general, and Europe and the rest of the world is not included in here. But when we look at ethnic groups in the US, between Asians, African Americans, Hispanics, and American Indians, then it looks like that alcohol-associated liver disease in the US is associated with severe forms of disease among youngs, females, and Hispanics in particular. And this is an important recognition, and certainly we have to be sensitive to these groups. So again, this study identified that various predictors of inpatient mortality in patients with alcoholic hepatitis. And interestingly, if you look at the various ethnic populations, inpatient mortality in alcoholic hepatitis appears to be lower in African Americans compared to whites. However, total hospitalization costs in alcoholic hepatitis are higher in Hispanics compared to whites. So it's interesting to recognize that the ethnic differences certainly are present in alcoholic liver disease, various aspects of the disease. Some potential other explanations included discussion about socioeconomic status and access to care. And in the there is a kind of an alcohol paradox where we also find that the alcoholic liver disease and the sequelae of that typically is lower in upper income categories compared to the lower income categories, and could be multiple socioeconomic reasons for that. Comparative other explanation include more obesity and undernutrition. So there is an exponentially growing epidemic of obesity, as mentioned earlier, and also persistence of relative undernutrition. It's shocking that obesity has nearly tripled since 1975. And in fact, if you look at the various populations here between the non-Hispanic whites, the non-Hispanic blacks, non-Hispanic Asian and the Hispanics, then we find that there are some differences between men and women in general in the percent of the obesity in this here. Looking at other special populations, there was also discussion of alcoholic liver disease and comorbidities. And previously, before available therapies for hepatitis C, there was a lot of interest in the interaction between alcohol and hepatitis C. And indeed, there is a concomitant hep CV infection is well established as a common component in progression of alcoholic liver disease, and also hep CV infection is common in patients with alcohol use disorders. So the synergistic effect of alcohol and hep CV has been well described on hep CV replication and the increasing hep CV quasi-species and reducing the cellular immunity. And in fact, there is an increase in fibrosis progression of cirrhosis in those who drink alcohol and have hepatitis C. Multiple studies have shown this, and this is just a reminder that you should continue to check your patients who have alcohol use disorders for hepatitis C and vice versa. Those have hepatitis C, not only they should be treated, but they also be advised on not using alcohol. A similar synergy is true for alcohol and HIV infection. 27 of HIV positive patients report risk of drinking on adult-C questionnaire, and alcohol misuse is associated with increased HIV acquisition, with reduced ART adherence and increased mortality. And the liver injury is also common from the ART hepatotoxicity, and also with hep B and hep CV co-infection. Less kind of noted interaction is alcohol and marijuana. So studies showing nationwide inpatient samples suggest that decreased rates of various alcoholic liver disease stages compared to alcohol alone when we look at the combination of marijuana and alcohol. And further studies are needed to better understand this kind of an overlap. Alcohol and cocaine is another probably bad combination. Cocaine alone can cause acute hepatic necrosis, and the zone 3 necrosis and fatty change was found that is very similar to acetaminophen. Alcohol and caffeine is potentially not necessarily such a bad combination. Multiple studies show that high caffeine use probably is a very rare cause of hepatotoxicity. And in fact, there is a growing evidence for liver protection with coffee consumption that is greater than 3 cups a day by studies showing reduced cirrhosis, reduced HCC, and reduced liver stiffness with greater than 3 cup coffee consumption. So the key takeaways here is that alcohol plus hep CV or hep BV is increasing cirrhosis and HCC and mortality. Alcohol plus HIV, maybe HEV, may be less kind of harmful. And alcohol and cocaine and other substances of abuse are most likely a bad combination, but alcohol and marijuana or caffeine will need more evidence and studies, but it looks like caffeine potentially has some beneficial effects. So I'm going to actually go on and talk about some of the key pathogenic factors and new information that we discussed at the liver meeting, and particularly start focusing on the intestinal and host interaction. So Just to recap, one of the components of the pathogenesis of alcoholic liver disease, the increased gut permeability that is caused by alcohol. But this is way more complex because in addition to this, there is a major change in the gut microbiome and also in the microbiome that is the fungal microbiome and also the virome actually in the stool is also changed in alcohol use and in alcoholic associated liver disease. So here there was a nice review here where intestinal homeostasis and alcohol-associated liver disease were summarized, and it pointed out that compared to the healthy microbiome, diet and alcohol and environmental factors change the composition of the microbiome, and dysbiosis occurs. And this is something that has been described a very long time ago by Dr. Bode in 1984, that recognized that alcoholics have increased CFUs in the cecum and in the feces, and there is a increase even in the duodenum in the CFUs in alcoholics, suggesting that the changes in the gut microbiome actually happen not only in the lower gut but also already in the duodenum. So the intestinal homeostasis and alcohol-associated liver disease is related to some of the changes in the tight junction, and that's related to some of the direct effects of alcohol and alcohol metabolites, particularly acetaldehyde on the tight junction, breaking down the key molecules in tight junction, also recruitment of pro-inflammatory cells, particularly macrophages, to the intestinal mucosa that causes a sustained inflammation there, and also contributes to some of the microbial changes. Now, studies with microbiota transfer have shown that the fecal microbiome transplantation from an alcoholic hepatitis individual to mice can actually increase the alcoholic liver disease, particularly on alcohol feeding, and this was the data. And further interactions were found in enterocytes and the intestinal luminal immune system, where multiple studies shows that expression of key molecules such as REC3G is reduced in alcohol, and particularly in alcoholic liver disease, that these are protective molecules in the gut mucosa that protect from the essentially helping the barrier function of the microbiome, between the microbiome and the host. It has been also shown that certain microbiome and certain bacteria, particularly the L. reuteri, could be a target, and in fact engineered the bacteria that overexpress IL-22 could improve alcohol-induced liver disease. And here, this is the data showing that this administration of this kind of bacteria that expresses IL-22 improved the plasma ALT levels after alcohol feeding, improved REC3G expression, and reduced hepatic bacteria numbers in a model of alcoholic liver disease in mice. So overall, the key physical barriers of the intestine are create importance and play functions in maintaining intestinal homeostasis and also disruptive alcohol abuse. Microbiota protects against acute alcohol-induced liver disease. This is data based on germ-free mice, and alternative approaches that modulate intestinal homeostasis and intestinal immune microbiota interactions could be used to prevent alcohol-induced liver disease. And further studies are underway with antibiotics, fecal microbial transplantation, and probiotics that hopefully will answer many future questions. And along those lines, there were nice presentations from Dr. Guy. We've learned about liver-gut signaling in alcoholic liver disease. And here they actually focused on HMGB1 as one of the hepatic sterol damage-associated molecules that are released and present in alcoholic liver disease. So it turns out that HMGB1 increases in alcoholic hepatitis patients and correlates with disease progression. And furthermore, this HMGB1 is secreted into the serum of patients with alcoholic hepatitis. So in this particular study, they hypothesized that in alcoholic liver disease, the hepatocyte-derived HMGB1 is increased and binds IL-1 beta, and this complex signals through the RAGE receptor on macrophages and activates pro-inflammatory program that damages the liver. And they also postulated that in addition, this complex also causes intestinal barrier dysfunction. And in fact, they showed that HMGB1 this binds to IL-1 beta in patients with and in mice with alcoholic liver disease. And they also shown that this complex is found in the liver of mice. So this study kind of concluded that the HMGB1 is in complex with IL-1 beta, and that can act on the RAGE through the RAGE receptor to increase pro-inflammatory program activation. And they are essentially suggesting that potentially a modified HMGB1 could be a therapeutic approach where this modified HMGB1 could bind IL-1 beta without actually activating further downstream signaling, and almost like acting as a sponge to prevent further inflammatory activation. So apologies here. So the next very interesting study is related to the modulation of the gut microbiome. And this study from the University of Louisville from Dr. Watsaya and Craig McLean's group shows an efficacy of a 6-month lactobacillus GG therapy, reducing heavy drinking among patients with alcohol use disorder and concomitant moderate alcohol-associated hepatitis. So here they conducted a pilot double-blind treatment trial identifying the dual therapeutic role of lactobacillus GG in patients with comorbid alcohol use disorders and alcoholic liver disease. And their goal was to identify therapeutic effects on lactobacillus GG lowering alcohol consumption over 6 months of treatment compared to placebo. They wanted to evaluate the therapeutic outcomes of LGG treatment on liver injury, progression, and prognosis, and to validate the central role of gut dysfunction in the altered gut, liver, and gut-brain response in this therapeutic paradigm. So they analyzed 38 participants in an NIAAA funded clinical trial, and this was a DASH consortium that I personally had the privilege of being part of. And this investigation was a double-blind placebo-controlled study of patients with moderate severe alcoholic hepatitis defined as mild less than 21. And they also had heavy alcohol drinking history. So the data on demographics, drinking, and baseline at 3 months and 6 months were assessed, and all patients received standard medical treatment for liver disease and counseling for alcohol use disorders as standard of care. So what they found was that lactobacillus GG treated patients with the moderate alcoholic hepatitis actually had a reduction in the alcohol drinking per week after a 6-month period. And this difference was actually significant compared to placebo-treated patients. So like the patients treated with LGG showed a significant reduction in drinking. And there was a significant drop at the 6-month assessment for average drinks per week in this LGG treatment compared to placebo arm. And the lowering of alcohol consumption over 6 months in both the groups for average drinking was significant. with higher significance in the LGG group. This is likely that counseling is a contributing factor to the reduction in alcohol intake in the placebo arm. Therefore, I think it's exciting to think about that modifying the gut microbiome could actually have some downstream effect on alcohol seeking in the future. So they concluded that a 6-month LGG treatment can reduce heavy drinking and social drinking or abstinence levels. Counseling therapy in patients, particularly in placebo-treated patients, seem to provide some benefit. And overall, larger study actually is currently ongoing with this intervention. So going on to a short presentation. There was a poster about reduction in alcohol preference and intake, which is transmitted through colonization of germ-free mice with stools from alcohol use disorder patients that received fecal microbiota transplant. So in this study from Dr. Jaz Bajaj's group, they essentially used human to mouse FMT transplantation, and these were patients who received previously fecal microbiota transplantation, and then the mice were exposed to alcohol and then assessed the drinking behavior. And they found that those that compared to the pre-FMT, those that relieved post-FMT found a reduction in alcohol intake, and there was less in alcohol binge use over a 2-hour period. And then they also found that this was correlating with a change in the gut microbiome diversity changes. Just another evidence for the gut microbiome affecting alcohol use behavior. We particularly found that those that were colonized with post-FMT the beneficial effects were linked to the ruminococci and other microbial diversity. So there was also another relevant study where a randomized clinical trial of fecal microbiota transplant for alcohol use disorder. And here they used men with alcohol use disorder and cirrhosis, and did a 1-to-1 randomization between placebo and FMT in this small study of 10 individuals, and looked at short-term 15 days and 6-month follow-up. And the outcomes were alcohol craving, quality of life, and inflammation. They also find microbial diversity and some changes in the short-chain fatty acids. And overall, what they found is that alcohol use-related hospitalization, serious adverse effect, and in the placebo group versus the FMT group was increased. So FMT had some beneficial effects. Number of subjects with serious adverse effects was reduced. And there was also a trend in higher long-term abstinence in the FMT group, suggesting that FMT was safe and no FMT-related adverse effects were noted throughout the study. Going back to the lactobacillus, and here there was another study from Louisville where Dr. Jiang presented that extracellular vesicles from Lactobacillus rhamnosus GG promoted intestinal FXR activation through suppression of microRNA 194 and alteration of bile acid in alcohol-associated liver disease in mice. Essentially, they showed that they didn't even have to give the entire LGG. They could just use the LGG derived nanoparticles to treat and benefit alcohol-induced fatty liver disease in a mouse model. And in the green one, that those mice that received the nanoparticles from LGG actually showed a significant improvement compared to those mice that haven't received any treatment and still received alcohol use. So overall, I think these studies with the modulation of gut microbiome suggest that this area is very fertile and very active in a way of future studies where we probably will learn more about the intricacies of the type of microbiome that potentially could have beneficial effects in alcoholic liver disease. Now I'm going to switch gears to the study that was presented by Philippe Mathurin. This is a large European study where a combination of amoxicillin, clavulanate, and prednisolone was used in severe alcoholic hepatitis patients. That was an anti-BioCore study that was a randomized controlled trial. The aim was to determine if a combined therapy with corticosteroids and amoxicillin clavulanate is more effective than corticosteroids alone. And here there was a one-to-one randomization of patients with biopsy-proven alcoholic hepatitis that received either placebo plus prednisolone or a combination of these antibiotics plus prednisolone. And they looked at day 30 and day 60 survival. And the prednisolone was not discontinued at day 7 in case of non-responders based on the Lilly score. Essentially, the conclusion of this study was that the 30-day course of antibiotics associated to prednisolone did not improve 2-month survival in patients with severe alcoholic hepatitis and MAN score greater or equal to 21. Antibiotics decreased the probability of developing infection from 41.5 to 29.7%. And the incidence of hepatorenal syndrome, survival at 3 and 6 months, probability of the treatment response of having a MAD score of less than 17 were not affected by antibiotics. So the use of antibiotics will also save. But overall, administration of these antibiotics, in addition to prednisolone, have not had a significant benefit on survival as the primary endpoint of this study. Some other clinical studies to mention include this Cyril study group result that was persistent moderate alcohol consumption, that showing that it impacts survival in patients with compensated alcohol-related cirrhosis. So here, patients with compensated cirrhosis, alcohol relapse rate is about 50%, 30% of cases at 5 years, and age, liver function, platelet count, and alcohol liquid baseline impacted overall survival. They found that coffee seems to be protective, and alcohol consumption during the follow-up, even if it was minor, was associated with a higher risk of death and complications. And they concluded that complete abstinence should be recommended in patients with compensated alcohol-related cirrhosis. I think this is a very important and really kind of life-saving message to patients with cirrhosis. Now, there was another study that looked at patterns of alcohol use and liver fibrosis in the Framingham Heart Study. So this is a large study. This was from Michelle Tong's group from Boston Medical Center. The aim was to investigate association between specific alcohol use patterns and liver fibrosis among a cohort of community dwellers, specifically among moderate alcohol users. What they found was that multiple alcohol use patterns associated with significant fibrosis in a community cohort with few heavy drinkers. A strongest association for risky weekly drinking was in women greater than 7 drinks per week and men greater than 14 drinks per week. And they found that even moderate alcohol use may contribute to liver fibrosis and may be important to consider when enrolling in clinical trials or counseling patients. So from the clinical trials, now I'm going to switch for the rest of the summary for a few more minutes on cellular molecular biology and pathomechanisms. So one of these studies from the Catholic University in Washington, D.C. Described microtube modifications that alter protein trafficking as an early marker for alcohol-induced liver injury. And as we know, the chronic alcohol metabolism is playing a major role. Hypothesis was here that oxidative stress, metabolite adducts, and post-translational modifications produced by chronic alcohol metabolism may alter macromolecular functions, contributing to hepatic dysfunction and liver injury. And what they found was that alcohol-induced protein acetylation and AA induction alone leads to defects in protein trafficking. So each modification alone exerted similar effects as alcohol, including cath-mediated endocytosis, transcytosis, secretion of membrane delivery of extracellular vesicles. And they suggested that modulating protein acetylation is a novel therapeutic strategy. And in fact, some of the deacetylase agonists and acetyltransferase agonists are listed here and potentially could be considered in preclinical studies for the future. Some of the debriefing talks and posters also featured alcoholic liver disease, and interestingly, this was a new molecule showing a knockout of biliary neurokinin 1 receptor, ameliorating liver phenotypes in alcohol-associated liver disease. So here they found that human alcoholic liver disease samples showed increased substance P serum and neurokinin receptor 1 expression biliary immunoreactivity compared to normal controls. And they find that alcohol-induced ductal reaction, liver injury, hepatic steatosis, and inflammation were decreased in the neurokinin 1 receptor knockout mice, suggesting that this could be yet another target of some of the biology that we see in alcoholic liver disease. There were quite a few discussions and presentations related to neutrophils. And obviously, neutrophils are pathognomic for alcoholic liver disease. And some of the recently recognized function of neutrophils is how they have the function of neutrophil extracellular trap formation, which is originally as a host defense and antimicrobial strategy. But it has been described that actually this net formation can also happen in response to damage-associated molecules in steroid inflammation. And my group has previously actually reported the presence of these neutrophil nets in alcoholic liver disease, both in the serum of patients with alcoholic hepatitis, but also in animal models and in the liver. So as a follow-up in that, in the AASLD, a presidential award-winning poster was presented by a graduate student from my laboratory, where she showed that a unique low-density neutrophil subset is present in alcoholic hepatitis, and this low-density neutrophil subset has a defective function in extracellular trap formation, contributing to liver damage and alcoholic liver disease. And this study concluded that neutrophils contribute to liver damage through increased net formation. The low-density neutrophils increase in alcoholic hepatitis, and this seems to be unique in alcoholic hepatitis. We don't find this in NASH. And these alcoholic hepatitis low-density neutrophils are mature neutrophils with defective functions and clearance. And the defective neutrophils increase potentially can be associated with higher susceptibility to infection in these patients because these LDNs have a reduced capacity to have antimicrobial effects or phagocytosis. So neutrophils are regulated by the granulocyte colony-stimulating factor that has been shown in previous studies, particularly studies from Dr. Sarin's group and from India, that in patients with severe alcoholic hepatitis in a selected group, GCSF could improve survival. So here in this particular study, the GCSF was tested in an animal model, in a mouse model of alcoholic hepatitis. And we found that GCSF can prevent alcohol-induced inflammation and liver damage through hepatocyte proliferation in alcoholic hepatitis. This study concluded that even though GCSF increases liver-infiltrating neutrophil and monocyte numbers, it has a significant beneficial effects in reducing alcohol-induced inflammation and ALT increases in the liver. The GCSF inhibited liver damage through promotion of hepatocyte proliferation specifically, and also increased M2 macrophage differentiation in alcohol-fed mice. suggesting that this could be a dual therapeutic benefit, but really the novel finding here that it appears that GCSF actually induces proliferation of hepatocytes that may contribute to some of the kind of regenerative capacity of the liver and restoration of that otherwise is affected and diminished in alcoholic liver disease. There was a study from Dr. Sharma's group from India, from Chandigarh, that showed that granulocyte is stimulating factor with or without 4 weeks of N-acetylcysteine treatment is effective in severe alcoholic hepatitis, and then certainly this is a study that deserves further attention. Finally, I wanted to share some of the oral presentations that we found we had at the liver meeting, and this is about in vivo inhibition of the Bruton tyrosine kinase signalosomes in alcoholic liver disease. This is a new finding that we reported, that BTK expression is upregulated, particularly in neutrophils from alcoholic liver disease in patients with alcoholic hepatitis. And this upregulation of BTK phosphorylation was found not only in the human livers, but also in the mouse liver disease model of alcoholic liver disease with the increased BTK phosphorylation. And interestingly, if in vitro in a preclinical model, a BTK inhibitor was administered with alcohol use, then that could prevent all of the pro-inflammatory activation that we otherwise see with alcohol feeding in the liver, suggesting that a novel, the BTK phosphorylation has a novel role in alcoholic liver disease, and potentially BTK inhibition could be explored as a potential target in alcoholic liver disease.
Yeah, I think now.
Finally, I wanted to point out some of the elegant studies from Laura Nudge's lab, where she showed single-cell RNA-seq to demonstrate distinct immune cell functions in patients with alcoholic liver disease. And this beautiful map shows that the CD14 monocytes that otherwise in the past were thought to be one population actually has a very different transcriptomic profile, and also the T cells, as the particular site of the T cells appear to be different and have unique characteristics in alcoholic hepatitis patients. Then they went on and further showed that the monocyte cluster 1 could become pro-inflammatory in alcoholic hepatitis, particularly after LPS stimulation, but their cluster shows different expression of the various chemokines, for example, in alcoholic hepatitis compared to normal controls. And overall, they concluded that monocyte clusters behave differently in alcoholic hepatitis and healthy controls, suggesting that these differences in the various monocyte CD14 monocyte clusters is another way of better understanding.
Yeah, sorry we had to interrupt that because we are running behind schedule. And can I have some quick comments from Dr. Datta and then maybe Rajesh and a couple of comments, and then I think we move on to the oration, which is waiting.
Yeah, thank you, Dr. Torak. I will just summarize it in 3 sentences. First, that there is an increasing impact of alcohol on liver disease, which we already know, but I think it is increasing all over the world. The second thing is that alcohol and obesity, it increases the impact on the liver. Alcohol plus hepatitis C, hepatitis B, again increase impact on the liver. The only thing which seems to be slightly protective is a good microbiota in the gut. And the second thing is caffeine intake. So 3 cups of coffee along with alcohol can reduce the burden of disease on the alcoholic liver disease. And the third thing which I learned was probiotics may have a role in not only decreasing the injury, but also decreasing the alcohol drinking behavior. So that was very interesting, that how gut microbiota can modulate the amount of alcohol a person takes. So that was interesting and new. Use of augmentin, amoxicillin clavulanic acid, along with prednisolone, decreased the infection rates in alcoholic hepatitis, but did not impact mortality. and there might be a problem with neutrophil functions in patients with alcoholic liver disease. So I will just summarize it with these components of what her basic talk was. Unfortunately, we haven't been able to put the question of Dr. Sareen to her. Maybe an email would do that.
Dr. Rajesh, quick comment.
Yeah, thank you, Dr. Vinay. And this is actually the Dr. Sabu has already covered the majority related to the American population, but in India, we have a major issues. Alcohol continues to be a major issue for our population as well. Especially the psychosocial aspects must be fully addressed because we don't have much therapeutic agents for the management of this liver disease. So I see the promising results of fecal microbiota transplant in this area, and we need to see more data from all over our country. Thank you for giving me this opportunity to participate in this.
Dr. Mithun, quick wind up from you.
Very short. So the problem in India is different from the West, I believe. It starts from quantifying alcohol, which is very difficult in the clinic. It starts from a half or a full. And there is possibly a role of desi daru and moonshine alcohol. We don't know how they play a role. So Indian data would definitely be totally different from maybe what we're getting in the West. I'll sum it up with it. Thank you.
Thank you very much. So we exit this session now. Thanks to the moderators for being with us. And now we go on to the next session. And that is the H.G. Desai oration. And joining us for this would be, the oration will be given by Dr. James Boyer. I request Dr. Sareen to introduce Dr. Boyer, and Dr. S.P. Mishra, who was a senior professor at Allahabad, is now also joining us for this session as a moderator.
Dr. Sareen, sir.
Dr. Sareen will introduce Dr. Boyer. Sareen, sir.
I don't see Dr. Sareen.
So the H.G. Desai oration, and I think Dr. Sareen may have some connectivity issue, or is he on?
Your voice is echoing, Vinay.
Sir, you have to introduce
Thank you, Vinay. It's a distinct honor for me to give a brief. Yes. Can you hear me? It's a distinct honor for me to give a brief about. Can you hear me now? Hello, Vinay, can you hear?
Yes, sir, we can hear you.
You're audible.
Yes, I am introducing.
We can hear you, sir. I think
Professor Boyer is a friend of India. He started his career. Under. Sorry. इसको म्यूट कर दें. Dr. Boyer started his career in Calcutta under Dr. A.K. Basu, and he was the first one to describe as idiopathic portal hypertension. Dr. Boyer, as a medical student from Johns Hopkins, was the first to have a paper in Annals in 1967, where he described idiopathic portal hypertension. Subsequently, he went back and started the bile lab at the Yale. Dr. Boyer, as a medical student from Johns Hopkins, was the first to have a paper in Annals in 1967. There he described idiopathic portal hypertension. Now, Professor Boyer went back and started the bile lab. Professor Boyer set up the first liver center at Yale. These are amongst the 5 centers in the whole US. And I was witness to, as a Fogarty Fellow, to go and work at the Yale Liver Center. Of course, I worked with Roberto Grossman, but Dr. Boyer remained a force all through. And there were a couple of things which I learned. First was scientific honesty. Second was his mentorship. And third was his love for India. He trained many people, including one, Anil Gautam, who described the hepatocyte couplet with Dr. Boyer, that it is not one hepatocyte which is a unit, but the couplet is a unit. I just wanted to give this brief background of this great man who most humbly, on my writing, accepted to give this talk. Why he chose not to appear was he is on service at the age of close to 85. He is still doing clinical work at Yale. And I don't know how many of you looked up the dictionary. I did. Peripatetic means that a man or a teacher who teaches at more than one places. And he has been teaching at many, many places. And this is his life's journey. And I wish many of you, like me, would enjoy, get encouraged, initiated to be someone close to Professor Jim Boyer. With this, I would like to start, ask people to start Dr. Desai's oration, who himself had been a great teacher, a motivator to all of us. So it's a tribute that Professor Boyer is giving the H.G. Desai oration of 2021. Over to you, Vinay, to start Dr. Boyer's video.
I think now we can have the oration going. Thank you, sir, for introducing. And thank you for agreeing to chair this. SP, thank you very much.
Well, it is a distinct honor to be asked to deliver the Desai oration today, and I'm very thankful to the organizers for inviting me. I decided to take you on a 50-year journey today to describe sort of the highlights of my career and the people who have influenced it, and some of the milestones that we have made over these years. The trip will take you from my medical school to Calcutta, to Yale, to the University of Chicago, to the Mount Desert Island Biological Laboratory, and back to Yale. And this is illustrated on this first slide here. My interest in liver disease began in India, in Calcutta, where I found myself in 1964, along with my new wife, at the Johns Hopkins University International Center for Medical Research and Training in Calcutta. There I was supposed to be studying cholera, but as you will see, I became fascinated by the liver. And so I ventured to finish my residency at the Yale School of Medicine, where I would follow up with a fellowship with Gerald Klatskin, a renowned hepatologist at that time with an excellent training program in liver disease. And then a few years later, 6 years later, I was recruited to the University of Chicago, where I established my own independent program. At about that time, I began to go, and that was about 1971, 72, I began to spend time in the summer in the Mount Desert Island Biological Laboratory, looking for a species that was amenable to study the formation of bile. And I shortly thereafter, I was recruited, of course, from Yale to the University of Chicago, but I continued to, and then back to Yale in 1978, where I've remained ever since and have continued to interact with the biolab in Maine. So my goals for this talk are to illustrate how my academic career as a physician science developed. I want to highlight the importance of some of the people who have influenced me in the field of biology. It takes a village, not just one person. And I will highlight some of the milestones from our lab during the first formative period of my career. Now, when I was a second-year medical student, I received this reprint from a paper that had my name on it. And this was based on my senior thesis at Haverford College. And when I saw my name in print, I was extraordinarily excited, and I decided I would like an academic career, and I'd like to see my name in print again. Well, it was a long 8 years before that happened. Now, this was the Vietnam War era in the 60s, and all male physicians were subject to the draft. I was no exception. And so in the middle of my residency, I did go off to the Public Health Service. And as I said, found myself in India, in Calcutta, for about 18 months. And there I was encouraged to work on non-cirrhotic portal hypertension by Frank Iber, who was the hepatologist at Yale. I'm sorry, at Johns Hopkins. And he wasn't there except for a brief visit, but was the one who really encouraged me to work on this problem rather than cholera. Here I am with my young wife in a tour of Shingur, a village with a colleague who was studying hookworm. This was just a day off for us at that time. I'm stationed at the SSKM Hospital, and the Institute of Postgraduate Medical Education and Research. This is a view from one of the buildings. It was quite a lovely place. You can see the Victoria Memorial in the background, and you can even see the Howard Bridge right about there. Now, fortunately, I came under the influence of this gentleman, Ajit Kumar Basu, who was a thoracic surgeon, and he had been trained in England at the Hammersmith. And I was taken under his wing as my original mentor had left the institution to go to Chandigarh. And this turned out to be fortuitous because he controlled the input of patients with portal hypertension, splenomegaly, and did workups and surgery on these patients. And he installed me in what had been his former office. And here is a dark picture of this. It was very rudimentary. I had brought with me a small Bosch and Lomb spectrophotometer, an infusion pump, bromosulfathaline, and some Cornon catheters to study liver blood flow in these patients. These were the kind of patients that we saw there. These enormous spleens in the abdomen. His staff, Basu's staff, performed splenoportograms, and this is a rather striking vision of the patients with non-cirrhotic portal hypertension. The needle is placed in the spleen. Here's the splenic vein, the portal vein, and you can see this marked attenuation of the intrahepatic branches of the portal vein, characteristic of this disorder, and a very, very large coronary vein going up to esophageal varices. This is what the livers look like at operation. Dr. Basu made a fairly wide incision, and I was able to take pictures of the livers at surgery, as well as to obtain histologic material. These I took back to Johns Hopkins and the pathology department there, stain them. This is a trichrome stain. You can see this portal fibrosis, but the rest of the parenchyma looks quite nice. The findings, though, that were striking in these couple of patients who we had autopsies was the presence of organized thrombi in the intrahepatic portal veins of the liver. And we thought these intrahepatic portal thrombi were the likely cause of the idiopathic portal hypertension. And this was our seminal publication of the study in the Annals of Internal Medicine in 1967. From Calcutta, as I mentioned, I went to Yale to finish my residency, the first 2 years having been at Cornell. And then I found myself under the tutelage of Dr. Gerald Klatskin, a remarkable clinician and with interest in liver pathology and the correlation of clinical and pathologic studies. I also thought I should do some fundamental research. I hadn't any background in basic research. Bob Scheig was a colleague in the section and was interested in lipoprotein secretion at the time. And we set up this isolated perfused rat liver. This is a picture of the original livers that we looked at, which we perfused in a chamber that's surrounding this perfused liver and being perfused with, in this case, with rat blood. We had to cannulate the bile duct to measure bile flow as a sort of a functional parameter of how well the liver was doing. And when I saw this perfused liver secreting this yellowish fluid from in an isolated state, I again had one of these eureka or epiphanies, and said, "How in the world is this happening?" I dropped my interest in lipoprotein secretion and started studying the deformation of bile. Components of bile at that time were divided into ductular secretion and bile salt independent and bile salt independent flow. The molecular determinants had not yet been discovered, and we worked out one of the things we worked out early on there together with Joe Bloomer were the measurements of canalicular bile secretion in humans using the biliary clearance of radio-labeled mannitol. And that allowed us to determine that in humans, in man, the canalicular bile averaged about 450 milliliters in 24 hours, divided equally between bile salt dependent and bile salt independent fraction, and that the ductular component was added on to that for an average of about 600 milliliters in 24 hours. Now, I want to stop here for a moment and talk to you a little bit about the importance of mentorship, because I was very, very fortunate in my early days to have several different mentors along the way. Dr. Klatskin, who I just mentioned, was my clinical mentor. He was an outstanding clinician and brilliant mind and memory, and I learned most of my clinical skills from him. At the same time, Dr. Peter Kern was in the Department of Physiology at Yale, and he is the founder of the standing osmotic gradient hypothesis. And he encouraged me to come and present my work to his lab group. And I was quite scared at the time to do that. He was a PhD and I was a struggling MD, but he really encouraged me to do so. And afterwards, he started sending me papers to review, as he was the editor of the American Journal of Physiology GI section. And that encouragement from a colleague like Peter Kern was, I can't tell you how important that was as I was beginning to enter academic medicine. And it went a long way to convincing me I should continue to work on problems of biliary secretion. We sometimes forget how important a few encouragement words are to a young colleague. And then after I moved to Chicago, I was asked to join the American Association for the Study of Liver Disease Council. And there I came under the influence of Hans Popper, who began to introduce me to international colleagues. And it's through Hans that I really made those international contacts, from which a number of postdoctoral fellows came in subsequent years to study in my laboratory. So I had three very wonderful mentors. About that time, I visited the Mount Desert Biological Laboratory, Salisbury Cove in Maine, looking for a creature that might have a large enough biocanalicculus that we could put micropipettes, and as the renal people did with renal tubules. But the anatomy of the of the marine species there was just about the same as humans, and the task seemed to be formidable. However, I found a number of colleagues there, particularly basic scientists in studying renal secretion, that greatly influenced me in our own studies. This is a current aerial view of the campus of the laboratory. Now, the organism that we worked on for most of the time was the little skate. It has a liver about the size of a rabbit and was easily obtained in the waters surrounding Mount Desert Island. So then I was recruited to the University of Chicago after 6 years at Yale, and was there for another 6 years before coming back to Yale. So I would like to now turn to some of our scientific milestones. One of the first significant findings was the localization of the enzyme sodium-potassium ATPase. In this middle panel, using this histochemical technique called the Ernst technique, you can see the deposits of here from this histochemical technique, which represents the staining of the sodium pump. You do not see any canalicular staining. Magnesium ATPase was present in the apical membrane, the canalicular membrane, as shown in panel 2 and panel 5 here, but whereas the magnesium ATPase was not present on the sinusoidal membrane shown here in 4. Now, this meant that the sodium pump was present in the basolateral membrane of the hepatocyte, and at the time, this meant that the hepatocyte was polarized in the same way as standard epithelia were. Prior to this time, it was thought perhaps that sodium pump was on the apical membrane, pumping sodium into the bile. So this allowed us to think about the significance of this work. It allowed us to think about the hepatocyte as a classic epithelium. And this is diagrammed here, where you see 3 hepatocytes, the biocanalicculus, and the sodium pump in yellow here on the basolateral membrane, where it provided a sodium outwardly directed sodium gradient, inwardly directed potassium gradient, a negative intercellular potential, which could drive anions such as bile acids and amino acids and other organic anions into the hepatocyte. And this initial presentation was published in this New Concepts of Mechanisms of Hepatic Bile Formation, and did a lot for my reputation in my early career. After 6 years at the University of Chicago in 1978, I was recruited back to Yale, where I have remained ever since on the faculty, full-time faculty here. And it was at Yale in the early time after we got back that we began to work on a cell culture system that involved the isolated hepatocyte couplet. These are hepatocytes that are dissociated from the liver in the process of making isolated hepatocytes. But as you can see from this Nemarsky optic here, they not only retain, but form a large apical canalicular membrane space. And I said, aha, this is this preparation that will be able to finally use micropuncture techniques. And I was able to elicit the talents of Jurg Graf, a Viennese physiologist who came to Yale And here he is in the midst of a Faraday cage surrounded by all the electrophysiologic equipment required to do this work. And here is one of the first tracings, electrical tracings of a micropuncture of the hepatocyte couplet, and where the recording of the electropotential profile. The needle is advanced into the hepatocyte here, number 1, and this is the electrical potential, and then proceeds into the canalicular space here at number 3, and then further penetrates the second cell, as you see here. And this established the electrical gradients across the canalicular membrane for the very first time. And this was communicated by Hans Popper for the PNAS, and this was used for a number of studies of canalicular function, in addition to these elective physiologic studies. A little bit later, Mario Straszo-Bosco came to the laboratory as a fellow from Parma, Italy, and Mario was interested in bile duct epithelial function, and he was able to, for the first time, to develop isolated bile duct units from the rat, shown here in the electron micrograph here, and these isolated bile duct units, together with the isolated hepatocyte couplets, enabled a number of studies over those years to be done to determine what came from the canaliculus and what came from the bile duct epithelium. And then Peter Meyer came to the lab. Peter, unfortunately, has died this past year from complications of bone marrow transplant after developing AML. But Peter was the one who really established the transport studies of bile acids that we began to be interested in. He used a zonal rotor, which allowed us to collect enough mixed liver membranes that could be subfractionated in sucrose gradients and separate out the canalicular liver plasma membrane from the basolateral plasma membrane. And this allowed functional studies. This is an example of using the basolateral membrane vesicles, looking at the uptake of radiolabeled sodium taurocholate in the presence of a sodium gradient. When there is no gradient, there's just diffusional uptake. And this established that there was a functional sodium-dependent bile acid transporter on the basolateral membrane of the hepatocyte. We also looked at apical membrane vesicles and only saw an electrical diffusional component. We completely missed the fact that there was an ATP-dependent transporter there, which other labs subsequently did. So we missed the holy grail there. However, this was the beginning of the molecular age, and when Peter went back to Zurich, he was in his lab with the first to clone the sodium-dependent taurocholate cotransporter that I showed you was physiologically there, NTCP. They went on to clone several of the organic anion transporting polypeptides, and then others, primarily initially from the cancer biology group, began to look at the ABC transporters. There were export pumps on the apical membrane. And the final major contribution, which came from several different laboratories, including Peter's, was the cloning of the bile salt export pump, which is the mechanism by which bile acids, of course, get into the bile. This was a review that we were asked I was asked to prepare for the New England Journal in 1998. And since then, of course, we've been interested in the modification of these transporters in cholestatic liver injury, but I don't have time to go into that. I'd like to switch briefly to tell you some of the additional contributions that came from the Mount Desert Island Biological Laboratory. Here we worked on the marine skate, and the marine skate had no evidence of a sodium-dependent uptake mechanism rather seem to be sodium independent for the uptake of bile acids. And this is Ned Ballatori. Ned was a PhD from the University of Rochester who came to my lab, and he then came with me to Maine and fell in love with the place there, and came back and worked with me for many summers until his tragic death from sarcoma of the heart about 10 years ago. Ned isolated some RNA from the hepatocyte of the skate, took it back to Rochester, and subsequently cloned 2 subunits that consisted of, which he named the organic solute transporter alpha and the organic solute transport beta. And as you can see here, the beta is a single transmembrane main transporter, and the OST alpha is a 7-membrane. You needed to express both of these separate clones to get functional transport. Now, what the significance of this was and was not initially clear. It was it took Paul Dawson who had cloned the apical dependent sodium uptake system for the ileum to localize, to discover the fact that it was also localized to the ileum in its highest concentration. So bile acids are synthesized in the liver. They're excreted into bile by the bile salt export pump. They're taken back up by the apical sodium dependent bile acid transporter, and its OST alpha, OST beta is the mechanism by which the bile acids get back into the portal blood, where they return to the liver and are taken up by NTCP. So this discovery was the missing link in the enterohepatic circulation of bile acids. Here, shown in this review from Paul, is the presence of the in the ileocyte, which has the highest concentration of this transporter on the basolateral membrane. You also see it in the proximal tubule, where it's on the basolateral membrane and helps with the reabsorption of bile acids from the urine. And it's also present on the basolateral membrane of the hepatocyte, where it functions as an efflux pump when bile acids get too high in cholestatic liver injury. Now, we also were interested in all of this period of time and continue to be in clinical research. These are some of the highlights of some of our clinical observations. We defined subacute hepatic necrosis along with Dr. Klatskin as a prognostic marker in viral hepatitis for progression to chronic liver disease. I showed you some of the work that we did early on idiopathic portal hypertension that came from India. We've had a long-standing interest in autoimmune hepatitis, natural history of the disease, and also most recently the use of mindfulness in regulating and controlling the stress-related exacerbation of this disease. And of course, we've had a very long-standing interest in primary biliary cholangitis and primary sclerosing cholangitis, establishing the natural history of PBC in the prior to the onset of discovery of the use of ursodeoxycholic acid, and the natural history of PSC, and most recently the discovery that we can use bile to develop organoids from patients with this disease as an in vitro method for studying pathogenesis and treatment of this disease, for which we have none at the present time. So I think my time is coming to a close. I would just like to refer you to this, particularly the younger people in the audience, to this paper here in the clinical in the journal CMGH. It's an online journal. I was asked a few years ago to write a piece about how I'd been able to maintain a vibrant and productive laboratory as a senior investigator. And these are some of the points that I maintained in this paper. First of all, as a younger person, it's very important that your time be protected so that you can maintain your enthusiasm for this work. You have to develop a passion for what you do to be successful, but you have to have time protected as a younger person. As you begin to progress in your career, you need to keep your thinking and your research approaches modern, as fresh as you can, as you become established, and not just hang on to the techniques that and approaches that you learned during your training. You're going to have challenges if you're successful when you're a mid-career investigator, because people are going to want to drag you into committees, and you might even be asking to be a unit chief or department chief and serve on study sections and do all kinds of administrative work. You need to clearly protect yourself from too much of that activity if you want to continue with your investigations. And then as you become a senior investigator, it's very important to surround yourself with younger people who are smarter than you and who can carry on and keep your lab active and productive. And then, of course, you've got to have a certain amount of luck. None of this success occurs without other people, but also without a good deal of luck. So I have a lot of debts to pay here. I can't mention many of my other fellows who came from many countries over the years who have contributed significantly to our work. My colleagues in the digestive disease section at Yale and at the Mount Desert Island Biological Laboratory. Very indebted to the Falk Foundation, whose meetings on bile acid over the years got me acquainted with young people who came to the lab in subsequent years. My professional organizations, the AASLD and the ALF, which provided me with opportunity for leadership positions over the years. And very much for 40 straight years, I was funded by the National Institutes of Health and at the lab in Maine by the National Institutes of Environmental Health Sciences. And of course, to the University of Chicago, where I spent 6 formative years, and the Yale School of Medicine, where I continue to be active. This is one of my favorite quotations from Sir William Osler. Should your assistant make an important observation, let him publish it. Through your students and your disciples will come your greatest honor. And then finally, a quotation from Goethe, which is my watchword. The German is above here, wer immer streben sich bemüht, der können wir erlassen, which in translation means, whoever aspiring struggles on, for him there is salvation. And I thank you very much for your attention and for this wonderful honor to provide the Desai lecture for this year. Thank you very, very much.
I think there can be no questions after such a wonderful oration. And I think we should propose a vote of thanks to Sir for having given this oration and taken time out. So I think he deserves a standing ovation from all of us for this. So I think I can join in the standing ovation. So I think so SP, I think now we will, you have to say anything?
Just an overview of an illustrious career and so much of inspiration for all of us to do something well in life. I have had the privilege and honor of meeting him many times in the APSL and other fora. Wonderful person, human being too, and really a good friend of India, as Dr. Sareen said. Last word will be Dr. Sareen.
Yeah. Sir, would you like to say something? Dr. Sarin? Sir?
I think Vinay, then we better wind up because we are getting late.
Yeah. Okay. So now we close this session and move on to the next session. And thanks to Dr. Sarin and SP for being here. And of course, special thanks to Dr. Boyer for giving us this wonderful talk. So now we move on to the next session, and that is COVID in liver disease by Dr. Sumit Asrani. And on the panel will be Dr. L. Venkatakrishna, who is professor and head of the department at PSG Hospital, and Professor Manoj Sharma, who is HOD of hepatology at the ILBS. So let me invite the panelists and let us get on with the next session, please.
Funded by the National Institutes of Health.
Can we start?
That's a lab made by the National Institutes of Environmental Health Sciences. And of course, to the University of Chicago, where I spent 6 formative years, and the School of Medicine, where I continued.
Good morning. Thank you again for this kind invitation to talk at this important conference. My goal this morning is to provide some updates from COVID and the liver that was presented at the liver meeting in 2021. My name is Sumit Asrani. I'm an associate professor of medicine at Baylor University Medical Center in Dallas, Texas. So this was data that I just pulled 2 days ago regarding the current status of COVID in the United States. And as you can see that already 1, 2, 3, 4, we're maybe starting our 5th wave of COVID. In addition, if we look at sort of, deaths, for the top 3 countries, US, Brazil, India, out of 5 million deaths, about 2 million deaths are within these 3 countries. So 2 out of every 5 people who's died in the last 2 years because of COVID has been within, our 3 countries. In addition, in the US, we have about 1 in 420 to 1 in 450 people who have died because of COVID. So the situation remains somber and important. And with that unfortunate background, I wanted to go over and discuss, what was presented regarding COVID and the liver at AASLD 2021. The 3 themes of discussion were, one is short and long-term outcomes in chronic liver disease with regards to COVID. The second one was a thought that COVID vaccines work. And 3, the theme was of the indirect impact for non-COVID related care. Now let's talk first about liver injury. So first looking at short term, so this was a analysis of about 14,000 patients across an administrative database showing that liver injury on admission was associated with worse outcomes in patients presenting with COVID-19. This was a nationwide retrospective cohort study of about 14,000 patients looking across electronic medical records for 87 US-based healthcare systems from December 2019 through part of September 2020. So this is a bit outdated data. And this analyzed associations between abnormalities in liver chemistries, AST, ALT, alkaline phosphatase, total bilirubin, and mortality, intubation, and prolonged hospital length of stay in patients with laboratory-confirmed COVID-19. And pay attention to the red bars. So that is, was an abnormal liver test present or not? And what we saw, so this was not just related to liver patients, but the kinds of patients or the groups of patients who had abnormal LFTs tended to be obese, diabetic, smokers, heart disease, CKD, and then liver disease. So abnormal LFTs was present in up to 50% of certain subsets of the population that presented to US hospitals. Pattern tended to be cholestatic in a majority, and in about 1 out of 5, it was a mixed pattern. Now, Presence of abnormal LFTs was associated with poor outcomes. So looking at the blue bars, so if you look at the blue bars, presence of any abnormal liver chemistry, the ratio was 1.7, intubation 1.4, and prolonged hospital stay 1.1. And if we specifically look at AST, that had a stronger association, which is shown in red, 2.2, 2.1, and 1.1. Now, what about long-term? So long-term clinical outcomes of patients with COVID-19 and chronic liver disease. Now, this is another US multi-center effort called the COLD study, the COLD Consortium, and Elizabeth Abbey presented this data on behalf of the consortium. And the prior work has shown that when we look at chronic liver disease plus COVID-19, all-cause mortality is about 14%. Hospitalization, 60%, ICU admissions, 23%. Now remember, a lot of this is self-reported, and so this may be enriched for tertiary center data. But if you look at the predictors of adverse outcomes, this includes alcohol-related liver disease, hepatic decompensation, HCC, older, diabetic, hypertension, COPD. So the older chronic condition patient tends to be higher risk for complications. And now they extended the study to look at sort of long-term impact. So this was 15 centers across the United States. Patients were identified via EMR search. Inpatients and outpatients were included, and about 300 patients were identified across these centers. And if we look at the characteristics, now this was chronic liver disease. If we look at cirrhosis, it was only in 1 out of 4. So most patients in this cohort did not have cirrhosis. And in those patients with chronic liver disease, about half were NASH, followed by hepatitis C and alcohol liver disease. What we saw is that the long-term mortality was 7%, 3% experienced delayed COVID-related mortality, and hospitalization rate during the follow-up period was 38%. Long COVID symptoms was present in 1 out of 4 patients, and the symptoms included dyspnea, it included severe fatigue, included depression, cough, arthralgias, as well as chest pain. Now, if we looked at liver tests, they actually improved over the long term. So let me walk you through these graphs. So this was baseline, diagnosis, peak, and then in follow-up. And what we can see is that from peak to follow-up, AST improved, ALT improved, alkaline phosphatase was the same, bilirubin improved, INR improved, and albumin increased. Alcohol use continued to be an issue, as is seen across the US as well as worldwide. 24% of patients reported moderate to heavy alcohol use after recovery from COVID-19, 18% reporting worsening alcohol use, and 18% reporting actually critical complications because of that. And almost all of us have seen this impact across our hospital systems. Weight gain, 32% of patients, and the median weight gain was about 4 to 5 kilograms or 10 pounds. Second part is vaccinations. So there was a lot of studies based up that reported impact of vaccinations. Dr. Kamath has already presented some as it relates to liver transplantation. I wanted to discuss vaccination from a larger nationwide analysis, and this is data from Chile, where vaccination against COVID-19 decreases hospitalizations in patients with cirrhosis. Here, they looked at the national surveillance program for the Chilean Ministry of Health, confirmed and probable cases between March and May 2021, confirmed by real-time polymerase chain reaction. And what they looked at is incidence, hospitalization rate, and presence of comorbidities, as well as the overall vaccination rate. And again, this was not just cirrhosis patients, but anybody who had confirmed or probable case of COVID in Chile. And what they saw is that they had 1.7 million cases during that 1 year. A majority were confirmed by PCR. Median age was 38 years old, half were female, and 7% required hospitalization. Now remember, the previous data had shown was a much higher rate of hospitalization, and this again is more population-based data. And out of this, 1 out of 1,000 had cirrhosis. And of the cirrhosis patients, 43% required hospitalization. And what we see here is that there is an absolute reduction in hospitalization rates after administration of 1 vaccine dose. So you see the absolute reduction of -5 for cirrhosis as compared to heart failure, as compared to chronic kidney disease. And if you look at reduction after 2 doses, cirrhosis patients tend to have the largest benefit as compared to other chronic conditions, including chronic kidney disease. Now, identifying patients at highest risk against COVID remains an issue. Like, who are patients? And this is Dr. Mahmood presented this on behalf of the vocal cohort. Now, the vocal cohort is consists of cirrhosis patients in the Veterans Administration healthcare system. And what they saw is about 43,000 patients were looked at. 28,000 patients, or 60%, received vaccination. Half were Pfizer, about half were Moderna. And of these, we'll walk you through this data. Look at the column, which is this second column right here, which says less than 50%. So this is what is the predicted probability of receiving COVID-19 vaccination. And the themes that we saw is it was the younger patient, so 57-year-old versus 68-year-old. It tended to be male across the 3 groups, but it tended to be white race as well as patients who are smokers, so 50% smokers as compared to 25% in the other groups. And etiology seemed about the same, except for alcohol, which was 46%. So young smokers and alcohol tended to be a group here, at least, that did not get vaccination. And there also was a pattern in terms of these patients actually had less comorbidities. They probably were the younger patients, and this may be looking at a later wave of COVID-19 in the United States. And the region tended to be more southern US as well as more rural as compared to urban. So those were some of the factors of certain kind of groups of patients that were still not getting vaccinations. Now, what about the indirect impact of COVID? I've discussed this before with this group, but I think it's worth mentioning again, is when we think of the waves, and so this is not referring to waves of COVID, this is actually referring to waves of a response, waves of, how we've seen healthcare sort of evolve over the last 2 years, or as we go into our 3rd year. The initial first wave of the pandemic, there was a lot of delays, especially for liver transplantation, elective procedures, imaging, routine patient follow-up, and we tended to prioritize high acuity care, right, in early 2020, mid-2020. This was then followed, as many of our patients, not because of COVID, but because of non-COVID, ended up having emergent decompensations. Patients tended to wait longer for transplant, started dropping out. There was a backlog of deferred visits and tests. And now, add to that alcohol use and alcohol-associated liver disease that all of us have seen, really, really unfortunately take off. And then finally, we're sort of in this 3rd wave of response, where yes, you have a bit of priority for higher acuity care, but now we're starting to see patients that were lost to follow-up, the misdiagnoses, the incomplete cancer screening, the progressive disease. And hence, even though we are not dealing with COVID on a day-to-day basis in certain countries, the indirect effects still linger and will continue to linger for a while. And this study sort of highlighted some of these things that I mentioned. So COVID impact on viral hepatitis B and hepatitis C elimination, looking at 31 centers worldwide, led by some of our European colleagues. And what they looked at is 37 programs across the world. 20 were European, 17 were rest of the world. And you can see the distribution on this map. And these centers covered a population between 10,000 and 8 million people. And all centers except one attended COVID-19 patients. Looking at hepatitis B treatment, so if you look at the number of patients who started treatment, that declined by 35%. And the number of centers that saw more than 50 to 75% reduction. I mean, most centers were sort of in this group right here for hepatitis B treatment. And same thing with hepatitis C treatment. If you look at the number of patients who started treatment, this was down by 50%. And again, 50 to 60% of centers had more than a 50% or 75% reduction in hepatitis C treatment. Final, talking about sort of the impact of COVID-19 pandemic on hepatology practice and provider burnout. And this impact is real. This is taking a toll on all of us as providers, either on this call or in person in Hyderabad. Is during the COVID pandemic, many of us had to adjust the way we provide care. Several switched to telemedicine. Practices here reduced staff. There was reduction in compensation. Some people moved to new employment, closed practice, moved from patient care to non-patient care roles. So there has been sort of this alignment in terms of, how we've sort of changed our practice. And burnout, 40% in this survey. Women, 2 times more likely to experience burnout. Majority of the respondents in this survey said that they felt that their employer did not honor their dedication and sacrifice, provide the tangible needs, or provide support for childcare. And this was some of the responses of what your colleagues felt. They did not feel worthwhile at work, 20%. Did not feel that the work was satisfying, 16%. Did not feel in control when dealing with difficult problems at work, 27%, or that they contributed professionally in the ways they valued most, which is about 20%. And here are some of the selected quotes that was reported in this abstract as well as study. I'm falling behind with work, research tasks because of increased family commitments and family needs during the pandemic. The problem is not so much time to do things that are enjoyable, but the ability to do them at all. Cannot travel, haven't seen family in over a year, cannot do any of the things that used to provide enjoyment. If I travel, I lose access to childcare for a week, which is not an option. Somebody else saying, I love my work, but I've been disrespected, insulted, humiliated. I'm too old to start again, and I'm trying to concentrate on what I love, my patients and my clinical research, but it's hard to believe that we're in 2021 and a woman has to be poorly treated by an institution. Just hope my daughter, who's in med school, will have a different experience. And then this last quote of, I sometimes wish for a car accident just to be able to have an extended break. So we've sort of gone through this extreme experience, all of us together, over the last 2 years. But I think, there's hope. And what I wanted to close this talk with is actually share a recently posted YouTube video by Google, which I think might give us an idea of, where things are going. I think the impact of COVID on our lives and our livers has been that innovation is possible, collaboration is possible. It's humbling to see all of us rally around a common cause. And we've started to reset our lives to focus on what truly matters. And this sort of gives us a flavor of, what people think is important. So let me share this video real quick, and then we'll close and take questions after that.
This year has been extremely challenging for me. I am broken, and I am healing.
I'm here at the memorial wall. I wanted to do something to remember my mum.
For some reason, I'm having anxiety. Obviously, it's normal with everything that's going on right now.
I think I'm going to take a break for a while.
You can get through it. And
if you can get through it, there's a greater reward on the other side.
Just like anybody else, I'm just trying to do my little part to try and save my community.
I'm just really excited we're back open.
And I am smiling under my mask.
Incredible scenes on the day the fans came back.
Welcome back to the theater.
You guys, it's been so long.
You're looking at yourself in the mirror and you're just like, there I am.
Be your best. Never, ever, ever stop dreaming. I don't care what they tell you.
We, the jury, in the above entitled matter as to count 3, find the defendant guilty.
I am proud to be Asian.
We are not drowning. We are fighting.
We cannot keep quiet about climate injustice. No action is too small.
We just have to band together as a community and get people's lives back.
Even as we grieved, we grew, that even as we hurt, we hoped, that even as we tired, we tried, that we'll forever be tied together, victorious.
May I invite comments from the panel?
Thank you, Dr. Asrani. I have one question for you. In the Chilean study, which was regarding the use of vaccination, what kind of vaccine was used? And what is your experience regarding side effects of vaccination in cirrhotic patients especially? Because I have seen few cases of Bell's palsy which resolved on its own. So what is your experience regarding that?
Yeah, I'm not sure of the distribution of the vaccine used in Chile, but I don't think it was the ones that are used in the US. But the second part, vaccinations have been, overall well tolerated. We had initially a couple of cases of dural thrombosis that we saw with the J&J and young women that had come to our hospital. But overall, it's been very well tolerated. The one issue now that is as we are vaccinating our children here, we were worried about side effects, we were worried about neurological, we were worried about myocarditis, and fortunately, we have not seen any of that.
Thank you.
Dr. Venkat, any comments? Dr. Venkat Krishnan,
yeah, about the impact of vaccinations, especially once in cirrhotics when you vaccinate the complication of COVID has come down. The only issue is if they're waitlisted in transplant, do we go ahead and give vaccine?
So we have, and this is, it's such an interesting dynamic, and I would love to hear how it is being handled in India. Is here we have vaccines, and we're trying to get our patients vaccinated, even if they're decompensated. But there's still resistance. So we as a program actually try to mandate, vaccinations for our potential recipients. And there was a lot of backlash. And so that's, some centers have done it, but they're being sued. But, as a practice, we are still recommending vaccinations to every single person who we see.
So thank you, Dr. Asrani, and thank you, our moderators, for being with us at this late hour on a Saturday evening. It's a challenge, actually. And I thank our viewers who are with us. Almost 900 people are online, I believe. So we are move on to the next session, which is the second last session of the day. And this session is by Dr. Robert Lewis on hepatobiliary malignancies. And for this session, the moderators I invite are Dr. Anil Arora, who is the professor and head of the department at Sri Gangaram Hospital, and Dr. A.C. Anand, who is at KM Hospital, and Dr. Parimal Lavate from Pune, who's my good friend and colleague, and he's sitting in the same room with me, as a matter of fact.
I would like to thank Professor Sarin and the organizing committee for the opportunity to present to you at this Hot Topics at AASLD 2021. My name is Louis Robert, and I'll be speaking on hepatobiliary malignancies. So I have a few disclosures. So I'll go right into the discussion here. This first study that I would like to show you talks about the incidence threshold for routine surveillance and the opportunity perhaps to lower the threshold given advances in our understanding and appreciation of the risk of HCC in patients with hepatitis C cirrhosis who have achieved virological cure, as well as changes in the standards of what is considered a cost-effective surveillance modality. And this was by Drs. Chatwell and colleagues. So cost-effectiveness studies used for HCC incidence threshold calculation are to some degree old. In part, they did not consider lower competing risks in patients with hepatitis C virus who have been cured. And they did not tend to include new and more comprehensive hepatocellular carcinoma treatment option. Further, they used old willingness to pay thresholds to determine if HCC screening was cost effective or not. And with all of these changes in our practice, Dr. Chatwell and his colleagues made new calculations of the cost effectiveness. So he developed a microsimulation model of the natural history of HCC in individuals with HCV and cirrhosis who achieved virological cure with oral direct-acting antivirals and accounted for competing risk post-HCV cure, HCC tumor progression rates, real-world HCC surveillance adherence, and contemporary HCC treatment options and associated costs, as well as the utilities of different health states. So with all of those, they came up with an updated HCC incidence threshold. And you can see that the old HCC incidence threshold was at 1.5 per 100 person years, or 1.5% per year. And that corresponded to an incremental cost effectiveness ratio in terms of dollars per quality adjusted life years of about $50,000 per quality adjusted life year. With the new standard of $100,000 per quality adjusted life year, you can see that the new HCC incidence threshold is 0.4. And what that translates to is that individuals who have HCV with cirrhosis who are treated, although we see some decline in their risk for HCC, that is still above the threshold. And so the general recommendation is that these individuals who have cirrhosis are cured of HCV should continue surveillance for HCC. And this is a probabilistic sensitivity analysis that basically confirms this, that the new HCC incidence threshold remains lower than the current AASLD recommended threshold, irrespective of uncertainty in the model outcomes. So this study is an important update on HCC incidence threshold, above which routine surveillance is cost effective in virologically cured hepatitis C individuals with cirrhosis. So moving on now to HCC surveillance in patients with hepatitis B virus infection, Dr. Grace Wong gave an excellent summary of this during the HBV Global Symposium, which was organized by the Global Outreach and Engagement Committee of AASLD. She reminded us that the surveillance benefit of surveillance programs has been documented in a number of different retrospective studies showing that individuals under surveillance who have their HCC diagnosed have longer survival than individuals who have HCC diagnosed when they are not under surveillance. A novel presentation from Dr. Wong's group was on machine learning models to predict HCC. So there have been a number of models that have been developed, and I'll give a little bit more detail later on in the talk, that have been developed to predict HCC, particularly in individuals with chronic hepatitis B. And Dr. Wong and her group developed an artificial intelligence-based machine learning model to predict HCC and compared this new model with the previously developed models. And what you can see here is that they used a number of different methods to develop the model, and found that the ridge regression model in the second row had the best performance overall. And when they compared this to a number of other scores, you can see the other scores, you can see how that the area under the receiver operating curve was quite a bit higher for this new risk score than for the previous risk scores, including the REACH and the PAGE and REAL risk scores and the CU-HCC score as well. So this potentially could be beneficial in improving the cost effectiveness in HCC screening, because if these risk scores allow us to eliminate individuals who are at exceptionally low risk of HCC, then the resources can be diverted towards those individuals that are at higher risk, and hopefully from an overall population basis, our surveillance efforts can become more cost effective. Another point that Dr. Wong made that's worth remembering is that individuals with chronic hepatitis B virus infection who go on antiviral treatment have reductions in active hepatitis and inflammation, and subsequently reductions in tissue or liver regeneration, and reductions in the baseline AFP elevation. What this does is it makes AFP a more sensitive marker and specific marker also in this group of patients. And instead of the standard cutoff of 20, which achieves a sensitivity of 64% and specificity of 87% overall, we can see that in a cohort that they studied, reducing the cutoff to 6 led to a sensitivity of 81% and a specificity of 80%. So there's potentially some substantial benefit to be gained by reducing the cutoff in individuals who are on therapy. It seems as though AASLD 2021, though, was the year of the biomarker. And what we've learned is that there are many different biomarkers being developed for HCC. One of the biomarkers that Dr. Wong mentioned is based on plasma metallomic profiling. This was actually from a number of years ago, and she mentioned that the technology that was used in this initial study was quite expensive at the time. And she spoke about the hope that these technologies might become less expensive. And as we will see in some of the next few slides, there are actually technologies that look like they will be coming to market with modifications of the epigenetic methylation-based biomarkers incorporated into those models. So next, we'll take a little bit of a detour here into, we're talking about chronic hepatitis B, but into the debate about entecavir versus tenofovir. And we've seen data from Asia primarily suggesting that tenofovir has advantages over entecavir as far as risk of HCC diagnosis while on therapy. And what this is a study from Professor Hashem El-Sarrag and his colleagues at Baylor College of Medicine. And what they did was a retrospective cohort study examining this. And what they found was a trend towards lower HCC risk developing in patients who were treated with TDF compared to entecavir. And you can see here the data suggesting this trend with depending on whether these were unadjusted or adjusted, they just sort of barely reach statistical significance. So additional studies, and in this will also, I think, lead us into some of the other studies as well. Is a study by Dr. Muhammad Ali looking at data from the Mayo Clinic, evaluating factors associated with outcomes of patients with hepatocellular carcinoma who were treated with liver resection. And this was a real-world data analysis. And particularly, Dr. Muhammad Ali investigates the effects of inflammatory markers as well as nutritional markers on long-term outcomes. And the results here are that a higher preoperative lymphocyte monocyte ratio was significantly associated with better overall survival, where lymphocyte monocyte ratios greater than 2.63 versus ratios less than or equal to 2.63 resulted in 1 year overall survival of 93.6 versus 79%, 5 year of 65.7 versus 36.6%, and 10 year of 42.4 versus 21.7%. Similarly, a higher prognostic nutritional index was significantly associated with better overall survival. A nutritional index greater than 42 versus an index of less than or equal to 42 led to 1 year overall survival of 95.3% versus 76.5%, 5 year of 63.7 versus 39%, and 10 year of 43.5 versus 17.9%. And in multivariable analysis, these two, the lymphocyte monocyte ratio and Child-Pugh score were significant prognostic features. These graphs show the effects of both the lymphocyte monocyte ratio and the nutritional index on patient survival. And we can see that this carries through, particularly for overall survival and disease-free survival. For survival after recurrence, there was not a difference in the lymphocyte monocyte ratio graphs, and that's in the upper right graph, but there continued to be a difference for the prognostic nutritional index. So next, a few papers on epidemiology and chemoprevention. So this first study is from Dr. Calizao at the University of Southern California. And it's really interesting. Her group examined lifestyle factors and the association with the risk of hepatocellular carcinoma and whether they were associated with increased risk or benefit. And interestingly enough, they examined smoking status, alcohol consumption, diet quality, coffee drinking, physical activity, and body mass index, and examined the association of these factors with HCC incidence and also calculated population attributable risks for the overall cohort, as well as stratified by race-adjusted BMI. Interestingly, what they found was that these modifying lifestyle factors can have a substantial impact on HCC burden across diverse populations, and coffee intake was the dominant factor in this population, contributing to 44% of risk among lean participants. And so as far as lifestyle is concerned, they make the point that providers should incorporate diet and lifestyle counseling into HCC preventive strategies. And you can see here the data where for people with normal BMI, drinking less than 2 cups of coffee per day was associated with a higher risk of incident HCC. Presumably then the opposite, which is drinking more than 2 cups of coffee per day is 2 cups or more of coffee per day is protective, particularly for those with normal BMI. Next, statins. There's been increasing evidence for the benefits of statins in not only hepatocellular carcinoma, but also cholangiocarcinoma. And this is a study that came from Dr. Beiyao Zhao at Stanford University Medical Center. And they examined the association between statin initiation and risk of HCC among patients with NAFLD. And basically, their study provided strong evidence for the association between statin initiation and reduced risk of HCC development. NAFLD patients who used statins had a 70% reduction in hazard of developing HCC compared to non-users, so a substantial reduction in risk. And this here shows the hazard ratios unadjusted as well as adjusted as well, showing here with the IPTW model 47% or 0.47% hazard. So that's a 53% reduction in risk, even after adjustment and doing the inverse probability weighting. Next, following on in the discussion about NASH, is we see the association between longitudinal changes in markers of liver fibrosis and risk of hepatocellular carcinoma in patients with non-alcoholic fatty liver disease. And this is the question if you do serial monitoring of non-invasive tests for liver fibrosis, can that help with risk stratification? So if you do a fibroscan and you do another scan 3 years later, what happens if the initial fibroscan level is high and then it remains high, versus if it's low and it remains low, or if it's low, it goes to high, or high goes to low. So this is quite interesting. And the basic conclusion is that longitudinal measurements can be a cost-effectively and easily implementable method for risk stratification of these patients, because the reference, of course, is people who are low risk from the first test of cirrhosis, and also low risk when they are tested at 3 years and using the FIB4 test, and that's the reference group. And if individuals are high risk FIB4 at the first test and high risk FIB4 at the second test, their adjusted hazard ratio was 48.6-fold. So you can see a substantial increased risk of HCC if people had high FIB4 risk and maintained this over 3 years. So we'll switch back to the biomarkers. I told you we would have discussions about biomarkers, and one of the biomarker models that gets receiving a lot of use recently is the GALAD, which is a model based on gender, age, AFP-L3, AFP, and DCP or des-gamma carboxyprothrombin, developed by Professor Philip Johnson and his colleagues. And these are 2 phase 3 biomarker studies that were performed in the United States This first one reported by Dr. Jorge Marrero and colleagues in the cohort that's called the HEADS cohort, the hepatocellular carcinoma early detection study. And basically, what they found was that GALAD substantially improved the detection of preclinical HCC 6 and 12 months prior to the actual diagnosis of HCC. You can see 6 months prior to HCC diagnosis, at a fixed specificity of 90%, GALAD had a sensitivity of 50% compared to 35% for AFP, 42% for AFP-L3, and 39% for DCP. 12 months prior to HCC diagnosis, GALAD performed almost equivalently with a 49% sensitivity compared to 29% with AFP, 41% with AFP-L3, and 33% with DCP. The second study, though, that was reported by Professor El Sarag and his colleagues, did not show as good performance. So this was a study that was performed in a similar cohort of individuals receiving 6 monthly surveillance with liver imaging and AFP. And they calculated true positive rates and false positive rates for detecting any HCC or versus early HCC within 6, 12, and 24 months of HCC diagnosis, and compared them with individual biomarkers and the HES scores. And what they found was that GALAD was associated with a considerable improvement in sensitivity for HCC detection, but they also in this study found a considerable increase in false positive results over the individual or combined biomarkers. Therefore, the overall performance of GALAD was reportedly modest and not different from AFP-L3 alone or HES. And you can see where the curves essentially overlie each other when you look at these different biomarkers. So clearly differences, perhaps these relate to underlying differences in the cohorts that are being studied, but something that will need further evaluation and discussion going forward. So moving back to the discussion that we had earlier about new epigenetic methylation-based markers. This is a study that was reported by Dr. Amit Singhal and colleagues, the validation of a multi-target hepatocellular carcinoma blood test showing high sensitivity to detect early-stage disease. This test combines patient-specific information from 3 methylation markers, HOXA1, TSPY-L5, and B3GALT6, the AFP, and patient sex into a logistic regression algorithm to provide a qualitative result for the presence of HCC. And this is a phase 2 case control study. And you can see here the test performance for early stage sensitivity was 82% for the multi-target HB test, HBT, with overall sensitivity of 88% and specificity of 87%. This compares to AFP at a cutoff of 20 nanograms per mil, with sensitivity for early stage of 40, overall sensitivity of 58, and specificity of 100, and GALAD with an early stage sensitivity of 71, overall sensitivity of 81, and specificity of 93%. So more to come on that test. Another test is tissue and blood-based TGF-beta pathway functional biomarkers. And this is a proteomic analysis using the SomaLogic platform. And we can see here evidence for, again, differences between cirrhosis and HCC using this platform. And we're sure that there will be more to come on that new biomarker test. This next study talked about the incidence and clinical characteristics of HCC associated with NAFLD without cirrhosis or advanced liver fibrosis. And they stratified HCC by presence or absence of cirrhosis and by FIB4 index at the time of HCC diagnosis. and clinical characteristics of the HCC patients with and without cirrhosis, and non-cirrhotic NAFLD patients with and without HCC were analyzed. So compared with patients with HCC and cirrhosis or high FIB4, HCC patients without cirrhosis or advanced fibrosis were more likely to be female, more likely to have a history of hyperlipidemia, and more likely to have better liver function test results. And this hints at differences in the underlying NASH HCC biology between individuals who have cirrhosis and then develop HCC versus those who develop HCC without cirrhosis. So more to come on this interesting distinction in patients. And this shows you some of the data from that study. In the interest of time, I'll keep moving. I discussed Dr. Wong's study, the machine learning-based HCC risk score, and this just shows that data, which was presented this year as well. And basically, this HCC risk score developed using a machine learning approach of ridge regression outperforms conventional risk scores to predict HCC in patients with chronic viral hepatitis. And here are the details of this. I showed you this actually earlier in the presentation. A couple of papers that talk about pathogenesis, particularly related to the immune microenvironment, both in cholangiocarcinoma and in HCC. This initial one by Dr. Lollard and Dr. Elias, showing that tumor necrosis factor-related apoptosis inducing ligand or trail fosters myeloid-derived suppressor cell-mediated tumor immune evasion in cholangiocarcinoma. And they were able to show that mice that were negative for trail had a significant reduction in cholangiocarcinoma tumor burden and myeloid-derived suppressor cell infiltration, suggesting that trail functions as an indirect T-cell checkpoint and augments the immune suppressive effects of myeloid-derived suppressor cells. And this just shows that they take these cells, and if they put them in the trail knockout mice, the tumors do not grow as well, and they see more cytotoxic T lymphocytes and fewer myeloid-derived suppressor cells in the tumor microenvironment. Another study here showing markers of response to immune checkpoint therapy here in HCC by Philip Haber and his colleagues. And basically what they did was take 111 samples from patients who received immune checkpoint inhibitor therapy for advanced HCC and use whole genome expression data, mutational analysis of the beta-catenin exon 3 and histological evaluation to try to identify signatures of response to immune checkpoint therapy. And to be brief, what they found was that interferon signaling and MHC2 related genes were key molecular features of HCCs that respond to anti-PD-1 therapy. And so this needs validation, but is really interesting because it could point to how to select individuals that are most likely to respond to these newer therapies. Finally, Dr. Renu Dhanasekaran and colleagues did a study. We know now that the combination of immunotherapy against PD-L1 and CTLA-4 appears promising against advanced HCC, and they used a transgenic mouse model of MYC-driven HCC to examine this combination using high-dimensional mass cytometry or CyTOF to compare the immune responses. And in conclusion, they found that dual blockade of PD-L1 and CTLA-4 led to delayed tumor progression in an immunocompetent mouse model of aggressive HCCs. There was a distinct impact on the myeloid population with repolarization to a tumoricidal phenotype with increased expression of the ligands CD40 and MHC2, which play crucial roles in antigen presentation and activation of T cells. So these findings provide novel mechanistic insights on how the combination immunotherapy remodels the HCC microenvironment. So thanks very much. I hope this has been a good walk through the highlights of the Liver Meeting DX from 2021, and hope we can have a good discussion in the discussion time. Thanks very much.
Thank you. Exciting data indeed. And now may I invite the panelists to give their views, their comments, and on this very interesting data.
Is Dr. Robert available for questions?
Yes, I'm here.
Yeah. Thank you, Dr. Robert, for excellent presentation. Very few quick points. In Indian scenario, if alpha fetoprotein is 6 or say 7, would it warrant doing a CT angiography? Because 99% of the times our ultrasonologists will not pick up an early HCC. Would you say if alpha fetoprotein of 7, especially in a man who is having replicating virus, say raised OTPT, is a good enough indication for to go in for CT angio, which is a costly proposition?
I think it really depends on whether that person is on, if it's, for example, someone with chronic hepatitis B, they have to be on therapy. Because I think that what the message is that once people are on therapy, or if they have chronic hepatitis C, they have achieved sustained virological response, then the regeneration that leads to false positive elevations in AFP is substantially reduced, and you can reduce the threshold. But if you have a patient that is not on therapy for HBV or has active HCV, then the threshold should probably remain at 20 to maintain specificity.
And secondly, your comments on TDF versus entecavir in reduction of HCC, would that also be applicable to TAF, which we are using more often than TDF? Would a 25 milligram dose be equally effective in reduction?
I think that will be the presumption, even though we don't, we've had TDF for much longer, so we've had the opportunity to follow cohorts of patients on TDF. We don't have as much data that's long-term with TAF. But I think particularly in the data that's come out of Asia also suggests that, there's this benefit of the, tenofovir-based regimens over entecavir. It's in some cases, like in the US cohort, it seems like it just barely reaches significance, but overall it appears to be that the benefit favors the TDF or TAF-based regimens.
And finally, the relationship between the coffee and say HCC or chronic liver disease, is there a distinction between say warmer countries or temperate countries and the countries which have very low temperatures? Across the board, is there a difference between say temperate countries like India? Nobody will drink 3 coffees a day.
That's a great question, and I don't think we know. And I think really the onus is on our epidemiologists and hepatologists to do the studies in different countries. I think, though, that it's almost like wherever the study has been done so far, coffee has proven to be beneficial. And so I think we really do need to study it. And, India, I have the same question about Africa, about whether, we will see the same sort of benefits there. But it's definitely something worth considering, is because the effects are not small. The effects are actually quite significant on a population basis.
I think Parimal may have a question.
I had a question regarding hepatocellular carcinoma in people who have been treated for hepatitis C. So if you look at hepatitis B, you have the virus which is integrated into the DNA, host DNA. While here you have a virus which has disappeared from the cells. And what do you feel could be the plausible mechanism why these people still continue to have the risk of it? Because all of them may not really be cirrhotics in the true sense. So what do you feel could be the mechanism why these people are still at risk for hepatocellular carcinoma? Post-treatment HCV.
That's a great question. I think I think one of the things we're learning is, and you made the point about cirrhosis. I think one of the things we're learning is that the risk is limited, or it seems to be primarily limited to people who had cirrhosis at the time of cure, because I think that those individuals without cirrhosis seem to have a lower risk. But when people have, by the time they've reached cirrhosis, it appears that, the cirrhosis occurs in the context of inflammation. That inflammation usually is associated with the generation of reactive oxygen species that damage DNA. So the inflammatory milieu actually causes mutations in the DNA of the liver cells in these patients. And our presumption is that even then, after you cure this, you cure HCV, that changes that have already occurred before cure are responsible for the continued additional risk for potential progression to HCC. So we know the risk drops, but it still is high enough that we should continue surveillance.
Thank you.
Thank you, Dr. Lewis. And we are behind time, so I think we have to wind up the session. Thank you, Dr. Parimal. Thank you, Dr. Anil, for being with us. We move on to the last session of the day, which is actually on autoimmune hepatitis by Dr. Gideon Hirschfield. So for this, I invite the moderators, Dr. Shaukat Zargar, Dr. Ajay Kumar and Dr. Shravan Kumar. Dr. Zargar is from KIMS, Srinagar, as KIMS. Dr. Ajay Kumar is the chairman of BLK Hospital, the GI department, and a good friend, senior to me by a year. And Dr. Shravan Kumar, of course, HOD Gastro at the Gandhiji Hospital. And let us hear on this very interesting and sometimes confusing topic of autoimmune hepatitis from Dr. Hirschfield.
Hello, my name is Gideon Hirschfield. I am a hepatologist based at the University of Toronto, and it's a great pleasure to be talking to you today, unfortunately by Zoom, to your important update on hot topics from AASLD 2021. The title of my session is Autoimmune Liver Diseases. I'll do my best to give you some insights into some of the things that I found interesting, particularly around autoimmune hepatitis, and a few little things that also popped up for PBC and PSC, recognizing that there will be another session on cholestatic liver diseases as well. These are my disclosures. So I think it's really important when we talk about autoimmune liver disease to see these as a family of diseases. We clearly don't know the causes of autoimmune liver disease, but we see three clusters: primary biliary cholangitis, AMA positive patients, small bile duct lymphocytic cholangitis with elevated IgM. These patients are treated successfully with ursodeoxycholic acid, obeticholic acid, and there are a number of drugs in development and use from the PPAR pathway. In contrast, primary sclerosing cholangitis is another autoimmune bile duct disease, but it's medium to large bile ducts with common association with inflammatory bowel disease and a particular problem with cancer of the colon and the bile ducts. This, of course, is a devastating disease with very few treatments. Nestling in the middle is autoimmune hepatitis, a syndrome really of steroid-responsive interface hepatitis with autoantibody positivity, with very effective treatment, but very non-specific treatment. For none of these diseases do we actually know the exact etiology, and this causes some challenges in our management. Focusing on autoimmune hepatitis as an exemplar of this, what we see is that there are many, many factors behind a clinical presentation in a patient. So in autoimmune hepatitis as a paradigm, we see that there are genetic factors, changes in tolerance, environmental factors, risk factors which are individual, exposures to drugs, and the potential importance of infectious agents. I could have updated the slide to include a bullet point for COVID, of course. And this leads to the syndrome of loss of immune tolerance and inflammation. I show you this slide because this will be actually for a future ASLD. This is really important data that's coming out of our group. Christina Plagianakis, one of our MSc students, looking at our patients with autoimmune hepatitis in Toronto and in Edmonton with Aldo Montano Lazo. Now, with over 500 patients, what we've done is look at what is important for determining the outcome of our patients. You see at the top left, cirrhosis is clearly important. You see on the right, a time-varying Cox-dependent regression model showing you the importance of age, sex, baseline bilirubin, cirrhosis, and how long after diagnosis the ALT remains abnormal. And then this is really then shown much more clearly at the bottom, and it highlights a very important practice point, that in general, the goal of your treatments in autoimmune liver disease, autoimmune hepatitis, here is the example, is to normalize liver tests. And in the case of AIH, is to try and ensure that your patient's ALT, particularly if their cirrhotic presentation, is normal. So these are the kind of data that still come out of cohort studies and which are very commonly presented at meetings like AASLD. So this is again is the 4 clusters of autoimmunity that we look after in our clinics with autoimmune liver disease: PBC, autoimmune hepatitis, PSC, and of course the unusual, probably more immunoallergic condition, IgG4 sclerosing cholangitis. Genome is important, risk factors, epigenome, the exposome, what is around us. And this is important to remember because maybe that's why autoimmune liver disease, autoimmune hepatitis might look different in different parts of the world. And again, similarly, the microbiome. So some themes that I want to explore with you from the conference are, where are the technologies going in these diseases? And theme number 1, I'd like to just talk to you about an important presentation from UCL in London, AASLD, using UK PBC data, looking in PBC, was proteomics. So, proteomics, the study of proteins and all proteins, has clearly become very important. And this was looking at proteomics essentially of treatment response in PBC. Who does well and who does badly? How do we go beyond alkaline phosphatase? So, what you were seeing is that there were different proteomic fingerprints. And I'm not going to give you the exact data because it's probably not that important. And all these studies need to be validated and need to be very careful of initial presentations until we have large-scale studies. But in the study, they were finding differences in stress response, differences in immune damage, difference in lipid transport in non-responders. So there were distinct proteomic fingerprints between those responding to URSO and those who don't respond. Okay, non-responders had higher levels of SICAM1, PIGR, and ApoE. Okay, and these become new markers of treatment response. So proteomics is an important theme that at AASLD was being explored in autoimmune liver disease, autoimmune hepatitis, and beyond. This was then a study that looked at essentially metabolomics in the etiology of itch. Itch is something that's important in AIH as well as PBC and PSC, but it's particularly prevalent in cholestasis. And as you know, we don't actually have the exact etiology of itch for most of our patients. Is it through TGR5? Is it through lysophosphatidic acid and autotaxin? Is it neurological? And this study from the US found a distinct serum and skin metabolome in PBC patients who were itchy. Okay, and this was linked possibly to disordered lipid metabolism pathways. So again, this is exemplary from AASLD of the kind of studies, proteomic and metabolomic studies, to discover new biomarkers of relevance for management in our clinics. In the same session, a very important oral session at AASLD, was a very nice study from Germany, from Freiburg, looking at immune checkpoint inhibitor hepatitis and autoimmune hepatitis histologically, and using very advanced immunohistochemistry technologies to look at the cell infiltrates in the checkpoint inhibitor hepatitis and in classical autoimmune hepatitis. And this is just a very simple picture that summarizes a very complex study, showing you that very important as you look at these patients, when you see them, and you'll see them a lot more, is that checkpoint inhibitor hepatitis is not the same as autoimmune hepatitis. There is a different set of T cell infiltration. And there's higher immune cell count in autoimmune hepatitis, but the checkpoint inhibitor has more CD8 T positive C cells. So when they were looking, they were able to use very, very novel technologies at using human liver tissues to cluster the difference between a checkpoint inhibitor hepatitis and an autoimmune hepatitis. And in essence, what they're finding is different patterns of immune cell infiltration. So for example, more exhaustion and tissue residency features in autoimmune hepatitis. So I found this particularly interesting abstract because it came up with some key takeaways from this German group, where the checkpoint hepatitis was proliferative cytotoxic CD8 positive T cells, which correlated with ALT. The AIH was tissue resident memory CD8 T cells correlating with ALT and more T cell exhaustion. So really quite clearly two very distinct diseases, and that's really important in clinical practice. We treat checkpoint inhibitor with very, very high dose and very short-term steroids. We use a very different paradigm of treatment in AIH, and we also in AIH are much more interested in tackling the B cells in our treatment paradigms. And that dovetails nicely to an important poster where a group from Switzerland and Finland have taken liver histology from patients with autoimmune hepatitis and used the usual classical pathway of a training set and a validation set to use deep learning to start to learn how you could automate the analysis of a liver biopsy. Again, I don't really think that the exact findings of the study are the most important point. What I think is more important is that is the methodology. So we're moving to the point where methodologically we can look at liver histology differently. And that means that we can automate to some extent and maybe standardize. And by standardization, we may be able to measure and quantify what's going on in the liver in a different way. So this is just an example of an algorithm that is predicting autoimmune hepatitis histology. And I just found this very important because I think there's going to be a lot more of this kind of technology in the future. Okay, I mentioned that, autoimmune hepatitis is a disease of genes and a disease of environment. And we've always known that there are different prevalences of autoimmune hepatitis across the world and that they sometimes present in different ways. This was a nice study that I saw for autoimmune hepatitis from Anchorage, where they were looking at some of the features of autoimmune hepatitis in a very defined cohort in Alaskan Native individuals. What do you see in the study, which is interesting, I think we'll show you a little bit more in another poster from India, is number one, this disease is presenting mainly in patients in their 50s, okay? This disease is not necessarily perfect to treat. Not everyone presents the same. And, there is not everyone getting a full treatment response. So, and the incidence and prevalence is very high in this population, suggesting that there may be different environmental triggers around the world, which is why we see different patterns depending on where we work. So in this example, Alaskan Native individuals had high rates of autoimmune hepatitis, and they weren't managed as well, and they had significant complications. So you can see that we can still learn about what we think is a classical disease with classical treatment by having an open mind and looking in different populations. If we flip from that side of, Alaska, and we move to a different part of the US and the rest of the world is facing a very significant burden of obesity. You'll know that there's been a lot of studies at AASLD on NAFLD, NASH. Now, this was a study where we looked at impact of disease-related attributes of quality of life in a North American cohort, lead author Craig Lammert, and they're looking at quality of life surveys. Now, you shouldn't really use the PBC-40, of course, in autoimmune hepatitis. It wasn't designed for that. But what they demonstrated was a reduction in quality of life. But additionally, they saw that that patients who had elevated BMIs, that was a significant predictor of health-related quality of life in pre-transplant patients with autoimmune hepatitis. So this is definitely something for the future in our patients as we see rising BMIs globally and the impact not just of NAFLD on liver outcomes, but quality of life as well. Now, this was a study from Professor Sarin, the first author, Varadarajan. Okay, again, I think I found this very interesting because it's a very large study, okay, with a lot of patients and a lot of liver biopsies to review. And this was just trying to show you, I guess, the prevalence of disease and this concept of what is overlap. And do we even know how to define what overlap is? And are the historic definitions that are used often usable? Are they correct? Now, I would point out that I'm not sure I know how to define overlap, and that I think is a problem. And certainly you can't define overlap based on histology. That would be a misunderstanding of a very complex evaluation of a spectrum of presentation of liver disease and liver inflammations. But in this very large cohort from India, PBC was around 16.9%. The biliary features were very important, and they found around 10% of their patients had what could be overlap syndrome. But they found that the IgG is not really necessarily the best cutoff, at least if you use the definitions and approaches of these authors. So this was another example of how important it is that we look at different parts of the world and we learn from more than just one methodology of ascertaining what is an autoimmune liver disease. So that sort of really highlights a lot of the, particularly the AIH updates, I think, from AASLD. There weren't very many therapeutic advances, unfortunately. Many of that data, we believe, will be presented in years to come at other conferences. But, linking that from overlap into PBC, I wanted to highlight a few things about PBC and PSC, which I think are important, because I think they also set the paradigm for future understandings of autoimmune hepatitis. Really, for PBC, I think it's important to realize that in this autoimmune biliary disease, we're very focused on a goal-driven care. We want to prevent end-stage liver disease and treat symptoms. And obeticholic acid is the first new therapy licensed for PBC. And we're assembling real-world data, where the real-world data has evidence of improvement in cholestatic markers, just like the phase 3 clinical trial, the POISE clinical trial. Okay, but people want to know whether obeticholic acid makes people live longer. This is very difficult because the original phase 3 clinical trial, it was not possible to maintain a placebo-controlled component of it. And so there's 1 year placebo-controlled data and then 5 or 6 years of long-term safety. So this late breaker from Fiorella Marilla Perez in the late breaker at AASLD this year looked at patients from the clinical trial who then had long-term extension with obeticholic acid and compared that to real-world data from 2 large PBC cohorts. So I highlight this as an important methodological advance in how we prove, and we'll need to do this for all autoimmune liver diseases, how we prove the new therapies that we see in clinic are changing the outcomes. So what we did was see what happened in POISE over 5 years and have events. And we have to date the liver transplant on death, and we're trying to accrue information from the sponsor on decompensating events, and then create a synthetic control group from the global PBC study group of real-world data, historic real-world data, and a control group from UK PBC, a group of patients with PBC from across the United Kingdom. And you're trying to match these populations on sex, age, duration of PBC, treatment, FOS, bilirubin, liver enzymes, and use logistic regression and other statistical tests, inverse probability of treatment weights, to create so-called synthetic controls. And that allows you to recreate what could be considered the placebo group. Of course, it isn't the true placebo group. We know that. We know that clinical trials are not the same as real world. That is a clear fact. But it's an effort to try and get data when there is no possibility in a long-term rare disease to do the kind of controlled studies we'd like. And in fact, if you look at the history of URSO, at 5 rates in PBC, this methodology has been applied in principle. So we have a selection of patients treated with OCA and a control group. And then we're trying to basically compare the outcomes. And in 2 cohorts, the global PBC cohort and in the UK PBC cohort, what was important was that we saw similar outcomes for the synthetic controls and better outcomes for the POISE clinical trial cohort. Now, this is clearly just the start. This is provisional data, but we demonstrated as an example that we could see a new treatment improving the outcome of patients with PBC, and we refined the methodology, and there's more refinement ongoing to get different endpoints and different ways of matching those patients to try and make them look as similar to a trial cohort as possible. But, we had clearly lower risks of events by univariate, multivariate, and weighted Cox analysis for obeticholic acid in both of the PBC real-world data sets. So very exciting that we can do this, that we can work together prove new therapies. Because to prove, not just by placebo-controlled studies, but by real-world studies, that new drugs such as seladelpar, glitazar, elafibranor will have an impact on the outcome, as has been done for some data from Japan, for example, I think shown at maybe one or two of the previous AASLDs for bezafibrate. So one study to highlight was presented by Professor Mayo from the US, seladelpar in PCA agonist, effects on bile acids and metabolic long-term use of this drug. So giving long-term safety and efficacy of a novel by Zoom. And I was presenting the study by Professor Mayo about the seladelpar in treatments with PBC as an example, again, of the progress being made in PBC and diseases like PBC we hope to see in the future. Inadequate responders to UDCA, elevated alkaline phosphatase, long-term use of seladelpar up to 2 years, open label experience. And what do we see? Professor Mayo shows us a significant drop in ALK phos, both by percentage and numerically, and that this effect was profound and persistent. So a drug that's having an anticholestatic effect on biochemistry. And then when you look at a composite endpoint, the endpoint that was used for obeticholic acid, a surrogate of treatment response and treatment benefit, you can see significant improvements for the patients. Nearly 80% of patients are hitting a composite endpoint, and nearly 42% or more are normalizing the alkaline phosphatase. So this is, going beyond urso, beyond obeticholic acid, going into delpars and other fibrates. This is the future, we believe, for PBC. So there was a safe and well-tolerated new drug. There were improvements in biochemical cholestasis and hepatocellular injury, and a significant number of patients were responding. So this is one of the number of phase 3 clinical trials now for new therapies for PBC, which are being launched across the world. Finally, I just want to touch upon PSC, which of course can overlap with autoimmune hepatitis, and which is a devastating inflammatory stricturing cholangiopathy. This is what it looks like inside the bile duct. It looks like a very inflamed bile duct, a bit like a Crohn's disease of the bile duct. It's a disease with 6 C's: covert, it has cholangitis, it has colitis. The consequence is cirrhosis, and the fear is cancer. And the patients need, deserve, want a cure. And we're looking at similar therapies that we've been used in PBC and in fact in NASH, around bile acids, the microbiome, immunomodulation, and we're struggling to get the right biomarkers. But again, I want to show you some work in preparation from our program in Toronto, which will come up, I guess, in EASL 2022, demonstrating that we're learning how to stratify our patients into who's going to run into problems and who has a so-called flat course. Because maybe what we need is drugs that can move patients from the blue group in these slides to the pink group. So this is a reverse timed analysis. So the starting point is the event, transplant or death. The patients are 580 patients who come to our PSC clinic in Toronto, and you can see the differences in behavior of alkaline phosphatase longitudinally. Stays elevated for the patients who do badly. Bilirubin, it starts to really significantly climb a couple of years before the event. Albumin starts to drop 6-7 years before the event. And FibroScan starts to progressively go up around 4 to 5 years before the event. And the patients with a stable flat FibroScan are in the group of patients who do well. And this is what we have to move to as we get new therapies for PSC, to see whether we can move patients from a cluster that the blue group to a cluster that is the pink group. And obeticholic acid was tried, previously presented at these meetings, and this is with the data for obeticholic acid in PSC, a small change in ALK phos, but really there was not sufficient at this time for the obeticholic acid because of pruritus. But Gilead have got a clinical trial of their FXR agonist, which is cilofexor, and this was the phase 2 data, which was originally presented in 2018 at AASLD, showing what happens to ALK phos on and off urso for patients with PSC with the synthetic non-steroidal FXR agonist. And at AASLD 2021, Professor Trauner showed you what happened over 96 weeks. And it was very interesting to see that this very, very potent FXR agonist, which has been developed for inflammatory liver disease, there's only a very small drop in ALK phos over 96 weeks in the open label extension, cilofexor and improvements in liver enzymes. And the ELF score, a measure of liver fibrosis, was stable over 96 weeks in this phase 2 study. So you can see how hard it is to develop new drugs for PSC. And this drug is currently in phase 3, where the endpoint is liver biopsy and liver tests. So we're going to have to work very hard to get to the final conclusion as to how to develop new drugs for our patients. And this, I just wanted to then highlight what we're doing with a drug called berberine, a drug that's already used, I think, quite a lot in India, which has got ursodeoxycholic acid linked and berberine together. This is the high-tide drug. And this was looking at what happens to patients with PSC who received this drug, but who hadn't had ursodeoxycholic acid before. It's a subgroup analysis of a small, short study of HTD 1801 to see what the effects are when there was no urso on board. And we're able to show that this interesting molecule, when you take it, which is equimolar for urso and berberine, and therefore the berberine brings extra anti-inflammatory, anti-cholestatic and metabolic effects, that you do see an improvement in alkaline phosphatase with HTD 1801. So although alkaline phosphatase is clearly not a perfect biomarker in PSC, we have another approach to considering the treatment of PSC, and we look forward to further clinical trials. So with that, apologies for the technical problem in the middle where they've sewed together the talk. I hope you have a fantastic meeting in India. I hope that I've given you some of the insights around autoimmune hepatitis and a few little tidbits around PBC and PSC, and that you can start to see where the field is currently at and where the field is going to go. Many thanks.
So now can we have some comments from the panel on this very interesting and the concluding topic of the day?
Well, I think it was a very well reviewed topic, quite exciting developments taking place. The newer drugs appearing in the autoimmune disorders as so is in the PSC. Just like to ask that this new mechanism of itching, do you foresee any developments for a new focus for the medicines to develop that? You talked about it as related to some lipid metabolism, the new mechanism of itching this described. So do you think you're looking at a new mechanism for the medicine to act like a new site for the medicine to do?
Well, first of all, thank you very much for asking me to speak today, and congratulations on a great meeting to all organizers. I think itch is a very difficult area, as you know. I think there are lots of hypotheses. I really wanted to highlight the methodologies that were being used, the proteomics and the metabolomics. I'm a little bit nervous to over-extrapolate early data because I think we all know from the history of these abstracts that things have to be replicated and validated, and it takes a long time. The way I do think that itch really is an issue is I think of it as a neuropathy. I think of it as a small nerve fiber neuropathy where the nerve fibers are being irritated in the skin by chemicals that could be lipid-based. I think we've seen in cholestatic liver disease that drugs like the ASBT inhibitors can be effective antipruritic drugs. So I think that something within the bile is relevant, and it may be a downstream effector, which then goes to a lipid pathway. But certainly there's evidence from pediatric programs now, and you'll know that in the US, 2 ASBT inhibitors are licensed for very rare pediatric liver diseases, for Alagilles and for PFIC. And they're both apical sodium bile acid transporter inhibitors, so they stop the recirculation of bile acids. In adults, there's some phase 2 data for these drugs in PBC and a phase 3 trials ongoing. There have been some other suggestions for drugs around itch, not necessarily focused on the data I showed you, but around G protein coupled receptor inhibitors, as there's been work to understand, are there receptors for bilirubin, for example? And so broadly speaking, yes, there is the opportunity. I would just caveat all of that by saying that clinical trials in itch are notoriously hard. I'm not sure what your practice looks like. We find itch to be a very variable symptom, probably more stable in PBC than it is in PSC. But even in PBC, you get patients who are itchy, then suddenly they're not itchy. And the minute you subject patients like that to a placebo-controlled study, which is what you want, you really, it's quite challenging to detect differences, even when you're sure a drug is effective because of natural variation. So, I think it's exciting. I think the methodology is the thing that excites me the most. Really, I think you have to watch this space.
Thank you, Dr. Hirschfeld. So I think there are no more questions from the panel. Ajay, is that right?
Oh yes, I think everybody's in India at least is getting at the sleeping time.
And thank you for being with us on this Saturday. And I'll have closing remarks from Dr. Sareen. Please, those who are in the audience, don't forget to leave your feedback so that we can improve in our coming meetings. So it's a request. And again, a reminder for all of you to join us tomorrow at 8 o'clock for yet another exciting half a day of hot topics. Concluding remarks by Sareen, sir.
Thank you, Vinay, and thank you, Gideon. This is close to 10 p.m. in the night in India. And I am happy to say that we are still 900 plus connected people. And it remained 850 throughout and now 900 plus. So it is a tribute to all the speakers and the hard work they have done to put up. And it looks like we are actually in AASLD, the way we have seen. And thank you, Vinay, for your whole day stewardship and keeping timings. With that, thank you and hope to see you sharp at 8 tomorrow. Thank you all. Good night.
Good night.